from BP Gastro Center and Hospital, Coimbatore. So it's my pleasure to welcome you all for this live webcast of endotherapy in obesity and GERD. So welcome to all. Hi friends, good morning. Welcome to Coimbatore, Australia. So it's called the Manchester of Coimbatore. So today we have a very beautiful workshop that is going to happen on studies from our BEM hospital at Coimbatore in Tamil Nadu in South India. Good morning, friends. So I'm Dr. V.G. Mohan Prasad, you know, greeting you from Coimbatore, which is the Manchester of South India. So welcome to this endobariatrics and endotherapy of GERD workshop. So this is of paramount importance today globally, and I'll just show you some evidence why it is important. So what is the need of endotherapy in GERD? So if you look at the stratification of GERD patients, it is done based on severity of symptoms, recognizing those with atypical symptoms, recognizing those with the possibility of developing complications. So not all GERD is benign. So there could be a lot of problems associated in the form of mild, moderate, or severe, how severe the reflux is, and also those with atypical symptoms. So how do those people present, like right from bronchial asthma to Singer's nodule to laryngeal carcinoma, all those complications could arise and the Barrett's complications could arise. So recognizing those people with the possibility of developing complications is of paramount importance. So we need to stratify GERD patients based on severity of symptoms, the inconveniencing, the distressing, and disrupting. The disruptive GERD is 1/3 of all GERD population. There is a higher prevalence of severe and frequent reflux symptoms, sleep disturbances, and future complications like developing ulcers, strictures, or Barrett's adenocarcinoma. So if you look at the systematic review, the burden of disruptive GERD in uh, reflux disease on health related quality of life. There's a beautiful article which appeared in 2012, which showed that the quality of life suffers in these people with disruptive GERD because they have a lot of difficulty. Even sleeping is a problem for them. So now we move on to endotherapy of obesity. Why do you need endotherapy in obesity? Right. Now, today, so there is a global pandemic of obesity, and non-alcoholic fatty liver disease is an integral part of, this problem. So we are really worried about the, the fatty liver progressing, and this creates trouble. So if you see the prevalence of, non-alcoholic fatty liver disease is increasing around the world. And today it is numero uno in the cause of cirrhosis, even more than alcohol or hepatitis B or C. So there are a lot of people with a higher risk for developing fatty liver disease. One such is the obesity metabolic syndrome combo, which goes hand in hand with type 2 diabetes and with increasing age. So 25% of global population of non-alcoholic fatty liver disease, 33% of Indian population have obesity in some form or the other. So the disease burden of NASH is increasing over time. So it's going to really cost us a lot of money tackling these patients globally. So, and again, in type 2 diabetes, so it is tremendously increasing, exponentially increasing complications of fatty liver and thereof. So this is the reason why we thought we'll put up a workshop for this GERD and obesity, and we have great stalwarts here today, and we have on the screen with us Dr. Barham Abu Daya from Mayo Clinic, who's been kind enough to deliver his talk today on endobariatrics, the state of the art. So it's a pleasure. Now we have Dr. Cadman, who's also joining us from Mayo. Dr. Prasad Iyer will be demonstrating from BGM, and also we have Dr. Saransh Jain, who will also be with us at BGM for live demos. So, my friends, we are in for a feast of procedures that we're going to show how to augment the sphincter, how to treat gastroesophageal reflux disease, including Barrett's, and again we're going to demonstrate the Allurion balloon in the afternoon session, and also we're going to show endoscopic sleeve gastroplasty, which is now the state of the art when compared to even the laparoscopic sleeve gastrectomies. With this, I have a great pleasure in inviting all of you for this workshop, and may I request Dr. Professor Barham Abu Daya from Mayo Clinic to deliver his talk. Thank you.
Thank you, Dr. Prasad. Can you hear me okay?
Yeah, it's perfect, sir. You can proceed.
All right, I'm going to pull my presentation. Can you see my slides?
Yeah, very well, sir.
All right. Well, good afternoon, colleagues. It's always a pleasure to interact with my colleagues in India, and thank you for the kind invitation. Over the next 20 minutes or so, I'm going to talk about endobariatrics, so endoscopic bariatric and metabolic therapies, with the focus on the state of the art, where we are and where we're going to go in the near future. I'm from the Mayo Clinic in Rochester, Minnesota. I'm professor of medicine and director of advanced therapeutic endoscopy. These are my disclosures. So in 1902, one of the fathers of endoscopy, Dr. Chevalier Jackson, who is an ENT surgeon, wrote commending the advent of endoscopy in his famous book, Bronchoscopy and Esophageoscopy, that no longer will patient be cut open to see what the matter is, and if it's proposed to pass an instrument through the mouth, consent will rarely be refused. And here he was alluding to the fact that a natural orifice procedure that preserves the anatomy is going to be a way that's going to propel surgery and endoscopy in order to have the concept of anatomy preservation. I think in 2022, his vision came true, and now endoscopy is responding to the biggest pandemic or that known to mankind, which is obesity and associated metabolic diseases, afflicting almost a third of the world population and contributing to many deaths and morbidity. The problem thus far in our field is there has been a true treatment gap. That treatment gap polarized the field into either invasive, anatomy-altering bariatric procedures or minimally invasive lifestyle intervention. And most of the patients are not currently getting an effective treatment for this disease because of this polarizing spectrum of care. As to any field that have bridged that spectrum of care, for example, cardiovascular medicine, we're seeing this revolution of minimally invasive, whether endoscopic or laparoscopic intervention, that all targeting to replicate the benefits of bariatric surgery while preserving the anatomy. And that is truly the value proposition of bariatric and metabolic endoscopy. Patients want organ sparing. Patients also want safe and effective intervention with some durability to it. They do not want to have any long-term consequences to health. So that means they don't want treatment with one modality to cause problems with another. And they want minimally disruptive modality with their lifestyle. And I think the field of endoscopic bariatric and metabolic therapy has responded to all of these. And therefore, we're witnessing this expansion of offering that now hopefully will increase access to effective therapeutics. So hopefully the spectrum is evolving to be looking something like this, where you enter the spectrum of care based on the severity of your disease. and you're always in treatment, so you only graduate from one treatment to another, rather than saying that there's one treatment that's going to fix the problem of excess adiposity, which we do not have. So what is good enough weight loss? There's a lot of misconception about what's good enough weight loss, but from the state-of-the-art evidence, it seems like if you could get the patient to lose more than 10% total body weight loss and maintain that weight loss with whatever modality, you're going to have good metabolic outcomes. And this study published in the New England Journal of Medicine showed that they allocated patients to either gastric bypass or to a very low caloric diet, almost a restrictive boot camp type of diet. And both groups lost 18% total body weight loss. That means that they equalized the weight loss. Then they looked at gold standard measure of insulin resistance using hyperinsulinemic euglycemic pancreatic clamp. And as you could see, there was identical improvement in insulin resistance with that degree of weight loss. No difference between a gastric bypass or 18% total body weight loss with severely restrictive diet. When they looked at 24 hours glucose profile, same difference. 24 hours insulin profile, same difference. Beta cell function, same difference. And body composition as far as visceral fat, same difference, which tells us that if we have endoscopic modalities to produce this 18% total body weight loss, or at least more than 10%, and keep it for a period of time that extends anywhere between 2 to 3 years, we expect significant improvement in metabolic disease that comes with excess adiposity. With that in mind, now we're pushing the envelope. We're pushing the envelope as far as efficacy. We're pushing the envelope as far as durability. And therefore, my talk is going to be focusing on the state of the art. Where are we going? And the first theme here is improvement in technique and physiological understanding to develop better procedures. What do I mean by that? We've tried for decades now to alter the stomach for weight loss, doing multiple things on the stomach. But we evolved after understanding or studying the physiology to understand that if we want to remodel the stomach endoscopically, we want to get this shape, which is the shape of a funnel with a small pouch in the fundus that accommodates to affect the process of satiation, where how much do you eat in a particular meal. And then we need a shortened and tubularized greater curvature that delays the emptying of that pouch in order to enhance satiety, which is how long do you go before you pursue your next meal. So this funnel shape is the critical shape. How do you get there is less important as long as you get a shortened funnel shape stomach. And I will show you how we're evolving even this understanding of this endoscopic sleeve gastroplasty. Now this is state of the art. There is a robust body of evidence from hundreds of trials. And there is the landmark study that was published in The Lancet, which is the multi-center randomized trial that shows the efficacy, durability, and impact on comorbidities with the procedure of endoscopic sleeve gastroplasty. Based on the body of the evidence, the FDA did issue almost an unprecedented approval of a procedure, not device. So they approved the endoscopic sleeve gastroplasty for patients with obesity and body mass index between 30 to 50 in the United States. So again, this is a build-up from first when the procedure was described in 2013 at the Mayo Clinic, and then the global adaptation of this procedure, culminating in the MERIT trial, and then now the procedure is approved and the procedure has gained wide-scale adoption. And because why people adopt this procedure, not because it would last forever, they adopt this procedure because patients want it. They want to save their stomach in the process. It does produce significant weight loss, not the same as bariatric surgery, nonetheless significant, equivalent to the weight loss that will get significant metabolic benefit. As you can see, 17% at 1 year, and that weight loss is durable at least in the midterm, which is 2 years, and these are the component of an acceptable endoscopic procedure for obesity and metabolic disease. Now, a similar procedure that's being developed, which is the POST 2.0, we reported on this multi-center feasibility study between Mayo and 2 centers in Spain. This was an FDA study as well. And we could see that with the POST 2.0, we're using these tissue anchors to create an endoscopic sleeve gastroplasty. Unlike the Apollo version, which is with sutures, we're using these plications with the hypothesis that these plications are more durable. So now the durability could be even extended further with using such a platform as the POST 2.0 that was demonstrated in this video. And this study published in CGH have proven that when we looked at the configuration at 2 years, every single plication has been intact with this procedure. Therefore, I think it's a procedure that will continue to evolve. But right now, it's in clinical trials in the United States for FDA approval. Now, when I told you where are we going with this? Going with this is now we have better understanding of this physiology. We published this paper in Gut where we used MRI imaging, special sequence MRIs with 3 Tesla machines in order to understand the impact of endoscopic sleeve gastroplasty on accommodation and emptying of the stomach. These are the processes that regulate satiety and satiation, which is key for weight loss and metabolic improvement. And you could see in panel A, this is the stomach on MRI, segmented MRI for the procedure. This is the stomach 3 months after the procedure, and this is the stomach 12 months after the procedure. And what you're seeing a shortened, tubularized stomach. But more importantly, if you look at the fundus accommodation, this is after ingestion of a meal in the MRI, this is a special contrast labeled meal. You could see that after the meal before, the fundus is flattened. Now the small pouch in the fundus after a meal now accommodates much quicker and communicate these vagal afferent signaling in order to terminate that meal early. So that's one of the principles of endoscopic sleeve gastroplasty. The second principle, which now is going to even help us push the efficacy even more, is when you look on the x-axis at the changes of gastric emptying and the association of these changes in gastric emptying with the 12 months total body weight loss, you could see a strong correlation with R-squared coefficient of almost 0.5. That means that the more you delay the gastric emptying, the more the weight loss that you expect to observe at 12 months. So the question is, why does endoscopic sleeve gastroplasty delay gastric emptying? And the hypothesis is it eliminating the contractility of the stomach, and in which case we have gastroparesis, which is not a good thing? Or is the stomach still contracting, but the contractions are weaker, or the contractions are less frequent? And we went out to answer that question, and the answer that we found helped us even modify the endoscopic sleeve gastroplasty for even more weight loss. And this is now published in Gut in 2022. So this is the dynamic MRI that we used. And again, to answer the question, why does endoscopic sleeve gastroplasty delay gastric emptying? We were very surprised with the answer. And the answer is simply the following. Before the procedure in panel A, the contractions that empty the stomach originates from the proximal body of the stomach, right up here, and they propagate forward to empty that stomach. After endoscopic sleeve gastroplasty, you still have contractions of the stomach. They're still frequent, but now they're originating distal in the antrum rather than in the proximal body. And we show that in this contractogram generated based on the MRI. This is before you could see these long waves that originate in the proximal body of the stomach. There's 3 of them per minute. These are what empties the stomach. After endoscopic sleeve gastroplasty, you still have 3 contractions per minute. They're still vigorous and red, but now they're originating from the antrum rather than from the proximal body, so they're becoming much shorter, and that correlates with the delay in gastric emptying that we observe with endoscopic sleeve gastroplasty. So how do we use this as an actionable thing? So now the modification that we have and we're reporting on is combining ESG with APC in the antrum. So now instead of starting at the ancestral level, we start 3 centimeters from the pylorus in order to delay gastric emptying further while preserving the motor function of the antrum to empty the stomach eventually without causing gastroparesis. So here you can see we have these APC bands on the anterior greater curvature posterior wall of the antrum, and we're starting the first sequence of that ESG about 2 to 3 centimeters from the pylorus to shorten the antral contractility, further delay gastric emptying, and enhance the results. There is an ongoing randomized trial, and we would be looking to forward to reporting on this. But that's one of the things to look for in the near future. Now, the second theme of my talk is small intestines, endoscopic bariatric and metabolic therapy. This is a new frontier because now the gastroenterologist is gonna become a diabetologist. Truly, by every meaning of the world, we're gonna be dealing with diabetes in the very near future. Why? Is the following. This was just published in September 22 of 22. So it's in the New England Journal of Medicine. We all tout all these new drugs, the GLP-1 agonists, the SGLT2s as effective drugs, and they are effective drugs, but they're not a panacea for metabolic disease or obesity for that matter. Because what this trial showed us, that initially you take diabetics and you put them on these modern agents like SGLT2 and GLP-1s, there's going to be a response within the first few months. But what you could see with every single one of them is the patient is getting out of control as far as their diabetes control within the next 48 months. So that means these medications are addressing downstream signaling, the byproduct of diabetes, which is insulin resistance and beta cell dysfunction, rather than reversing the pathophysiological clock on the disease. And we as gastroenterologists have access to this organ. And this organ is the duodenum. And the duodenum, as you can see here on near focus, is truly a sensing organ that have a very robust network of endocrine and enteric nervous system that orchestrate the metabolic response. And we know that early in the disease of diabetes, the duodenum becomes dysfunctional, and now it could be a very appealing target as a regenerative medicine paradigm to kick back the clock on type 2 diabetes with the modern agents, but this would be a new novel target for diabetes control, as you can see here. So the idea here is, this is the villus and crypta I showed you in that duodenum. This is the enteric nervous system that correlates to them. And it's a sensing organ that is very well innervated, and it's truly the conductor of the metabolic response as shown in this figure. So when an organ gets diseased, for example, somebody have refractory depression, we give them electroconvulsion therapy. That means we put electricity in their brain, and this electricity regenerates or improve the firing of the nerves that produce serotonin, and the patient have treatment of the depression. So a similar concept is now being applied for the treatment of type 2 diabetes. It's called reset or endoscopic recellularization by electroporation therapy. And the concept here is the duodenum gets dysfunctional in diseases of type 2 diabetes. We introduce this pulse electrical field that generates about 700 pulses, but only for nanoseconds. And these electrical pulses, athermally, there's no heat, lyse the cells with phospholipid membranes without affecting the extracellular matrix. And now these cells, including the nerve endings, regenerate with ability to fire in order to have a robust metabolic response. So it's truly a regenerative medicine paradigm for diabetes. Unlike thermal ablation, which denatures the extracellular matrix and causes fibrosis, this regenerates the organ without denaturing the extracellular matrix. So it has significant safety and it regenerates also the deeper nerve and signaling of that organ for metabolic benefit. So with this procedure, again, the idea is electrical field to fix gut dysbiosis, inflammation, enhance nerve firing, and improve the stem cell niche. And you could see this is one of the patients who underwent this procedure. This is continuous glucose monitoring, 62-year-old. You could see on medications, and before the treatment, their time and range was out of whack. Anything in the gray is controlled. He's been in a 24-hour day, or every time of the day, whether night or day, out of control. And now we administer this reset therapy, and you could see that we got this patient under control all the time of the day, including at night, which is at night is not a target for medications usually. So because this is liver gluconeogenesis, you could see even during the night time, this treatment is capable of doing that. So it's exciting new frontiers for gastroenterologists. Finally, I will end with combination therapies. We're going to see a lot of these because these are exciting, and this is the brave new world. And the brave new world is similar to cardiovascular medicine. Somebody with aortic stenosis used to get a huge, big open heart surgery, morbid procedure to fix their aortic stenosis. Now we have TAVR, which is through an artery or a vein or transeptally, you could replace the aortic valve with a prosthesis. And now this have revolutionized the field of cardiovascular medicine. So the question is, could we create a bypass procedure with restrictive gastric conduit and a bypass small intestines, which is with a single anastomosis using endoscopy? And the answer in 2022 is yes, we can. So the first component of this procedure is creating a gastroenterostomy. It's a procedure now that is popularized across the globe. We use it for gastric outlet obstruction. And this is a mainstay procedure now that we could go into the stomach, identify a loop of the jejunum, distal to the locomotive tract, and using a lumen-opposing metal stent, create a gastroenterostomy. The problem here is if you create a gastroenterostomy without blocking the exit of the stomach, and you will not bypass the small intestines, and you will not use the anastomosis. So there is no point. So that's why we need step 2 of how could we create a bypass procedure that builds around a gastroenterostomy that's created endoscopically. And now there's this device. It's called the single anastomosis gastrointestinal system, which integrates just like a PEG tube. You pull it in place, it integrates with the axios, it bypasses a third of the stomach through this occlusion mechanism in the antrum and bypasses the proximal small intestines. Now this procedure is interesting here because it relies on a novel dynamic equilibrium anchoring system that accommodates the motility of the GI tract, does not fight it. It could be done with a laparoscopic gastroenterostomy or an endoscopic gastroenterostomy. And basically, it's just like pulling a PEG tube. You secure a wire through the anastomosis, and you're pulling this device like a PEG tube. It articulates here at the gastroenterostomy, as you can see, and then there's an occluder portion that bypasses the antrum. This is here the dynamic equilibrium part. This is not actively anchored anywhere. It's through dynamic equilibrium. There's a spring that if you try to dislodge it, it just makes its way back in. If you try to dislodge the antral component of it, the same thing is this springs and suspension allow it to accordion, and now you release it, it just finds its way in. So it's actively engaging this dynamic equilibrium system in order to bypass the stomach and the small intestines, as you could see here, just like a surgical anastomosis would. In pigs, the results of this has been very interesting, similar to bariatric surgery. No migrations observed given this dynamic equilibrium or trauma to the GI tract. And now we were able to prove of concept to combine this with endoscopic sleeve gastroplasty to create a full gastrointestinal bypass that will behave just like a bariatric surgery that would behave, but while preserving this anatomy. So here we place that device, and now we're creating an ESG. You can see here's the gastroenterostomy with the device in place, and now we're reducing the rest of the stomach using 3 U-shaped sutures of endoscopic sleeve gastroplasty in order to tubularize the remainder of the stomach to create basically a surgical bypass with a small gastric reservoir and a bypass proximal intestine. Here, for you those not familiar with ESG, we start with the anterior wall of the stomach. We're going to the greater curvature of the stomach. We're using the overstitch device. The overstitch device is the full thickness tissue acquisition device that uses 2O-proline sutures. It allows you to do continuous suturing. And now here we're using the silica retractor in order to create these U-shaped sutures. And then once you're done with the sequence, you cinch that device or you cinch that sequence. And now we're creating this endoscopic sleeve gastroplasty. At the end, here is the afferent limb of the jejunum. Here is the device in place. The antrum is bypassed, and here's the proximal sleeve. So you've created a fully endoscopic single anastomosis gastric bypass procedure using the technologies that are shown in here. So in conclusion, the GI tract is truly a front and central in weight and metabolic regulation. Endoscopic bariatric and metabolic therapies will play a significant role in the management of obesity and its metabolic complications. EBMTs have a clear physiological underpinning, and in my opinion, they're going to be the next big revolution in the field of gastroenterology and endoscopy. Therefore, as a community, we should embrace them and help develop them because they're going to be a big part of what we do as gastroenterologists in the future. With that, thank you for your kind attention.
That was a brilliant talk by Professor Barham Abudaya, who is the Professor of Medicine and also Director of Advanced Research in Mayo, with more than 250 publications and several awards. So he's globally looked upon a leader in the field of innovative endoscopy. We from VGM Institute of Gastroenterology, we are very, very happy and thankful to him for sparing time to be with us to deliver this prestigious oration. We are really thankful to you, Professor Abudaya, sir. So now we'll move on to the program, and let me introduce my team, and then we'll have a short talk by Professor Dr. Nagesha Reddy immediately, and then we'll start off with the live cases. So with me, on to my left is Dr. Madhura Prasad Suman, who's interventional endoscopist, who does all therapeutic procedures, ERCPs, EUS guided procedures, and the third space procedures, and including motorized power spiral enteroscopy. To my right is Dr. Vamshi Murthy, who's yet another hero of the unit, who does all interventional therapeutic procedures, including EUS, ERCP, third space procedures, and everything. So, and sandwiched in between is the big man from Mayo, is Professor Dr. Prasad Iyer, who is the Professor of Gastroenterology at Mayo with more than 250 publications. His area of interest is esophagus. So, and he has done yeoman work in the field of esophageal endotherapy. So he's going to demonstrate cases for us, how to diagnose GERD, how to diagnose the OG junction, how to diagnose Barrett's, how to treat low-grade dysplasias or medium or high-grade dysplasias. So then we have the entire team here. I have Dr. Sunil Chako-Varghese, who is our gastroenterologist, who is a wizard of all therapeutic procedures. And we have Dr. Sangameshwaran, our gastroenterologist, doing all therapeutic procedures. And again with Srinivas Reddy, who does all therapeutic procedures. And we have, two stalwart intensivist anesthesiologists, Dr. Harish and also Dr. Navneet. And the entire team of endoscopy department is here. Where is Kannan, Jodatin, and the entire team, Kavita, and all of them are here, and along with the team of Video Line, so Video Line Anand's team, and our electronic data processing team, EDP team at VGM, who have put up the whole show together. my gratitude to Ebenezer and Rajesh and the entire team. So we have a fantastic feast of cases today. So please stay on with us, to swim through an endoscopic journey of treating GERD and how to prevent complications, how to augment the sphincter, and also we move on to the obesity also. So how to treat obesity, the endobariatrics, which is less morbid than other laparoscopic or surgical procedures. That is why all the endoscopic procedures are coming to limelight. Now, we have a brief 10-minute talk by my own esteemed colleague, Dr. Professor Nageshwar Reddy, who's unable to join us today because of his commitment elsewhere, but nevertheless, he's going to give the talk on the endotherapy of GERD in obesity. So this is important because we know many obese people have disruptive GERD, as I was initially pointing out. So we need therapies to treat these patients. So how common is it, and how much should we focus on treating GERD in obesity? That is going to be the presentation of Professor Nageshwar Reddy's talk. Professor Dr. Nageshwar Reddy also does not require any introduction. He is the head of Asian Institute of Gastroenterology at Hyderabad, past president of Indian Society of Gastroenterology, Endoscopy Society of India, and also the World Endoscopy Organization. So I have a pleasure in now, bringing in the lecture from Professor Dr. Nageshwar Reddy.
I'd like to thank Mohan Prasad for giving me this opportunity to talk on this very important topic on endotherapy of GERD in obesity. Is it prime time? Obesity and GERD have a direct relationship. For example, many of the factors which can give rise to reflux, low residual sphincter pressure, hiatus hernia, transient relaxation of LES, and intergastric pressures are all increased in obesity. A significant percentage of obese patients also have disordered esophageal motility. All this results in increased incidence of GERD in obesity. There is also a direct correlation between BMI and the severity of gastroesophageal reflux disease, as shown by this study. As the BMI increases to over 50, majority of these patients will have grade D esophagitis, indicating a linear relationship. Now, before we actually treat these patients, the most important thing to do in these patients is to phenotype them. Are we dealing with erosive reflux disease, non-erosive reflux disease, which are treated endoscopically, or is it reflex hypersensitivity and functional heartburn, which are then treated only with the medication? So even in patients with obesity, this phenotyping is very important. Now, most of the patients of GERD are treated successfully with PPIs. But however, there is some concern here of long-term side effects of PPI, large volume reflexes, especially in obese patients. Some of them are reluctant to take PPIs or non-responsive to PPI. So there are several unmet needs. These refractory GERD patients and those with volume reflex require some form of endoscopic therapy. Surgery is to be an option in this patient, but unfortunately, especially in obese patient, surgery has certain problems. Another problem is post-bariatric surgery, especially post-sleeve patients have an increased reflex in them, and these patients also require some form of therapy. There are now several methods of endoscopic anti-reflex modalities: radiofrequency ablation, transoral fundoplication, and mucosal resection. Let's look at this. Radiofrequency ablation is best done by the technique of strata, where you can put radiofrequency needles directly into the lower end of the esophagus, produce a burn, and change the lower residual sphincter elasticity. I believe that this is a procedure that is most useful for mild GERD in patients who have undergone a sleeve gastrectomy. This would be the ideal form of treatment. But for more severe forms of GERD, this is not very useful. Of course, this meta-analysis showed its utility in this group of patients. The second is patients who come to us for transoral fundoplication, and here I think major advances have been made. There are several types of transoral fundoplication which resemble laparoscopic fundoplication but done endoscopically, giving rise to a complete transmural staplings. This is the device that we have been familiar with, the GERDX device, which is then controlled endoscopically. And just to show you a video of how this device is used, You can see the device is like a joystick, and we are passing a small pediatric endoscope through the device to watch how it is acting. And then you can see the distal part of the device, which is just retroverted around the G junction. With the helix, we fix the mucosa, pull it back, and then so that the layers come, and then we close the jaws of this device, and then we fire the device so that the stapler, a full thickness gastric stapling is done, which can be seen here quite clearly. This gastric stapling is quite effective, and normally we put two sutures, one at 5 o'clock, one at 7 o'clock on the greater curve, and this results in significant decrease in reflux. We have just published a randomized controlled trial where patients were randomized to sham procedure or into the actual procedure, and you can see very clearly that if you look at the quality of life, that is HRQL in these patients, significantly improved in those who had the real procedure compared to sham procedure. And of course, when we follow them up for 6 months and 12 months also, similar results are there. But more importantly, when we follow up these patients on long term, we find that in about 70% of the patients, PPIs can be withdrawn. At end of the year, only 30% of these patients who underwent the actual procedure were on PPI. Especially in patients with obesity, and even in those patients who had sleeve gastrectomy, this can be done if done carefully. There is a limitation in sleeve gastrectomy because you can't retrovert the design very easily. That's the reason why Stretta is preferred in these patients, and Gerdex comes lower down in the list. The third method is anti-reflex mucosectomy. Again, this is a procedure which Professor Inoue propagated several years back, where what he does is around the lesser curve, he does endoscopic mucosal resection in a horseshoe fashion and now in a butterfly fashion too. And what happens is when this heals, this produces scarring and G junction gets closed, and this results in decreased reflux. He published his initial studies which showed that this can be effective in decreasing the reflux in patients with significant reflux. Again, this is a procedure that can be done very easily in patients with obesity surgery also. For example, if you have a sleeve gastrectomy. So my preference for patients who had sleeve gastrectomy and have reflux is first is Stretta. If that is not available, you can go for arms. A modification of arms is the armor procedure, which again we have considerable experience here, where instead of doing endoscopic mucosal dissection, you do the same technique on the lesser curve, but we actually do ablation of this using argon plasma coagulation at 100 watts. Exactly similar. The scar that's produced can be quite significant, reducing the reflux. So in patients who have undergone bariatric surgery, either Stretta, arms or armor may be the first choice, and in these very resistant cases, you could think of going ahead with even a Gerdex procedure. But in primary obesity, I would still prefer Gerdex as the first procedure because either arms, armor or Stretta is not very effective in those patients who are obese and who also have a reflux. So challenges of GERD treatment, especially in patients who are obese, are majority of these patients are not satisfied with PPI therapy. Once they stop PPI, they get back the symptoms, and this can be a problem. There can also risk of morbidity surgical intervention, especially in patients who are obese. Morbidity and mortality increases a lot, and this is again going to be a significant problem. Therefore, in these patients, endotherapy is coming as a very good alternative. The other procedures which I didn't discuss in detail, like TIF, for example, with which you don't have much experience, again, there's not much literature about use of TIF in these patients. But again, I think majority of patients with reflux who are not responding to PPI, do not want to take long-term PPI with obesity, the ideal treatment would be, of course, lifestyle changes and so on, but ideal treatment is endoscopic rather than the more invasive laparoscopic surgery, which could itself result in more reflux. Thank you for your attention. I'd like to thank
Thank you so much, Professor Dr. Nageshwar Reddy, my very close friend for more than 35 years. So it was a brilliant talk of the necessity of looking at GERD in the obese people and how to manage GERD in obesity. I have a pleasure to introduce Dr. Mitra Prasad, also who's a hepatologist and transplant physician. So in Team VGM, there are 6 of us in the Team VGM, so who do all therapeutic procedures. So now I'm very happy to say that more than 580 participants have been registered for this program, right from Philippines to Burma to Nepal, Sri Lanka, Middle East, and African countries, and along apart from, of course, India. So there are more than 580 participants. Some of them, the sun has already, arisen, but some of them haven't even seen the sunrise. So I'm sure they'll just be logging in from different parts of the world at different points of time. However, the whole program is on the YouTube, and you can always watch it. Now over to Professor Prasad Iyer from Mayo for a beautiful demonstration of this patient who will be introduced now. Can you have the case present, history of this patient?
Yes, sir. Running, sir.
This is the first case of our day. This is Mr. Mani, 34-year-old male, who presented
Closer.
with heartburn and regurgitation for the past 2 years. And to refresh our minds, here is the NBA classification of Barrett's. This is a Bing classification, looking at the mucosal surface and the mucosal vascular architecture. Just another example showing non-dysplastic Barrett's epithelium with the high resolution endoscopy, and this is the dysplastic Barrett's epithelium.
Prasad, sir, you can. You're live.
Good morning, everyone. It's a pleasure to be at VGM Hospital. We have a wonderful team here, as Dr. Mohan Prasad has already introduced us. So this is a gentleman that was just 34. He presented with chronic heartburn, acid reflux, and some dyspeptic-like symptoms. And I hope you can see the endoscopy. There we go. And essentially we are into the stomach. As you can see the antrum down below there. And typically in a patient with reflux, my first effort is to really systematically assess the GE junction. Now, you could do this first antegrade and then retroflex. I tend to go first into the duodenum and then slowly pull back. So as you can see, this is a retroflex view of the stomach. And what we should do in every patient presenting with reflux, particularly if we are thinking of anti-reflux endotherapy, is to carefully assess the anti-reflux barrier. So as you know, the anti-reflux barrier consists of several components. There's a diaphragmatic crura, which we do not see endoscopically. There is the valve itself, the GE junction. And then, of course, we have the lower esophageal sphincter as well, which we don't see endoscopically. So here, as we can see, the classification of the GE junction on retroflex view is best done with the stomach being inflated. So again, if you do not inflate the stomach completely, you might be underestimating the laxity of the GE junction. So here we can see the scope is being hugged by the intra-abdominal component of the lower esophageal sphincter, the anti-reflux valve. And as the patient is expiring, there is a little bit of laxity between the scope, right there, between the scope and the lower esophageal sphincter here. So again, this would be an example of what I would call a Hill class 2. So class 1 would be where the valve is very snug, there is no laxity at all, and the intra-abdominal component of the valve is extremely intact. In Hill classification 2, you actually have a little bit of effacement of the intra-abdominal component, as you can see here, and a little bit of laxity with spaces between the endoscope and the stomach. Hill classification 3 would be where you have a small hiatal hernia, and Hill classification 4 would be where you have a large hernia with proximal displacement of the GE junction and a large part of the and a part of the stomach into the thoracic cavity. So again, this is a good example of what I would think would be Hill classification 2. So once we have done that, we will slowly pull back And our first landmark that we will try to assess is where is the diaphragmatic pinch. And as you can see, I'm just going to focus right here. And as you can see, this is the diaphragmatic hiatus, particularly as the patient inspires and expires. And we will want to make sure where the landmark is. So this is at about 37 centimeters from the G junction. From the incisors. As we come back, our next landmark would be the G junction, which would be the top of the gastric folds. And again, it is very important for us to assess this not in a lot of insufflation, but somewhere between inflation and deflation in order to allow the gastric folds to come up. So again, top of the gastric folds here are at about 36. So he has about a 1 centimeter hiatal hernia. So as we said, this is the beginnings of a hiatal hernia. And then as we slowly pull back, we then begin to look at where is the squamocolumnar junction, which is the third landmark that we would want to identify in every patient with reflux. And again, here it appears that this patient may have a 1 centimeter tongue of columnar mucosa in the esophagus, with the top of the with the squamocolumnar junction being located at about 34 centimeters from the incisor. So again, important to carefully assess both on antegrade and retroflex views. The other thing I would also want to mention is that we are actually using a new endoscope. This is called the EVIS X1 Olympus endoscope. And as you can see, it has excellent definition and resolution. And it has several components in terms of imaging that I would like to demonstrate. So what we are seeing right now is the white light endoscopy. So let's switch to narrowband. So there's narrowband, and again with narrowband, you can really get an excellent view of the mucosal and vascular pattern. So if you were to look at this pattern at about the 3 o'clock position, this is fairly normal. Let's go to something called near focus. So near focus allows you to get up close to the mucosa, and as you can see, hopefully, I also have a cap, a soft cap, and again, I can fix the mucosa and you can actually see the vascular pattern extremely clearly here. So this is wonderful resolution. So again, here I'm turning a little bit of irregularity at the G junction. I'm just turning from 3 o'clock to 12 o'clock. Again, I would say that this is a somewhat irregular mucosal and vascular pattern, and I'm slowly just pulling up proximally, again abnormal vascularity. And here we are turning on to the 12 o'clock to 11 o'clock position, again a little bit of nodularity, and again you can see the abnormal vasculature here. So let's turn off near focus and then maybe go back to the TXI mode. So the TXI mode is a wonderful mode. So let's first look without the TXI mode. And again, as you can see, this is great resolution, but once you turn on the TXI mode, again, everything becomes crisper and extremely well defined. And I think this is a wonderful advance, and hopefully this will be studied, and the yield of dysplasia in these patients is likely to be higher if we are to get such wonderful high definition pictures. So I'll stop there. So this would be a patient where I would at least endoscopically suspect maybe short segment Barrett's. I would call this C0M1, and we should be taking targeted biopsies from these abnormal areas in the tubular esophagus. Absolutely. So I think we are going to move to the next case, and thank you.
Patient has to be stabilized.
Ma'am, your mic on, ma'am. You are on live.
So,
Case history running, ma'am.
yes, this is a 33-year-old lady who presented with heartburn and weight loss, heartburn for a long duration, actually many years duration, increased since 2 months. And we actually already previously had done a biopsy of this tongue of columnar lined esophagus. It was proven there was no dysplasia. Now she's come for surveillance, and we just need a few minutes. So till then we will discuss with Dr. VGM what is his So we always like to screen our patients, every patient with reflux, with NBI imaging, and it has definitely, there has been a correlation with NBI and the pathology. So low grade dysplasia actually 9% goes in for intramucosal adenocarcinoma. So it's better we always like to resect out, do an endoscopic mucosal resection of the low grade dysplasia. I'll ask Dr. VGM what he would like to do if there is.
Of course, if there is a Barrett's, proven Barrett's, I'm sure we should be able to treat it completely, because we know that from metaplasia, it goes to low-grade dysplasia, intermediate-grade dysplasia, a high-grade dysplasia, which is equivalent of carcinoma in situ, and then it progresses to invasive carcinoma. So this sequence has to be broken. So Barrett's adenocarcinoma has to be prevented, because today obesity is more, and 20% of Indians have reflux because of laxity of ileus. I think it was in Olmsted County that first time they demonstrated that it could be genetically transmitted through 5 generations. So GERD itself could be genetic, and 5% of all GERD could be disruptive GERD, producing a tremendous amount of acid coming up, staying for long duration, producing a lot of problems so to the esophagus. So Barrett's definitely needs treatment, and once we see Barrett's, we would also go ahead and augment the ileus. Otherwise, they'll land up with a lifelong PPI therapy. So youngsters, what do you think, Prasad sir, youngsters who have Barrett's? So do you do a definitive procedure endoscopically augmenting the sphincter, or do you put them on lifelong PPAs? What is your choice?
Yeah, I think that's a great question. It all depends on how severe the reflux is, what the wishes of the patient are. Typically, at least in the United States, our first attempt is to treat the reflux medically with proton pump inhibitor therapy. So as I think it's very well known, patients with Barrett's typically have one of the most severe refluxes, particularly if you go from the no reflux to non-erosive reflux to erosive reflux and then to Barrett's. Indications for considering endoscopic therapy in those with Barrett's esophagus are really the same as those in those without Barrett's esophagus. So as you can probably, as has been shown really well in multiple studies, most patients can be controlled by medical therapy. So that's typically PPI therapy. But just like Dr. Abudaya showed in his slides, if someone has large volume regurgitation, if someone has medically refractory disease, someone is not able to tolerate PPIs because of diarrhea, severe headache, or say has acute kidney injury from interstitial nephritis due to PPIs, those would be instances where I would probably think of anti-reflux, either endoscopic or surgical treatment.
I absolutely agree with you. So it is not only the symptoms that the GERD patients present with, which disturb the quality of life of these patients. You also have a look at endoscopy. What grade of severity of GERD do they have? And then also look for Barrett's. If they have any of those complications like ulcers or strictures or other complications of chronic reflux, all those have to be addressed. So as Professor Prasad Iyer was pointing out, a volume reflux is also important. So today, which means if there is a patient with GERD, we need to go ahead, not only do endoscopy, we have to do a manometry and impedance paciometry, even off PPIs, because what, in my experience over 10 years, what I've seen using impedance, I see that like 50% of all reflux episodes are non-acidic reflux, the volume reflux, which may be even slightly alkaline or weakly acidic reflux, which can also produce damage. So can we have a presentation on this case, and then we go for a demonstration of a case of reflux?
Long duration of heartburn and even weight loss now because she's trying to avoid food intake. The past 2 months, she's had more severe symptoms. And this is her previous endoscopy where it showed some tongue of reddish mucosa from which we took biopsies, and it turned out to be columnar lined esophagus. But there were no dysplastic changes both on NBI and also what we saw histopathologically. Now she's here for surveillance.
Okay, so this is surveillance endoscopy for a GERD patient who's already on PPI's prokinetics. So I'm just showing you let me do a J maneuver here just to show the fundus, how lax it is, and then we move on to looking at the esophagus. So what is the Hill's grading of this valve?
Looks like Hills 2,
Yeah,
Hills
I
type
would-
2 probably.
I would definitely agree because you can see a little bit of laxity. Just going to have you turn off the near focus because that is, I think, leading to little blurring. There we go. Okay. Yeah. And as you can see, there's a little bit of laxity of the.
Yeah, it could be Hills 1 or Hills 2.
Yeah.
And definitely not a hiatus hernia. But
Yep.
still there is reflux in this lady. I'm just going to show you. So we have screened the stomach and duodenum. For want of time, we're not going to get in deeper. And then I'm just going to pull back to the OG junction. As Prasad Iyer was pointing out, it's very important, pertinent to define the OG junction properly. Where is the diaphragmatic pinch cock? And where is the OG junction, the squamocolumnar junction, which is the Z line as the Americans call it, or the Z line as the Europeans call it. So we just suck out all the fluid in the fundus, before moving on, especially in a sedated patient. You have to fall back into the fundus and keep sucking all the fluid completely so that there is no chance of risk of aspiration. Patient is in left lateral position, and now she is intubated, and that is the OG junction. If you see the OG junction, I would say there is a mild laxity, and this is the squamocolumnar junction, which is almost abutting on the diaphragmatic pinch cock. See, that's a diaphragmatic pinch cock which is there, probably a centimeter of separation, and then the folds come and end there. So this is not a hiatus hernia, but nevertheless we see Barrett's. I'll go to near focus mode and go to NBI mode. This is Olympus 190 scope. The scope that you were watching with Prasad Iyer is RDI scope, which is the latest EVIS, X1. And this is the tongue of, Barrett's, which is columnar lined esophagus, because we see the pit pattern is more of a cardiac type of pit pattern. We don't see any abnormal vascularity here. And if you see here, there is a small tongue of mucosa here. This is probably showing a little bit of ridge pattern on top. So this may be an ultra short segment there of mild metaplasia, intestinal type of metaplasia at 12 o'clock position. But rest of it, this patch appears okay to me. So now we'll introspect other, yeah.
This is a good demonstration. Careful examination of the esophagus when the esophagus is not overly distended. So you have the right amount of inflation and deflation here, and you can actually now very clearly see where is the GE junction, where is the top of the gastric folds, and where is the Z line. So the Z line is further up. So again, I would call this endoscopically suspected columnar metaplasia. You should biopsy the area which is in the tubular esophagus and is above the GE junction and send that off to histology. And I agree with you with under near focus, most of this looks fairly regular. I'm not seeing any obvious distortion of the pit pattern, the mucosal pattern, well as the vascularity.
Here
Again,
there is
you're
a
on the other
change.
side. Yeah.
This is
Yeah.
a little change from the regular cardiac pit pattern. See, I'm just using a black hood which just prevents the light scatter and focuses, and we're using the NBI, narrowband imaging mode of Olympus on the near focus mode. Can we just zoom it? I want comments from Prasad Iyer on this part of the,
Yeah, again, you can see a
epithelium.
little bit of a projection of abnormal mucosa into columnar mucosa, into the tubular esophagus. And again, you can see the subtle unevenness or nodularity. So this would be a perfect place to take a targeted biopsy from, in my mind, and really send that off to the pathologist. Again, as you can see,
Here,
this is
a
classic
cardiac.
gastric.
Yeah,
This is
pit
classic
pattern.
gastric pit pattern.
Now we move on to another area,
Yeah.
which is different from the previous one. This is a
Absolutely.
ridge-villus pattern of typical of intestinal metaplastic epithelium.
Now
From
the
this,
difference between this versus the difference that you showed above is that this is at the top of the gastric folds, whereas the initial area, which was maybe more around 9 o'clock-ish, was, so there you have it. So that's more in the tubular esophagus right there. So that would be an area I would take a targeted biopsy from.
what is your comment on this area?
So again, this is a little bit nodular. The vascular pattern is a little bit abnormal, and the pit pattern is a bit distorted as well. So this could either be non-dysplastic Barrett's, or you would probably also consider the presence of some dysplasia here because of the abnormality in the vascular and pit patterns.
Do you do routinely chromoendoscopy using Lugol's iodine or even bromothymol, the indigo carmine?
Yeah.
Any of those dyes? Do you use them now or you don't?
Great question. And I think these chromoendoscopy techniques are very helpful, but honestly, with the advent of electronic chromoendoscopy, which is what you are doing a beautiful demonstration of right now, I just haven't felt the need to do additional dye-based chromoendoscopy. I think with any kind of electronic chromoendoscopy, whether it be narrowband imaging, whether it be blue laser imaging, whether it be FICE, optical enhancement, the need in my mind for dye-based chromoendoscopy is low in my mind. Another technique that has been used and described is acetic acid chromoendoscopy in patients with Barrett's as well. And again, all of these techniques have been increased the yield of dysplasia by about a third. But honestly, with the advent of electronic chromoendoscopy, I think the need for dye-based chromoendoscopy is in my mind not as high as it used to be before. Right there, yeah.
So we have to target to biopsy these parts. So let me try and get to the abnormal epithelium. Can you reduce the brightness a little bit? Yeah. Okay. Open.
இது மைக்ல ஆன்ல இருந்தா சொல்லணும் நீங்க.
Right.
Okay.
Excellent. So again, this is a very important technique that Dr. Mohan Prasad is demonstrating. Careful examination, targeted biopsies, and having access to a good pathologist. I think these are critical components. Patient is well sedated. There is minimal movement. This is a tough area to examine. And with good sedation, we are able to do a careful examination, clean, and take targeted biopsies.
So once you biopsy, then the area becomes bloody. And so this is where probably the newer RDI scopes will be of great help because you can still see the tissue under the red blood. And here, we take off NBI because it really blurs the vision because of the bleed. So if you put the NBI now, see, it'll appear black because blood appears black in the blue-green
After
spectrum.
biopsying, NBI is difficult
NBI
to
becomes
interpret.
difficult, so, but we know where to target. I'm just giving constantly some wash on the lens and also brisk irrigation through the biopsy channel, working channel. Open. Keep it open like that. No, No, no. Yeah, wait. Yeah, there we go. So we just rotate the endoscope and reach there. That's right. Yeah. We'll take, please label this bottle as biopsies from, like that is a 12 o'clock position on
Yeah,
top.
so this
So
will be
we
3
take
o'clock.
it from 3 o'clock position is what we have labeled. And then we will target some more parts where it was looking abnormal. And this is, what do you think?
Again, I think if you go to near focus, you'll
Yeah.
actually have. So you can see how with near focus, once you fix the mucosa, again, this is an area I would probably want to biopsy
Target?
as well.
Yeah. Now the next bottle will be 12 o'clock
12 o'clock.
position. We quickly biopsy and then we move on to, a brilliant lecture next by Professor Cadman Leggett from Mayo is waiting for us to deliver his talk. And after that, more live procedures will go on. So please stay tuned. Open. Right. The NBI near focus mode really helps in targeting these areas. Bottle number 2 is 12 o'clock position. So previously people used to do circumferential biopsies random. What is the opinion? I think a lot of publications have appeared even in GIE on these modalities. So today, do we do all that with the advent of Zoom and NBA endoscopies? Do we still need those sort of things, or we do only targeted?
I think the recommendation is really to do a careful examination of the GE junction as well as the distal esophagus, and only biopsy if you think there is a visible abnormality. I think what we are doing right now is just about right.
Just hold, support the scope here.
Maybe one at 9 o'clock
Yeah.
as well.
So I'm doing some at 9 o'clock position where this mucosa also appears a little bit abnormal here. So I'm just putting a, zoom and a near focus. Can we zoom this area electronically? Electronic zoom we'll use. Yeah, look at that. That's brilliant actually. See that? This is the cardiac pit pattern, so which I will not be bothered. So how about this area?
Yeah, I would probably take a bite
this?
from there as well.
Okay.
Yeah.
But more like cardiac pit pattern,
I
but
think so.
there's some layering is there.
Yeah,
So
a little
do
bit
you-
of irregularity.
Do you want some biopsies there?
I think targeted biopsies from 12 o'clock, 9 o'clock
Yeah,
would be
9
fine,
o'clock,
yeah.
yes. This is the Barrett's epithelium which we had biopsied and showed that there was no dysplasia last time. So she's on surveillance endoscopy. So now, she has developed new Barrett's. So we in fact used to do those days the Halo 90 ablation device we used to use, open. But right now the device is not marketed in India, so it's not available. Otherwise we would have demonstrated. Leave the scope, please. Leave the scope, please. No, you close the biopsy forceps, close, wait. Yeah. Open.
Yeah.
Yeah, right. I think we are done with this demonstration. So we do multiple biopsies as far as possible. So I'm taking off the narrowband imaging and near focus. So I hope we had a nice exposure to what is a columnar lined esophagus, what is a cardiac type of pit pattern, which need not be worried about. So there is a difference of opinion between the British and the Americans on the Barrett's. Do you call this, cardiac pit pattern also as Barrett's, or you want intestinal metaplasia, the ridge villus pattern, to be called as Barrett's? What is your opinion, sir?
So I think this is a debate for the ages. And I think at least from an American perspective, and to be honest, most of the world also, we do require the presence of intestinal metaplasia to define a columnar lined esophagus segment as Barrett's esophagus, for the simple reason that if you don't have intestinal metaplasia, your risk of esophageal adenocarcinoma is not as high as if you do have intestinal metaplasia. And again, one has to be conscious about the endoscopic burden. If you were to call just a columnar lined esophagus without intestinal metaplasia as Barrett's esophagus, then the number of patients who are going to be in endoscopic surveillance is going to skyrocket. So with minimal benefit. So in that instance, we have decided to stick with the presence of intestinal metaplasia.
So when we are coming out, we don't linearly pull it. We don't give a longitudinal pull like this. We generally give a rocking movement. So it's easy for the endoscope to disengage,
Absolutely.
even at the cricopharyngeal level, and you don't traumatize anything here by gentle rocking movements. And then,
And it
pay
also
out.
lets you get a 360 view of the esophagus as well, I think.
Absolutely. And then, we also pay out. We don't go, as we are pulling out, we go away from the patient. So we just keep rocking like this and keep looking at it 360 degrees. Every inch of the esophagus has to be screened, because we many a time see columnar lining, which happens at the, just below the cricopharynx. So we need to biopsy those also. So absolutely fine. There are no vocal cord nodules, and the pyriform foci are normal. We need to define the laryngopharynx and the cricopharynx before we just end the procedure. So now we had a beautiful demonstration of Barrett's in this case, and I would like to introduce a team in operating room 2. We are in operating room 2. We have Kannan, Anbu, and then we have Subha and Padma here, and then of course the rest of the team is here. So thank you. We'll just move on to Professor Cadman Leggett lecture from Mayo.
Cadman.
Hi, can everybody hear me?
Can I request Prasad Iyer to formally introduce Professor?
We would like to welcome Professor Cadman. He's a professor of gastroenterology and hepatology from Mayo Clinic, Rochester, and he has won so many awards,
Hi.
and
Welcome,
Jerry
welcome.
Wegner Award, Charles Marcia Career Award, and this goes on, and he has so many international publications to date with his special interest in esophagus and early detection of cancer. Welcome, sir. We're waiting
Thank
to
you.
listen to your talk.
Thank you for the kind introduction. Can you hear me okay?
Yeah, yes, we can hear you.
Wonderful. Thank you, Dr. Prasad. Thank you, Dr. Iyer, for your kind invitation to give a talk at this excellent conference. I've been able to be present for the live endoscopy part of the course. That was excellent. Thank you. Thank you. Hi. Good morning. So I've been tasked with the in the next 15 minutes to give a state of the art on Barrett's esophagus endotherapy. So very pleased to see the live endoscopy case talking about Barrett's and how do we approach Barrett's. So the learning objectives of this talk is to first understand the indications and goals of Barrett's endotherapy. We will review current and emerging treatment modalities and their indications for use. And we will understand what a Barrett's endoscopy endotherapy treatment plan entails, including surveillance of these patients after they complete therapy. So I think it's best to start with a case. This is actually a case of a patient that I saw a few weeks ago. It's a 65-year-old man who was referred to our Barrett's esophagus unit for surveillance. Now, he has a history of long segment Barrett's esophagus, and this is described as having a maximum extent of 7 centimeters and a circumferential extent of 5 centimeters. So a Prague criteria of C5M7. His last endoscopy was performed 5 years ago. It showed non-dysplastic Barrett's. The Seattle protocol was performed, which entails the targeted of biopsies of any areas of concern, followed by random biopsies across the entire length of the Barrett's esophagus. And in fact, there were no mucosal abnormalities with that procedure. He takes a daily proton pump inhibitor, and he does not have frequent reflux symptoms. So he's here for surveillance. And I'm going to skip over this part because I realized that the live endoscopy course has targeted that as well. But I want you to keep in mind this image that I'm showing you now, especially the image here in the bottom right. This is a study performed by a renowned Mayo gastroenterologist who basically mapped out areas of dysplasia within Barrett's esophagus segment. And as you can see, dysplasia can be heterogeneously distributed across the Barrett's esophagus segment, but it can also be focal, like you can see in here. You have an area of high-grade dysplasia and cancer, and basically and the rest of the Barrett's esophagus is non-dysplastic. So there's a high risk of missing an area of concern with random biopsy. So there's a risk of sampling error. So let me skip to the video, and this video illustrates an exam of a patient with Barrett's esophagus. Now the video is in a higher speed. So my first advice will be to take your time when you do a Barrett's exam. And I saw that you guys were also using narrowband imaging. That's great. Digital chromendoscopy helps enhance the ability to detect lesions in Barrett's esophagus, helps enhance the ability to detect dysplasia. So the first thing you do is you establish your landmarks, as you guys were talking about in the live endoscopy course. And then I usually do a narrowband imaging exam looking for any mucosal abnormalities. And in this case, there's a very subtle lesion that will appear on your screen in a few seconds here. And that lesion is a lesion of concern. And I'll pause the video here. So right here, so this, as you can see, there is an altered vascular pattern, even an absence vascular pattern as observed under narrowband imaging. And this is a lesion of concern. So you could target this lesion with a biopsy, as the live course was doing, making sure that you label it in an independent bottle, or you can use endoscopic mucosal resection to target this lesion. The advantage of using a resection technique is that it allows you to give the pathologist a larger piece of tissue compared to a biopsy. And it has been shown that the use of a resection in a setting like this enhances the ability to diagnose dysplasia. So that's the lesion. And here I'm using near focus, as you in the live endoscopy course was using, and those are the features that we discussed. So then this is followed by marking of the lesion. I'm using APC to mark the edges of the lesion. You give yourself a 2 to 3 millimeter margin between the lesion and the markings. And then you inject the lesion. So one clue here is you're trying to see if the lesion lifts from the submucosa. You're performing an injection of methylene blue mixed with epinephrine and saline to inject. There are other solutions that you can use to inject, but in this case, the lift is a temporary lift. You don't need the lift to be a long lift. So, and here, this is a cap and snare technique. The snare sits in the ridge of the cap, pulling back, identifying again the lesion. The markings help identify the lesion, making sure that we are in fact resecting the entire lesion. And then the snare is closed. You get a sense of the tension in the wall of the esophagus. Make sure that you're at the level of the submucosa, and then you perform the resection, and you remove the endoscopic mucosal resection tissue sample. And then here you can see the resection bed with the markings showing that the resection was complete. And in this case, that focal area was the only area in the entire Barrett segment that showed high-grade dysplasia. The rest of the biopsies showed non-dysplastic Barrett's esophagus. So why is that important? Because that in essence is a branching point in the Barrett's endoscopy treatment plan. So the first thing you do when you're examining a Barrett's segment is you look for a visible lesion and perform endoscopic resection or biopsy to try and detect dysplasia. If the endoscopic resection shows submucosal invasion and cancer, then basically you go down the path of cancer staging and evaluating that patient for esophagectomy. If there's evidence of low-grade dysplasia, high-grade dysplasia, or intramucosal cancer, you assess the specimen for whether the lateral margins are involved with dysplasia or are clear of dysplasia. If they're clear, then you consider that a curative resection. In this case, they were clear. And then you move forward with ablative therapy once all mucosal irregularities are eradicated. Now, if there's no visible lesion, you would move straight ahead into ablative therapy. A few words on T1 esophageal adenocarcinoma. This is cancer involving the mucosa or into the submucosa. Most of Barrett's endotherapy is reserved for T1A cancer, so basically cancer that is at the level of the mucosa because of the lower risk of lymph node metastases compared to T1B esophageal cancer. There are features, histological features that we need to take into account, like depth of invasion, poor grade of differentiation, and the presence of lymphovascular invasion that put these patients at a higher risk of lymph node metastases and mortality. Now, what is the goal of Barrett's endotherapy? The goal is to basically decrease or eliminate the risk of neoplastic progression. We know that Barrett's is a pre-malignant condition, so we're trying to eliminate that risk. And the ultimate goal is to achieve what we call complete remission of intestinal metaplasia, or CRIM, that is defined by the absence of any visible Barrett's under endoscopy and the absence of intestinal metaplasia on surveillance histology. Sometimes CRIM is, we are unable to achieve CRIM. So a kind of a secondary outcome of Barrett's endotherapy is to reach complete remission of dysplasia. That's defined by the absence of dysplasia on surveillance histology. Now, it's important to take into account that if we achieve complete remission of dysplasia, that the recurrence of dysplasia is higher in this patient population, 12% compared to those that do achieve complete remission of intestinal metaplasia. And the other thing to take into account is that we want to pursue endoscopic therapy and try, in doing so, try to avoid complications such as strictures, perforation, and bleeding. So we want to do this safely in our patients. So what are some of the resection techniques? The video showed a cap-assisted endoscopic mucosal resection. We also have a similar technique called band EMR, where basically a ligation band is placed over the lesion. This can be done without the need of a submucosal injection. And then a snare is placed under the band, as you can see in this panel, and the resection is performed. Now, the band EMR allows you to target a larger lesion because, in essence, you can do piecemeal resection of that lesion. And the newer technique, new as of the last maybe 5-7 years, is endoscopic submucosal dissection, where we use different instruments, special knives, to basically dissect at the level of the submucosa. And I'll show you some examples in a minute. So EMR versus ESD, they're both highly effective in eradicating Barrett's esophagus neoplasia. ESD has a higher rate of achieving complete remission of dysplasia compared to EMR, but they both have similar rates of achieving complete remission of intestinal metaplasia. With ESD, there's a higher rate of achieving an unblocked resection. It makes sense. You're resecting the entire lesion on one procedure, compared to EMR, where you may be doing piecemeal resection of larger lesions. And ESD obviously will lower the risk of any residual disease compared to EMR, but in essence, they're comparable in terms of their ability to treat dysplasia and neoplasia. Now, ESD is more technically challenging. It takes a longer time to learn than EMR, and it takes a longer time to complete, and it's slightly higher risk of perforation associated with ESD. So when do we use one versus the other? I think the writing is still not in stone, but we basically approach this on a case-by-case basis. In my practice, if the lesion is 10 millimeters or less, I would entertain doing EMR, like the video that I currently showed. EMR versus ESD and lesions that are between 10 and 20 millimeters, and ESD definitely for larger lesions. Also for bulkier lesions, something to take into account, since the cap has a limited space. Lifting a bulkier or thicker lesion is going to be challenging if you're doing a cap EMR. So this is a video that Dr. Iyer shared with me of a case that he had, an ESD case. As you can see, this case The lesion is much larger than the case that I demonstrated, which was a flat lesion. This is more of a sessile lesion. So again, the marking, the video, the speed of the video again is increased. And using a special, so this is the part where you're injecting and lifting the lesion, and a special kind of knife called a hook knife, resecting in the distal end of the lesion, and then a lateral side of the lesion. And the advantage of ESD is, number one, I mean, you can identify that plane in the submucosa. You can identify if there's fibrosis and resect through that area of fibrosis. You don't rely 100% on the lesion having to lift into the cap. If you do see a vessel, you can actually cauterize the vessel before it bleeds. So it allows you to do some preventive measures there before encountering bleeding. So again, this is the dissection. You're kind of working on that plane, injecting as you go, trying to lift that lesion. You need to work with gravity in your favor. So yeah, usually you start dissecting in the lesion in a position where the lesion will fall back instead of towards your endoscope. And this is an example of how a vessel is identified and a quack grasper is used to basically ablate that vessel or so that it's cauterized before you can move forward. And at the end, you have a larger resection and it's removed en bloc, compared to a lesion like this, would be hard, I think, to remove with a piecemeal resection. So there are newer knives, newer techniques that are being developed. This is an example of a clutch cutter knife, a study that we did here at Mayo, comparing the use of this knife versus wide piecemeal EMR. And the ability of this knife is kind of like a scissor knife, is that it's a little bit easier to use than the traditional, hook or IT knives used in ESD. And the procedural time, still longer, and there's a learning curve associated with this tool, but a little bit of more of a user-friendly tool. So after resection of a lesion comes ablation, and by far radiofrequency ablation is our first-line modality. There is good evidence, multi-center randomized controlled trial that shows that patients that undergo radiofrequency ablation achieve a CRIM rate of 77.4. It's a contact device, so these are thermal devices. They come in different sizes, and the size depends on the length of the Barrett segment that you're ablating. But there is a 6 to 14% of stricture rate, and these patients usually have some degree of pain, especially if they undergo circumferential ablation. Another tool is spray cryotherapy. It uses liquid nitrogen and sprayed into the Barrett, over the Barretts, and it's delivered by a spray catheter. It's a non-contact device, so that's one advantage compared to radiofrequency ablation, but it does require the use of a orogastric decompression tube to prevent any barotrauma, because it's of a high-speed insufflation with this device. So you freeze for 20 seconds and then you thaw for 60 seconds, and it's that cycle of freezing and thawing that leads to deeper tissue ablation compared to radiofrequency ablation. And studies demonstrate that ability to achieve CRIM in 66% of patients with high-grade dysplasia. A newer kid in the block, an emerging modality, is balloon cryoablation, a little bit easier to use than spray cryoablation. The ablation device is housed within a pliable balloon that measures 3 centimeters and a diameter of 3.6 centimeters. It's again a non-contact modality. You can spray an area of 2 to 3 centimeters and then rotate and advance this catheter so that you can ablate across the entire Barrett's segment. CRIM rates of 88% with CRD rates of 94% in a meta-analysis, and comparable to RFA in achieving both of these end goals. Hybrid APC, most of us are familiar with a regular APC. The hybrid APC allows you to inject using a needle-free high pressure injection that basically lifts the submucosa and provides you with a barrier. So when you're ablating, it does not damage the submucosa or deeper tissue. It's again a non-contact device. I like this in the setting that you can also retroflex and ablate cardia. If you need to. It's a more flexible ablation device compared to other modalities. And again, similar results compared to radiofrequency ablation with a rate of 82.2% in CRAM. So refractory Barrett's is not uncommon. We encounter refractory Barrett's. These are patients that have undergone radiofrequency ablation at least 3 sessions and continue to have Barrett's to a certain degree. And the first kind of line here is to try and understand why they're having refractory Barrett's by testing for any gastroesophageal reflux. There's a mention in the life course about the need to do that and optimizing acid suppression. But what can we use as a tool to treat these patients? There are studies that demonstrate cryotherapy, the balloon cryotherapy, and is being studied, but the spray cryotherapy being able to achieve complete remission of intestinal metaplasia in 45% of these patients. However, the studies are small in their patient cohorts, and there's significant heterogeneity in terms of the study design. So back to our case, this patient achieved complete remission of intestinal metaplasia a year ago and returns for annual surveillance, and this is what you find. It's a subtle lesion under white light. You turn on narrowband imaging with near focus, and you can see that that's an abnormal area that you need to resect. You perform endoscopic mucosal resection, and as you can see here, there's an area of Barrett's. So this is Barrett's that lies underneath squamous mucosa. So yes, patients that undergo endoscopic therapy are at risk of recurrence, estimated to be between 8 to 10% per year for intestinal metaplasia and 2 to 3% for dysplasia. Usually the recurrence is at the gastroesophageal junction, and it can be managed with further endoscopic therapy. The surveillance protocol used to outline taking biopsies across the length of the original segment. New data demonstrates that you can simplify that protocol basically to take biopsies across the gastroesophageal junction, given the fact that that's where most of the Barrett's lies, the residual or recurrent Barrett's hides, and 1 bottle over the distal 2 to 3 centimeters of neosquamous epithelium. So in summary, Barrett's endotherapy is indicated in patients with Barrett's and early neoplasia. It consists of a combination of endoscopic resection and ablation. It's safe and very effective in reaching complete remission of intestinal metaplasia. It's not uncommon to encounter refractory disease, but there are emerging modalities, as we discussed, with advantages such as non-contact ablation modalities that allow us to treat these patients. And once we achieve the ultimate goal, which is complete remission of intestinal metaplasia, we continue to surveil these patients given the risk of recurrence. Thank you, and open to any questions.
Ma'am, go ahead, ma'am.
But from there I got into
Professor Cadman, thank you so much for that wonderful talk. And a lot of it was so enlightening, and using cryoablation and, EMR. So thank you so much. Thank you. If there are any questions, we'd like to.
I might have a question for you guys, if that's okay. What is commonly used in India for treatment of Barrett's?
What
is the
methods we
modality?
use for Barrett's? So
Yes.
one is, if it's just without any dysplasia, we follow them up. We do the surveillance every 3 years. And if they have low-grade dysplasia, we like to actually do an EMR. And if there's high-grade dysplasia, we'd like to do an ESD, or we used to do RF ablation as well with the Halo 360. So, but so the main thing is surveillance, I guess.
Surveillance. Is there any other ablation modality that you use besides radiofrequency ablation?
No, not so far. So we like to resect it out. So would you agree with us, Professor?
Yeah, so resection is the primary treatment there in India. Okay, good.
Yes. So
Wonderful.
Next, after this patient, we have a patient posted for endoscopic mucosal resection with a proven low-grade dysplasia. Not this patient. This is also a demonstration of Barrett's. Please be with us, Professor, and for the rest of our lecture too, for the rest
Wonderful.
of the workshop. Please be with us.
Th-
Thank you. Thank you
Thank you for the invitation.
so much.
Appreciate it.
Here is again the Olympus 1500 series with, we'll just have a look at the modes. This is also a patient, a 50-year-old who had a long history of reflux, and now this time he presented with increased symptoms and vomiting and heartburn. So we have here, we'll switch to the other modes just to show them the RDI. So RDI is a special feature. It makes things very easy for those who are doing resections, ESDs, and third space procedures where we have a lot of bleed and we cannot find the vessel to coagulate, and that takes a lot of time. So here this helps us to put the vessels totally in clarity. And Professor, we'll be looking at more of RDA when we are doing the resections further on in the day. So here you see what it does. It absorbs the amber light and just projects the red light into prominence, so the vessels are very clear. And the next mode here is the TXI. So the RDA is red dichromatic imaging, and TXI is the what is it, Professor? Yes, texture enhancement. It enhances the texture. You can see it into, I'll freeze it there for you. Yes. So it's so beautiful the way it's enhanced. So if you want to define a particular lesion before you decide what to do with it, this is the best way to go. So I just wanted to show you that before going on to our next data where we are going to be demonstrating AMR. You can go to NBI. So whatever it's said and done, we always go back to the mode which we use all the time. So we'll be switching to the next data. So thank you.
So that's about it?
Yes.
Okay. What do you think about this mucosa here?
Here this looks like it's NBI again. A little bit of
See
an inverted fir tree, but this, some edge of it has that gyrate villus pattern. So
and the
it's
vascular
more of the
pattern
regular,
also.
more of a regular pattern,
Yeah.
where the vessels have to go along the architecture. Then we call it a regular pattern. But this is proven Barrett's by biopsy. So
Obvious Barrett's, but
yes,
I
right.
think this is regular. The
Regular.
vascular pattern is absolutely normal.
Yes,
So,
yes.
and biopsy proven that it's a Barrett's metaplasia. There is no dysplasia. So this patient does not require any intervention, right? How about the island on top? So
Yes.
you can you come up a little bit? Yeah, yeah. What about this area?
The IPCLs are a little,
What about this patch over there?
the patch.
Yeah.
Yeah, there are some abnormal vessels there in the patch. But would you take it as part of the Barrett's, part of the tongue, or you will take it as
No,
part of
it's
the
like an island.
squamous?
It's an island of Barrett's. Probably it's an extension of Barrett's. So would you target biopsies there?
Definitely, where the vessels are slightly
I think
more
so.
prominent.
I think so.
Yeah, yeah,
Okay.
we will do that.
I think we had a wonderful demonstration once again of Barrett's. What is important is to look at the vascular pattern, the mucosal abnormality, and then try to define if this is just a columnar lining, or does it warrant more investigation, introspection by way of biopsy histopathology. That's exactly what we are trying to demonstrate here. Each case is different, so you have to tailor make to the need of the patient and what you see. So thank you, Madhura, for a wonderful quick demonstration. Now we move on to the OR2, where Prasad Iyer is going to demonstrate a case of low-grade dysplasia of Barrett's in OR2. So now we'll move to
Right.
OR2. You are live here, sir.
Yes, sir. Prasad, sir, your mic on, sir. Case history running.
Cases. Yeah, they're going to give only.
Am I supposed to say
Yeah.
something?
So please speak on this case.
Oh, this is a gentleman who's 63, presented with heartburn and had an endoscopy, which you can see on the left-hand side of the image with a narrow band. And as you can see, he has Barrett's esophagus, and biopsies from the top of the segment, I think this is probably around the 11 or 12 o'clock position, showed low-grade dysplasia. So he's here for us to take a good look at the Barrett segment and see if we see some obvious nodularity and perhaps do endoscopic resection. So that is the next phase of this procedure. Can I get some gloves, please? Gloves, medium gloves.
Gloves. Prasad.
So there was a question, sir.
Yeah.
Can NPI replace histopathology?
Yeah, that's a great question.
Yeah, I'll have to repeat the question because can NBI replace histopathology? Was the question on the YouTube from one of the viewers. So let us hear from the horse's mouth, Prasad Iyer.
So I think that if you look at studies which have compared the accuracy of NBI to histopathology, in expert hands, the sensitivity and specificity is upwards of 90%. So it meets PV criteria, the ASG PV criteria. Oh, sorry. So it meets the ASG PV criteria for use by expert endoscopists. I think the challenge is what happens if you go beyond an expert endoscopist who's using NBI maybe on an intermittent basis and is not using it on an everyday basis. So there I think it becomes more challenging. Particularly, I think if you intend to do therapy, we are still using histology as the gold standard because the correlation of NBI and histology is excellent in expert hands, but it's still not perfect. So I think that is the challenge that NBI still faces. So they both have to be used together or not separately.
Okay. Kannan, you can get the system on. Let's start.
We should do an exam for ourselves. Can I get, is the cap on? Can I get a soft cap, please, Kannan? Barrett's cap.
Can you focus here? So we have a, RB Bio 3 and with a service engineer. So we use RB Bio 3, which has been a very good system. So this is very versatile and it has got all power settings to do different procedures, and also like you can also add on APC, organ plasma coagulation, which will be demonstrating in the procedure that we're going to do, the anti-reflux mucosal ablation, the AMA will be demonstrated also. So Irby engineer is here. So what is your good name, sir? Sumit. Yeah, thank you, Sumit and Irby. So once we are ready, we'll start. Yeah. Where was the
Hello, everyone. So this is our second case here. This gentleman is 64. He has been diagnosed with Barrett's esophagus. Biopsies taken a couple months ago showed low-grade dysplasia confirmed by an expert GI pathologist, and he has now come back for further evaluation. So going back to our prior examination, so remember we talk about 3 landmarks. So our first landmark is the diaphragmatic hiatus. So that is at about 40 centimeters here. And as I'm coming back, I'm also now next going to look at the top of the gastric folds. And again, this is where the top of the gastric folds are. And that is at about 37 centimeters from the incisor. So he has a 3 centimeter hiatal hernia. And then our third landmark is the top of the squamocolumnar junction. The squamocolumnar junction in this instance is located at about, I would say, somewhere around 35 centimeters from the incisors. And as Dr. Leggett spoke before, we like to classify Barrett's using the Prague classification. So we look at the circumferential extent and we look at the maximal extent. In this instance, I am not seeing any circumferential Barrett's, maybe a centimeter at the bottom, but mostly it is in the form of tongues. You can see a tongue at about 6 o'clock. You can see a tongue at about 9 o'clock. And then you also see a tongue at about 12 o'clock. The first thing we do again is that we do careful inspection. And as you can see, I also have a small cap, a plastic cap at the tip of the endoscope. Now, if you focus your attention at the 6 o'clock position, you can see a raised lesion here. I would call this Paris classification 2A, so slightly elevated. And let's switch to NBI. So there we go.
Okay.
So here we have NBI, and again, you can see the raised lesion here at about 6 o'clock. And let's engage, I'm going to engage near focus. And again, with near focus, you can get excellent views of what this raised lesion will look like. So again, somewhat raised, abnormal pit pattern, little bit of abnormal vascularity. So this is at 6 o'clock. You also see similar changes at about the 9 o'clock position. Again, excellent views here. I'm going to freeze the image. And again, you can see some abnormal vascularity and a Paris 2A lesion. Now, the other thing to also appreciate in this instance is that you have some evidence of esophagitis. So again, you can see this area of, if we go back to white light, please. If we go back to white light, you can see this area of inflammation right above the top of the nodularity. Again, you can see this here. I would probably grade this as Los Angeles class B.
Wow. I have a question to you, Prasad sir.
Yeah.
Like, if there is somebody with inflammation and Barrett's, would you treat him for 8 weeks before you reintrospect? Because we need the inflammation to go and not interfere with Barrett's diagnosis. What do you do?
Absolutely. I think this is a great point, particularly in the presence, and I think what Dr. VGM is talking about is if there is a lot of inflammation in the tissue, the identification of dysplasia by pathologists becomes challenging.
Absolutely.
So there is inflammation related atypia. And but in this instance, I'm told that the patient already has confirmed low-grade dysplasia, and in the presence of some nodularity, I would feel comfortable resecting this patient.
Absolutely.
If this was the first time I had ever seen the patient, I would probably bring the patient back after 8 to 12 weeks of high-dose PPI therapy to suppress the inflammation, heal the esophagitis, and then do a resection.
Sure. So what is your plan now? What are you going to do with this?
So I think given the presence of low-grade dysplasia and inflammation, we can proceed with cap-assisted EMR in this instance and see what histology shows. So
We can pull back and then we can remount a cap-assisted EMR.
Yep. So we're going to pull out here and get ready with our equipment for band EMR in this instance.
You can hand over the, okay. He can load it and give it to you. Yeah. So Prasad sir, I have a question to ask you. If you see a lesion like this, is it necessary that you have to go with ESD or is it enough if you do EMR? So what are the challenges, positives and negatives?
I think Dr. Leggett just sort of went through some of this, but essentially If you have smaller lesions, the goal of both of these is similar, right? So instead of taking pinch biopsies, you're giving the pathologist larger chunks of tissue. The question is how large? And I think if this were a cancer, I would probably want to do ESD as opposed to EMR in order to make sure that we get clear lateral margins and we are able to get good deep margins. The second criterion I use is size. So if you have a lesion which is say approaching 20 millimeters or larger, you're likely to do better with EMR because then you can do end block resection. With ESD because you can then do end block resection.
Yes.
If there is scarring, inflammation, scarring, the patient has been ablated, or
ESD
there's
is going to be
biopsy related, then I think ESD is going to be more helpful because with EMR, you're going to have trouble lifting the lesion as well.
But
So those would be some of the things.
The same challenge will happen even for ESD because I've been doing ESD for almost 20 years.
Yeah.
So if post biopsy fibrosis, the lesions don't get lifted very well.
Yes.
Even in ESD.
But with ESD, you have the advantage of, I think, even if the lift is not the best, but you can still apply some traction. You can get into the submucosa and slowly dissect and get the lesion off. With EMR, the band is just not going to hold.
Absolutely. That's true. And again, do you snare above the band or below the band or doesn't matter?
I actually try to snare below the band.
Yeah.
I actually try to snare below the band.
And what are the chances of perforation to the youngsters? Is there a chance perforation here? What is the rate or zero? The EMR, band EMR per
It's never zero.
Yeah.
It's never zero.
Okay.
Sorry.
But we, in our experience, have never had even one perforation because of band EMR in Barrett's. So
yeah, so band EMR is technically safer than cap and snare EMR for the simple reason that the band is elastic and theoretically it does not, even if it were to grab the muscularis propria, the muscularis propria has the ability to slip out.
Absolutely.
That is the point. Once you put
point.
the snare on, then you grab the muscularis propria and you will cut through if it is caught.
Absolutely. So that was a very valid point because these bands under suction is inadequate to take the muscularis propria inside. So the band, even if it holds the mucosa, submucosa, muscularis propria, as Prasad Iyer sir was pointing out, the muscle layer will slip out. So what is going to remain as a polyp because of the band is going to be the mucosa, at the most the submucosal tissue. So you're safe to use a snare, even cut below the snare. Why is it cut below the snare? Sometimes if you cut above the snare, then it may be inadequate. You might still leave some tissue behind. So to the young friends who are watching this, I'm sure you can safely take up these patients for a band EMR. Now we have 6 bands, the Cook type of bands, loaded on a hood, transparent hood, and he's ready. He's just focusing on the abnormal area, which is the raised area Paris 2A at 6 o'clock position. That will be the first band that he's going to put, and he's going to use snare. Would you use a US endoscopy snare? USC? What snare do you want? USC snare. Okay. A USC, US endoscopy, the mini snare is very good.
So I think the snare is the injection. The needle is not going to go through this.
Okay.
So
okay.
we'll switch, inject, and then come
inject.
back.
Yeah.
So one of the debates in band-assisted EMR is whether you should inject or not inject. And a number of my colleagues would argue that you don't need to inject for band EMR.
Absolutely.
For precisely the reason that we talked about before, that the muscularis propria is going to slip out. Now, I belong to the school of thought, and I think it all depends on how you were trained. So I was trained to always inject.
Wow.
And the reason for injection is that if you get a good lift, then you know you are above the muscularis propria. Whereas if you don't inject, then there is a possibility you might actually grab the muscularis propria as well. So I think it depends on which school of thought you are in. So in this instance, we are going to try to inject, and unfortunately we had to change our scopes because the injection needle would not go through the endoscope
ligation
that we had.
Cylinder.
Now, the other thing I also have to tell you is that typically when I do band EMR, I would use the Duet EMR kit.
Yes,
So the
obviously.
advantage with the Duet EMR kit is that you can band, you can
And-
inject, you can band, and then you can
snare,
pass
and
the
snare.
snare through the same through the same piece of equipment without coming out. In this instance, I don't think we have the Duet EMR kit here.
You know, we always have in our unit, but not today.
Yeah,
We run
yeah.
out of it, so that I'm
So
really
I think
sorry.
I think what we will end up doing is we will inject, we will then go in, band, come out, and then go back
Again,
in
go
with,
back
with,
in
a,
with
with a
the
snare.
snare.
So we'll make it work.
I'm sure, but it takes time, so that is the only problem.
Sir, we will play Sharadin's video, sir.
Sure.
Thank you, sir.
Yeah, definitely. And then we'll come back, friends. As we are injecting, we'll get back to you.
Yeah, thank you, sir.
Thank you. They're playing your video or what?
Good afternoon, everybody. I'm Dr. Saransh Jain. I'm from Bhopal. And thank you, Dr. VGM, for the kind invitation. I would be talking about non-obesity uses of endoscopic suturing. So we would be covering this talk in the following outline. We will introduce you to the Apollo endoscopic suturing device, and we'll discuss some cases regarding its use in closure of mucosal defects, leak,
Sir, we will back, sir. Sir,
Yeah,
your mic
thank
on, sir. We will
Thank
back.
you. Yeah, we are sorry for this confusion. I think that video is on non-ESG, non-obesity ESG use of Apollo overstitch. That's a stitching technique which you will see later. We're going to move to obesity in a few minutes, and then
Okay,
we'll watch that video later on. So now we're going to inject. See, so what he does is he
Inject one,
just, see, he
two,
just brings out the needle and asks the technician to bring out
needle
with
back.
the fluid. This has got, you put in indigo carmine or what have
Yeah,
you
so
put?
this is 1:100,000 epinephrine
Epinephrine
with,
and
some methylene, with some indigo carmine.
yeah.
Needle out. Okay, one more.
So you should not go
hold on,
perpendicular
hold on.
to the mucosa and inject. All injections should be at 30-degree
Needle out.
angulation so that you inject into the submucosal plane. The idea is to separate the
Okay,
muscle
one more. Yeah,
muscularis
excellent.
propria from
Okay,
the
stop.
you know
Okay.
the
So you can see needle
dissection
back.
plane.
Yeah.
Yeah.
Very good. So what we will do is maybe we'll inject this side as well. So you can see we got a good lift, and that makes me comfortable injecting, resecting, and needle out, please. Okay, go there. Give me 1, 2, 3.
Any tricks of how to get a good lift while injecting?
4. Yeah, just a minute. Needle back. So I think the first trick is, as you said, don't be parallel. You want to be at 30 to 40 degrees. The second trick one could use, that's good enough. So let's switch our endoscope. The second trick is sometimes to actually inject as you are going in to find that plane. And once you find the plane, I also tend to move the needle back and forth a little bit
Just
to
jab
find
it a
that
little.
submucosal plane. So as you can see, we have a good lift here. So we'll withdraw this endoscope and then come back in with the banding device. Yeah, so I think those are some of the things that I would use to make sure that. Excellent point. So if I'm able to do everything with one endoscope, then I tend to inject, resect, snare, inject, band, snare. I tend to do it that way because sometimes it takes us longer to resect in a certain area, and by the time you move to the second spot, the lift would have subsided. But in this instance, our equipment is not all aligned, so I just injected the second side. So we are just getting ready with the second endoscope back again. So the other thing I always make sure, just a little bit, yeah, is that my, so we have the 6-shooter bander here, and I've made sure that I'm on 2-way, not on the firing mode. And I don't know if you can actually show this
Camera
here.
can focus on this, on the wheel.
So you can see I'm actually on the 2-way here. Let me just see if I can.
Yeah, it can rotate in both directions.
Yeah, so now you can see that I can either be on 2-way or I can be on the firing mode. So when I'm intubating, I actually like to be in the 2-way so that I don't accidentally fire the band
Absolutely.
as I'm going in. So again, we'll go in now.
This applies for the variceal ligation also. Always you should ensure that it's not in the firing mode and it's a 2-way rotatable mode. So
Can we get the lights down a little
yeah.
bit, please? Okay.
So now Prasad Iyer is satisfied that the lift is good and we are not going to band the muscularis propria. So yeah, that's enough.
Yeah,
enough,
that's
enough.
good. Thank you. So again, we'll try and get this side. So the other thing I typically like to do it's important to position this the best possible way. So again, we'll try and lift this. And again, I think going back to our discussion about scarring, this area is fairly inflamed. So as you can see, it is not, even though we got a good lift. So here I'm suctioning gradually, getting into my
the firing mode, and then he's continuously applying suction and also probably a little bit of torquing. Still, this is not lifting very well. So probably this is post biopsy. Could you take it a little bit away, sir, instead of doing that, the ridge, get some little normal tissue this side and probably that'll engage it. Yeah.
Just like that.
Now you'll probably get it better. So because that is a biopsied site which has gone in for a fibrosis maybe. So he's just continuously sucking and then now he's applied a band. So that area has come out very well.
So you can see, you can actually see this nicely. And now we'll come out and go back in with the second snare, second endoscope.
So next case. Oh, very sad.
I think if you are absolutely confident this looks dysplastic and you have expertise in EMR, it's reasonable to do EMR. It never hurts to take a biopsy, but I wouldn't biopsy extensively, because if you biopsy extensively, then you might end up causing more fibrosis and then your EMR is going to be difficult. So couple nice biopsies, targeted biopsies are all you need. And then you can, if you show dysplasia, then you can always come back in for a EMR. So again, if we actually had a The duet kit, we would have a hexagonal snare. In this instance, we are using a regular snare. Open, please. Close, please.
Close.
And again, I'm trying to, yeah, start closing, closing, closing. You got it? Snug? Okay. So
Now we are using Irby Bio. So cut coagulation, how
cut,
much?
please. Cut, please.
Yeah. So cut mode power 3 and coag mode power 4. This is a polypectomy, snare polypectomy setting that
you
we
can
have
see
used.
the site looks
Yeah.
good.
Yeah.
You can, the blue is very reassuring. Now, how do you, typically I would have a rot net to remove this.
Yeah,
but
we have
if
a
you
rot
have
net.
we can get
We
it
have
out
a
with
rot net, yes.
Now
to
the
remove.
other thing we can also do is inject that. We injected the other side, and we could do a band EMR of that side as well.
Sure.
If you need to. So can I get a little bit more injection first? We'll inject one more time. Since I'm here, I'm just going to use the opportunity to inject one more time, get a better lift. Needle out.
After this, we will demonstrate
Okay,
also the
so then
collagen
1,
spray.
2, 3.
Post resection,
Thank you. Needle
will
back.
really help to heal the
Okay,
lesion
good.
faster. Make the
So,
patient
rot net, please.
eat even hot foods quickly. So after your resection, I'm going to show the collagen spray.
Okay, good. So again, there are different ways of doing this, but open the net, please. So we are opening the net here. Yeah, close, please. Yeah. So we got this. Yeah. And again, we can probably show you what this piece looks like. If you have a gauze piece, we can actually put it on a piece of gauze, clean gauze piece, please. And yeah, you can just put it on there. Yeah, yeah. And take this out, please. There. Yeah. And you can actually see the base of the EMR site here. And if you can turn it over, please. No, not turn one. Yeah. And this is what the surface looks like. So again, much bigger than a biopsy site. And again, you can see the pathologist can now look at the margins. They can look at differentiation. Yeah. And in about 30% of these folks, when we resect low-grade dysplasia, they will come back as high-grade dysplasia. Okay. So
can we also demonstrate the fixing? You have some. Yeah, we can switch
so we'll
the
switch
endoscope.
scopes.
You leave it here. Can I? Switch the scopes.
Band, back to band. Any questions, Dr. BGM?
Yeah, actually, we don't inject. We just band and snare. So we have never had any problems so far. And then what happens is post resection, post EMR, post EST, wherever we resect, even in arms, arma, we use collagen spray. So this endoscopic collagen spray was my invention way back in 2011, 12. So it is taken from the egg cell membrane.
I see.
The chicken egg cell membrane. So which is very strong. It's this collagen is a helical protein. So once you spray, it just forms a coating on top, which just immediately allows the platelets to come and adhere. And usually this fibroblasts and all come in on day 5 after a mucosal injury. But here it is hour 0. Immediately, the collagen is deposited there. So the healing process can start, the platelets adhere to form a plug, and then the epithelial cells can migrate onto the edges and then start, trying to line up these lesions. So that way, it's a great asset. So, and patients can take hot liquids even within 6 hours of doing the procedure. So we always do post EMR, post EST. We always do that.
So again, I'm trying to reduce any overlap or a ridge here. So we will fire the band. We'll come back out. Just sedation.
Yeah.
Suction. Can you suction him? Please?
Suction, throat suction. Suction catheter. We are doing this procedure under IV propofol sedation. So whenever we anticipate a prolonged procedure, then we can actually, go for an intubation and general anesthesia. But we thought this could be a quick procedure, but unfortunately, we didn't have the device of 3-in-1 where you can inject, you can band and snare. So that makes life easy. So now we are taking more time because of this setback. So now Prasad Iyer is going back to with the endoscope to resect this endomucosally, and then he's going to retrieve it using the Rothnet basket of US endoscopy. So Rothnet is again a very good device which is very useful to get any bizarre objects. So with a very good hold. So I think all different sizes of Rothnet baskets are available. I think every unit should have some fishnet basket. So in this instance, we are using the US endoscopy Rothnet. So now we are ready with the snaring of the second polyp.
Okay, open please. Okay, close please. Yeah, close. Okay, you got it. Okay. So again, we have the polyp. Cut please.
So do you always coagulate first and then cut?
Yeah, I like a little bit of coag. Take that please.
So just to seal the blood vessel so that there is no ooze.
Yeah.
I think that is a beautiful resection of the area. So which is going to use now the Rothnet to remove. And then we straight away in 2 minutes we'll just spray collagen. So which is supplied by Shaili Endoscopy in India. It is not marketed to the rest of the globe. So this is still on a research mode which is going on. So
open please. Close please.
Yeah, that is a good grab. Now we are out with our harvest. Now quickly, I'm going to show you the collagen spray and then we'll move to the next talk and then we'll move to the next demonstration.
Thank you.
Good afternoon, everybody. I'm Dr. Saransh Jain. Thank you, Dr. VGM, for the kind invitation. I would be talking about non-obesity uses of endoscopic suturing. So we would be covering this talk in the following outline. We will introduce you to the Apollo endoscopic suturing device and will discuss some cases regarding its use in closure of mucosal defects, leaks, fistulas, and fixation and perforation. When we talk about suturing, suturing is basically a surgical concept. We all got introduced to suturing during our
Sorry for the interruption, folks. This is the base, and we just wanted to check for two things. One is a bleed. The other one is whether we have included only submucosal plane and not the muscular plane. So very clearly, this is submucosal tissue where we injected the indigo carmine, and then so it is clean base. So with no leftover Barrett's tissue, so it is a complete resection. So now there is no signal here, but we are getting it there. No problem. Okay. Can we go ahead with collagen spray? So we just first use air or carbon dioxide to flush the channel so that collagen can get completely get clogged in the catheter if there is moisture in the lumen. So we just try to do this. This is a simple device. So where the collagen is loaded into the bellows. I think you can see the bellows here with loaded with collagen and a syringe cartridge. So now we're going to introduce this catheter, so which will pass into the endoscope working channel now, and very quickly we can spray and then come out. So the chemo spray of Cook is not available in India as yet. So we've been using this collagen spray on a research protocol for the past several years now. So yeah, we are ready to spray now. So I'll just get back to the site of the lesion, and there we are. So yeah, now we can start spraying. So it get a snowstorm effect like you do with the Cook's hemoseed spray, but I think that is enough. We have covered it.
So VGM sir, is this more for hemostasis or more to prevent stricture formation or both?
Yeah, this is actually both, and then also, it helps a patient to take a hot coffee within 6 hours. So otherwise, they'll develop odynophagia because there's a raw area where the mucosa is completely denuded. So that's what I was trying to say. We are finished with the demonstration here. So what I was trying to tell you is that once, like there is a mucosal injury that happens, it takes day 5 for collagen to be the fibroblast to move in. So here we are giving collagen on hour 0. So immediately what happens, it forms a helical matrix on top of which the platelets can adhere and start the process of healing right away. So this way it forms a coagulum on top, and which can prevent people from reacting to acid reflux or any hot liquids going down. I've had we've been using for all EMRs, ESTs after all resections we always use, and any mucosal injury, ulcers, ulcer with clean base, used in all those situations to accelerate healing. So that's a good demonstration, Prasad sir. I think please give a round of applause, all of you. So for a beautiful demonstration of EMR. Now we move to the short talk by Sharansh Jain. It's my pleasure to introduce Saransh before we move on to the video. Dr. Saransh Jain is from Bhopal. His father was a veteran senior gastroenterologist. Unfortunately, is not no more with us. Saransh is a lion cub doing wonderful procedures, doing a lot of endoscopic sleeve gastroplasty and other procedures. So we are in to listen to Saransh first. Where all can we use endoscopic suturing other than the endoscopic sleeve gastroplasty? After that, he'll be formally introduced by Dr. Vamshimurthy. So over to the lecture by Saransh.
Good afternoon, everybody. I'm Dr. Saransh Jain. I'm from Bhopal, and thank you, Dr. VGM, for the kind invitation. I would be talking about non-obesity uses of endoscopic suturing. So we would be covering this talk in the following outline. We will introduce you to the Apollo endoscopic suturing device and will discuss some cases regarding its use in closure of mucosal defects, leaks, fistulas, stent fixation, and perforation. When we talk about suturing, suturing is basically a surgical concept. We all got introduced to suturing during our surgical residency days in our undergraduation. Hence, being a surgical concept, principles of surgical techniques apply to it immensely. The first being asepsis. There should be gentle tissue handling, effective hemostasis, maintenance of sufficient blood supply to tissues, proper use of surgical instruments, and accurate tissue opposition. Wherever you are doing suturing, whether it being for an obesity purpose or a non-obesity purpose, the principle of surgical technique should always be kept in mind and followed. When you see this device, it is basically a suturing device on top of an endoscope. There is a suture which is toggled between the handle and the needle exchange catheter, and there is a helix which pulls the tissue in between this handle so that we are able to take a full thickness bite. When we are doing a procedure to close the leak, fistula, or perforation, we start at one edge of this defect, use a bursting suture, drop the T-tag when our device is reached to the other position, and tighten this over a cinch, leaving behind the closure of defect. We can use it to close the mucosal defect after entry in third space endoscopy. In this case, the patient underwent a GPOM and there was a defect which needed to be closed. Traditionally, we have used endoscope clips. However, when the mucosa is thick, like in this case, the difficulty arises in holding the clip. Here, we are using a rat tooth grasper instead of a helix to pull the tissue inside the handle. And using a bursting suture, take from one edge to another, taking distal and proximal edges one after another. Once we have reached to the other end, we take this final bite into the proximal edge and drop the T-tag. We tighten the suture and use the cinch to close the defect. This was a case in which we used endoscopic suturing for closure of large tracheoesophageal fistula. This was a young male who had road traffic accident, long-term tracheostomy, and subsequently developed tracheoesophageal fistula. You can see during the initial endoscopy itself that this is a very large tracheoesophageal fistula. Even the scope can be easily negotiated into the trachea. So, to treat this type of fistula, first we need to raw the edges. Here we have used gold probe. We can use any other method so that we have a long-term opposition. Once all the edges have been used, we use a suturing device to suture these edges together. We start at the distal edge in the lateral wall. After taking the first bite, we go back to the proximal wall. You can see how large this fistula is, and it is very difficult for any other method to hold this type of fistula together, whether it be an Ovesco clip or a fully covered stem, which were the other options in this. We take the second bite in the proximal edge, and the third bite we take is just medial to the second bite to create a bursting suture. While doing suturing in esophagus, it is usually done without an overtube. we go back to the distal edge of this fistula and take our final bite lateral to the first bite. After taking this final bite, we drop the T-tag and tighten the suture over this fistula, thereby approximating the edge of the fistula. After tightening the suture, we use a cinch to keep this tightened suture in place. We can use this device for stent fixation. Fully covered metal stents have been used in treatment of benign esophageal condition. A common problem with these stents is migration, and we can use a variety of devices for stent fixation. Suturing is one of the devices that can be used for stent fixation. Here in this image, we can see a fully covered metal stent. We take the first bite in the mucosa, the second bite to the stent, third bite into the mucosa, drop the T-tag, and use a cinch to fix this metal stent in the esophagus. We can also use suturing devices to treat perforation. But when treating perforation, it is important to recognize whether they are spontaneous or iatrogenic. What is the duration of perforation or delay in presentation? What is the site of perforation? Is it accessible to your suturing device? Whether it is a clean or an infected perforation. Suturing can only be used in clean perforation, like this, where an ESD was done with suspected perforation and a suturing device is used to close this defect, or in this small defect, which is the clean perforation in the stomach. Coming on to literature review, the study in endoscopy for endoscopic suturing to prevent stent migration in benign upper GI condition found out that in 125 patients, benign stricture, leaks, fistula, and perforation, fully covered metal stent was used. Stent migration was more common when it was not fixed. And also when it was fixed, the time to stent migration in those did it migrate was longer. The rates of adverse events were similar in two groups. Hence, suturing can be used for stent fixation in a safe manner with good clinical success. This is a multi-centric European registry for endoscopic suturing for GI application. Here, 9 centers did 3-year follow-up. They took 137 patients and they were able to successfully perform endoscopic suturing in 136. There were no adverse event reported and overall clinical success was 89%. Mucosal defect was closed in 32 patients with 100% success. Leaks in fistula were treated in 23 patients with low success. Clinical success of stent fixation was 85% and perforation were repaired with clinical success of 94%. Fistula, especially when fistula was less than 1 centimeter, continuous suturing was better than intervention. AGA gave last year clinical practice update on management of perforation of GI tract and summary regarding esophageal, gastric, and colonic perforation is that if it is more than 2 centimeters, endoscopic suturing is the preferred option. However, right colon access is limited as the device might not be able to reach the site of perforation. To conclude, endoscopic suturing is a welcome armamentarium in toolkit of an endoscopist. Overstitch based suturing is technically feasible regardless of site and method of suturing. Overstitch technology provides reliable suturing with clinical advantage. However, basic surgical principles must be kept in mind and always followed while taking up a patient for such advanced intervention. Thanking you. Thank you.
The endoscopic sleeve gastroplasty is a non-invasive endoscopic procedure designed to reduce gastric volume. This animation provides an overview of the latest technique. A coagulation device, such as the argon plasma coagulator, is used to mark the anterior and posterior walls of the stomach along the greater curve. This creates a guideline for the first outer row of sutures. The first row of full thickness stitches is placed from distal to proximal. A running triangular suture pattern alternates from anterior wall, greater curve, posterior wall, and is repeated for 5 to 6 bites. The anchor is then released and the stitching sequence is cinched tight. The triangular pattern is repeated. A total of 5 to 6 triangular running stitches are repeated in this first row. This suture pattern is designed to maximize the reduction in stomach volume and foreshorten the greater curve. A secondary inner row of interrupted or running stitches is placed following the lesser curve to create the sleeve effect. These plications extend up to the gastroesophageal junction just below the Z-line.
Vamsi sir, your mic on, sir.
The way, can you show us? We are not visible, I think. You can remove the slide now. Yeah. Hello everyone,
Hi.
welcome back. Today we have a celebrity coming from all the way from Bhopal, Dr. Sharans. He's an excellent human being and fantastic endoscopist. He did his DM in gastroenterology from AIIMS, New Delhi. Now he's practicing at Jain Shriram Hospital at Bhopal. Later on, he was trained in bariatric and metabolic endoscopy at in United States at Brigham and Women's Hospital, Harvard. Over to Dr. Sharans to teach us what we can do for people who are obese and how to help them.
Hi, thank you, Vamsi, for that kind introduction. And thank you, Dr. VGM, for that kind invite. And I'm very happy to perform at this state-of-art facility in Coimbatore. So we have a patient with us who is obese, weight is 128 kg. She is having pre-diabetes, she is a hypertensive, she's a hypertensive, hypothyroid, she has osteoarthritis, basically having metabolic syndrome. She has tried multiple weight loss management tips and tricks, types of diet. Nothing is working for her actually. Her endoscopy is basically, we are presently doing the endoscopy. So if you can please share the endoscopy images with the audience, we will be able to, we will be able to, So we are presently in the duodenum. We have done a normal upper GI endoscopy here. She was scoped previously also.
Yeah.
So I'm just rechecking the scopy. So we are in the duodenum. We're coming back. This is the antrum. And this is the stomach that we are going to deal with today. So CO2 is on. Just check.
CO2 on.
No, I am not using it. So sometimes it gets off.
So why is the screening endoscopy always important?
Yes. So there are a few advantages of a screening endoscopy in such patients. You see, every procedure has its indication and its contraindication. So definitely a procedure to reduce the weight is indicated in this patient. And she needs help. She cannot do it alone. Sorry. Can I freeze this image? Yeah. So looking at this stomach, this is a big stomach.
This is what I call a C&E maneuver. You need to look at the incisura. This incisura is where you can come from here. And this is the point where the greater curvature meets the anterior wall. This is the anterior wall, and this is the incisura. Above this is the body of the stomach, and beyond this is the antrum of the stomach. So we are going to be mainly working in the body of the stomach. We are going to start from here and try and reduce the greater curvature of the stomach so that the volume of the stomach gets reduced. So here, 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 and here. This is how we are going to work for her. While we are doing the screening endoscopy, we would like to look for any gastric ulcers if they are there. You can look at me. That's it. We also want to look at sometimes like duodenal ulcers which are present. We can also look at the fundus. We need to know whether she has hiatus hernia or not. Obesity, by the way, is also a predictive factor for hiatus hernia. She does not have any hiatus hernia presently. We also would like to look for any evidence of reflux disease. And we also want to know what is the GE junction. So these are the advantages when we start doing endoscopy for such patients. The GE junction is at 43 centimeter presently. When you look at the patient, if you will show her lower part of the face, you can see that I have put in an overtube. Now this overtube serves me a purpose that it allows me to introduce my instruments without causing any sort of injury to the upper esophagus. So this is the overtube that I have placed, and this is a very special overtube as it can have inflation of the balloon which is placed inside this overtube by air, so that there is no air leakage when I am doing the procedure. Now I am going to demonstrate to you the instruments. I'm going to change it over to a double lumen scope, and I'm going to demonstrate to you the instruments that are being used for endoscopic sleeve gastroplasty.
Olympus guys, one man should be there. Olympus.
So while the scope that we are going to be using is a double lumen scope, it is a 2T scope. We are going to be using a 2T 180 scope from the Olympus. This is the overtube that I discussed with you. This is a
Olympus.
flexometallic tube.
Yeah. Okay.
It has a
2T
port.
scope. Okay. Okay.
Which can be used to inflate the balloon which is inside. You can see that the balloon, when inflated, narrows the lumen to the lumen of the endoscope so that there is no leakage from the side of the endoscope. And we can reduce and increase the air so that to modify our filling of this balloon. We have already inserted this overtube. This is a spare one that we had. Now we are going to use a device from the Apollo Endosurgery which is known as a overstitch suturing device. This overstitch suturing device consists of three components. One is the handle. This handle is applied to the 2T scope. It has a component at the tip of the scope which is known as the driver. Now when we close this handle, the driver gets closed, and when we open the handle, the driver gets open. This driver takes and gives back the suture, which is the non-absorbable polypropylene monofilament suture. It is marketed as Fill Block here and by Apollo Endosurgery, and it is a suture which has a unique part to it, that the tip, the driving needle is attached to the middle of the suture rather than to the end of the suture, thereby allowing it to toggle between the handle and something which we call as a needle exchange catheter. When we look at the needle exchange catheter, this is a catheter which can handle the suture and give the suture when pressed, so that the suture can toggle between the driver and the needle exchange catheter, just like a sewing machine, so that we are able to sew the stomach, reducing its greater curvature. We have something also known as what is known as a helix. This is a helical structure which is used to screw in the tissue and pull the tissue towards yourself, and then this tissue can be used to take the bite. I'm going to assemble this structure over the endoscope and then going to show you how we can transfer the suture outside, and then we are going to start the procedure. So just for information, the patient is intubated in left lateral position under sedation and paralysis in general anesthesia. So this is the position. This is a procedure to be done in general anesthesia, not in conscious sedation. Though you need the patient to be sedated and paralyzed with the whole suture load. So the first thing is we are going to use the handle to attach it to the endoscope. The tip of this the tip of this handle goes in the bigger channel, and then it is fixed on top of the scope like this. Gotcha. Hold. Once we have this handle over the, you hold it here. Yes. Handle attached to the scope. We load the needle on the needle exchange catheter. Note the needle on the needle exchange catheter and insert the needle exchange catheter through the big hole while the assistant is keeping the suture to the one side of the needle exchange catheter. Once we have reached up to this point, we'll insert the helix in the another port. And now we can shift to the endoscopy view, and I can tell you how I load and unload this needle. You can hold it here on. Light on.
Lamp, okay.
Yeah. So now I close this driver. I attach the needle exchange catheter to the driver. I leave the needle from the needle exchange catheter, and then
endoscopy image menu.
So you have to focus on my hands, and the audience needs to have two views. One is the endoscopy view and another is the hand view.
You need endoscopy view. Endoscopy view. Yeah. Yeah, that's great.
Now, so I will start again. So this was the position when I have loaded the device, and I am finding that the needle exchange catheter looks like in the endoscopic position like this. We close the device, we attach the needle to the handle, we leave the needle from the needle exchange catheter, and then we open the device. So you have seen that the needle has now been transferred from needle exchange catheter to the handle. Then we take in the tissue. Once we have taken in the tissue, we take the bite and then re-give the needle to the needle exchange catheter. This is one cycle of bite that we are saying, and we are taking multiple bites in a U-shaped pattern, starting from the incisura, then the greater curvature, then to the posterior wall, and going back from the posterior wall to the greater curvature and to the anterior wall. Once we have done this, we will do something which is known as cinching. Cinching is something to tighten the suture and keep it in place. Once I finish the first layer, I will go back and demonstrate the cinching to you. Now I am ready to insert the device.
You need some jelly.
Deflate करो. आजो. So we will be applying xylocaine jelly, but not to the tip of the device, just proximal to the tip of the device. We will deflate this balloon. go in with the driver closed. The patient is out.
No, she's fine.
She's out. She's out. We need to inflate 7 ml.
No.
So now we have reached up to the end of the over tube. Now this is an important point to negotiate. Here, if you push in blindly, there is chances that the esophagus can get damaged. So what I like to do is I would like to inflate a little. Once I inflate a little, I can see the way now. Then I go slowly. That's it.
CO2 is fine.
CO2, let me see. Just relax.
Yeah.
Into the stomach. You have a water jet? Yeah. No, not like this. I need a proper water jet. I need a proper water jet. Just do it when I not right now, but within few time. No, thank you. Right. That's it. So now we have cleared off that mucus which was there.
Yeah. Brightness increase. Yeah.
Yes. Manual max. Manual.
Manual.
Max. You're able to understand?
Yeah.
Yeah. Now. So now we are again to that position where I was telling you, Alexa. So this is the incisura, this is the greater curvature, and this is the posterior wall. So we have to begin at the junction of incisura and the greater curvature. The good landmark that I feel is for the body of the stomach is the fold end when the body meets the antrum. So you should go likely here, out. Wait, 3 हुआ हाँ. So नहीं हुआ. Pantosit 40 mg, Dexa 8 mg, PCM 1 gram. So out. Screw 1, 2, 3, थोड़ा सा और आधा. So we have screwed in the tissue from the junction of anterior wall and the greater curvature. We'll bring in the tissue. Bring in the tissue towards us, creating a complete red out. We'll close this handle and take back the needle from the driver. We will again open the driver, unscrew the helix, and then push out the tissue that we have taken. Water jet. Somebody else to bring it. But that's it. Okay. Thank you.
Wow, that's excellent. I think this is an excellent full thickness suture. Which
no, we have taken a full thickness suture, but what I'm seeing here is, I think I have crossed my suture.
Okay.
So the crossing means that that there is crisscrossing. I am actually not able to have a very good vision over here. Just remove this thing. I will suction a little and nikal de. Okay, now. दो हेलिक्स डालो. So When the trailing and the leading part of the suture cross each other, that is what we call as a crossing. So once the suture is crossed, we do a maneuver. I need a vision. Vision is not good. We do a maneuver to uncross the suture. So we push out the needle exchange catheter, do up, move the scope to the right, and then down. Vision is not good. No, vision का issue है.
You have some okay. Bubbles நிறைய வருது. Okay. Not knob நால இல்ல அது. Okay. He wants a better water jet, is saying.
Okay.
Now
once we have cleared this vision, I will just get back to just a second. Let me clear the vision. Okay, now we have cleared the vision. Now I would like to tell you that where we went in and how we came out. Yes. So we went in through here and we came out through here. This is around 1.5 centimeter. This means we have taken a full thickness bite. And the suture lines are parallel to each other. That means the suture is not crossed. Now probably we can go in for the next bite. For that we need to load the suture again. We'll load the suture, we'll go in and we will try and take this position. डाल के रख लेते हैं ना. Out. Wait. Unscrew. So again we have crossed, we move up to the right and then down and uncross.
No better. I think we had some difficulty in the vision now.
Yeah, because I
some
think
help
this,
from Olympus guys, now the
I
vision is
think
much better.
this was due to the fact that we had this air-water channel issue. Now it has been resolved. Now the vision is absolutely good. So I don't like to keep a lot of air in. I like to see the folds. If you put too much air in, you distend the stomach and you don't see the folds. That is when you try, the wall gets thinned out and you get outside structure inside. Out.
And also excellently you have demonstrated how this cross which happened, how we can tackle such situations. What we can see is he's waiting for a red out and then immediately he's trying to go ahead with the suturing.
एक सेकंड रुकना भैया रुको yeah, unscrew. ठीक है. So we have taken the third bite. I don't count the number of bites. I like to count just the direction that we are going in. We are going in right direction. We need to take the greater curvature now. Out. Bas half वापस. I like to keep this red out. Like most of us are gastroenterologists, we have done endoscopic banding, and a good band is when you have the red out. So this is, I like to keep it so that I know I have adequate tissue in place. So I have started from here and I have now reached here. Now my aim is to go here, here and come back. Yes.
Somewhere at 5 o'clock and
Yes.
4 o'clock.
Now we will go at around 6 o'clock,
6 o'clock.
like
Okay.
here.
Yeah.
So pulling and pushing. It's a common thing. You go back, you see what you have done. Go forward, do again another one. Go back, see what you have done. Out, out. Wait. Yeah. So this was the last bite. This is the next bite that I'm going to take. Out. एक आधा screw और कर. बस. आया नहीं.
Sir, एंगे BGM sir.
हाँ. Now. Out. करो.
No, I'm moderating to
2, 3. Gauge piece.
So Dr. Sharans, what is the learning curve for starting ESG?
I think there is a way to start it.
Okay.
First, you need to get accustomed to the accessories.
Okay.
You need to know how your accessories are functioning. It's a new accessory. It's not usually used in any other devices that we do training on. It's a different approach. So first thing is accessory use, which can be easily done on the animal models.
Okay.
So while I was talking to you, I actually dropped my suture. So this is what happens when you leave the suture and you're not engaged, or you are trying to talk to somebody while you are doing a procedure.
Wow. No, it's
so
it's like,
I could not complete my U, but I have a sizable chunk.
okay.
So I will cinch it
Cinch it
here,
here. Okay.
and then I will try and finish off my bite with the next suture.
Also always nice to see the difficulties which we face while doing such complicated procedures.
So
Now
it
we
should
have the
not
big
have
man
been a
itself.
difficulty. We had a great vision. Everything was there. So we will cinch it. Had it been a full U, it would have been a even better cinch. So what we will do is we start from here and complete this U and take another one.
Great, great. Saransh, you drop the cinch, right? Not the suture.
No. We drop the T-tag of the suture, and then we are loading a cinch on top of this dropped suture, so that it can tighten the suture with, and then it can keep the suture in place. Wait.
Handle.
So I will tighten the cinch. It takes some time. The suture has to run through the stomach. These are full thickness bites. It goes through the muscle. I like to use my thumb as a gauge of pressure that I am putting in.
Wow.
And then I cinch. एक और load कर लो. So go again. But even with this
It looks
half,
nice.
it
Looks
looks
nice.
that we have reduced some part of the greater curvature. We will go again and we will take a full U, and we will reduce it in U's till we reach the fundus. So the common question that I get asked is, how many sutures do you use? I use as much as the stomach tells me to do. I average 4 to 6 sutures per procedure are minimum that is required. Because if you do not do reinforcement, so sir is from Mayo, Baram does a lot of reinforcement. So if you do reinforcement, you double the number of sutures. So, okay. So reinforcement is, I will do one at the end. So I will tell you what a reinforcement is, and definitely we will be finishing, don't worry. नोट किया ना अच्छे से? गॉज दो, हेलिक्स दो, चलो आउट करो, आउट, गॉज, ये हेलिक्स में वो लग गया, आउट, आउट, आउट है, हाँ करो, अनस्क्रू, गॉज बड़ा चाहिए, बिग गॉज, पैड होता है, पैड होता है, हाँ उसका नाम ही पैड होता है एक्चुअली. Out.
So again, they are repeating the same steps.
Yes.
With the help of helix, they have got in the tissue, waited for a readout, and trying to apply the full thickness suture. And when there is crisscrossing, we always...
So there is no crisscrossing, they are parallel?
Now there is no crisscrossing.
Out. No, sorry. किया नहीं तुमने. Out. करो.
They are trying to get the tissue using a helix.
आधा बाहर कम करो. आधा कम करो.
Now they got the tissue and again applied the full thickness sutures.
Out. आधा कम. So there are a few people who actually also do the first one only straight line rather than a U. I don't do it usually, but there are a few people who do it because they say that the first one is the base. It needs to be the strongest. So if you have to do a base, you give them more strength by doing less number of bites. Not proven though. All suturing patterns have reported equal efficacy. So you can do box, you can do U, you can do other shapes. All of them have equal efficacy. The only thing that has proven is the compliance of the patient to the post-operative diet that you give. So this is very important to understand. Out. करो. आया? हाँ रुको इन करो. चलो पास में जाना पड़ेगा. हाँ अभी ठीक. आउट करो. Unscrew. So you can see when I'm pulling the suture, even the stomach wall is moving in. water jet है. So there is a problem. No. When I am not able to have a clear view of this thing.
Shyam,
So what is happening is whenever I'm trying to exchange it, I'm having I'm not able to exchange it well because I don't know whether it is locked or not. So don't worry. Cinch.
okay.
So this is the second time this happened. I was not able to exchange it well, and the suture dropped there. So probably the reason is that when I am trying to exchange this is not clear of the mucus, and when I am seeing the mucus, I am not able to understand whether I have engaged with the suture well or not.
Okay.
Tight.
Excellent.
So we have done the first layer, I think, and we will go ahead with the proximal layers. Gauge.
Pad கேட்டிருக்காங்க. Niti, they wanted a pad to clean his hands.
आराम से लेना, गीला लेना.
Cotton pad.
So go back.
So excellent demonstration. Already we can see the size of the stomach had started to reduce. We are getting ready with one more sutures.
You need a gauge. Yeah. That's it. Thank you.
இன்னொரு வெச்சிருங்க.
Suture remove करो ये वाला.
This will also help.
Just start. Okay. Reduction going on very well. Yes. Out. Here. तुमने आधा वापस करो. तुमने सूचर ले लिया. हाँ, तुमने क्या किया था देखा तुमने? सूचर ले लिया था. Don't do that. Unscrew. Now it is there. Out. Take. Unscrew.
विजयम सर इनके కాన్సెప్ట్ మీరు ఉంటే బెటర్ అని
Out.
వీడియో లైన్ சாரோட மைக் ஆன்ல இருக்கா?
Yes sir, go ahead.
Yeah.
Unscrew.
So endoscopic sleeve gastroplasty, I think there are head-on trials with laparoscopic Nissen fundoplication, and we find the results are equal, right?
So when we talk about Nissen's fundoplication, this is for hiatus hernia. You are talking about laparoscopic sleeve gastrectomy, I think.
I'm sorry, I
Yes.
just made a mistake. Yeah, sorry, sleeve gastrectomy. That was, I was totally in the GRD world. Okay.
Yeah.
So sleeve gastrectomy is the commonest obesity surgery
CO2 on
that
karna.
people do, and I think head-on. I think it has been compared, or in meta-analysis. What is your comment on it,
Sir,
Saraj?
CO2 on.
CO2. Yeah, no, it's
It's leaking here. Let's check. Sir, so that was a not a prospective study. That was a retrospective study by Fayad et al. In GI endoscopy. They found that the weight loss was a little better in laparoscopic sleeve as compared to endoscopic sleeve.
But I think the results were sustained over a period of 96 weeks, right?
Yeah, the results were sustained, and the patient acceptability was much more with endoscopic.
Because less morbidity, because this
Yeah.
can be perorally done.
Yes.
So I think that is why it's coming to prime time.
So we had a very excellent lecture by Baram in the morning, and which elegantly showed that how weight loss is important in dealing with comorbidities as well as obesity. Now,
So the trick of not engaging too much tissue is just to move the helix only 3 rotations
no.
and then stop, right?
अनस्क्रू करो, नहीं उल्टा करो, सीधा करो, स्क्रू करने की कोशिश करो, हाँ, शुरू करने की कोशिश करो, now, बेटा आगे लो, no, आप देखो आपका डिवाइस कहाँ है, आपका डिवाइस ऐसे कर रहा है, ऐसे करने की कोशिश करो, आ गया, इन करो. So what my assistant did there was most assistant do, they become overconfident. So what he did was he screwed 3-4 times, but then he unscrewed more than what he screwed. So basically unscrewing started screwing itself again. So we had to then revert it back. So this was a common problem that we face, and we should be very careful, otherwise it can lead to sharing of tissue.
I think, the moral of the story is, both the endotechnician and the endoscopy performer both should be at the same pace.
So
And
this is like ERCP, it's a 2-man job. It's not like a 1-man job.
Absolutely. So I think it's just like a household where the husband and wife are in harmony. Everything goes well. You want the helix to go between the 2 threads.
Yes.
So that you grab the tissue between the 2 threads. So that again is important. So to prevent crisscrossing of the threads also is important.
Good.
So how many times to screw, how many times to unscrew is all important. And the viewers can, put up their questions on YouTube. The experts will be happy to answer those questions.
So I've reached the posterior wall. I would like to make a base here at the posterior wall. Out. Low. Wait. Low. वेट मतलब उल्टा नहीं करना, छोड़ो, इन करो, out, low, आधा और, unscrew.
So it's highly important how much tissue is grabbed and pulled in.
So minor bleeds like this can happen, and we have to continue our suturing. BP lower side में रखना है, 110/70 would be okay. So we have to keep the mean systolic pressure also on around 110 side. She's a hypertensive, so they can also control these minor bleed well.
It's of paramount importance in all these therapeutic endoscopic procedures to keep the blood pressure around 100 to 110 systolic so that the bleeding is less.
Wait. आधा वापस, बस.
That was a very good grasp of tissue.
Unscrew. बस. So this vision of this attaching here is absolutely important. So I lost those two sutures because I was not able to get the vision, and I did not insist on getting the vision.
Now the threads are crisscrossing.
No, it's not
now it is.
crisscrossing. They are
No.
parallel.
Okay.
I have to go in between these two threads.
Okay. Now you've taken one on the anterior wall, greater curvature, posterior wall. Now you're going back to anterior wall.
Yeah.
Is that right?
Yeah.
Yeah.
Out. Unscrew. Yeah. Yeah, so we go in between the two sutures so that to prevent the crossing of the sutures. Okay, and now I have to go here a little, like this is my point. Out karo, ha, ab lo. You see that value half back, the wait, half forward. So this tissue was twisting over my helix. It should not happen. Half back, आधा back, वापस ले, वापस ठीक. This is the way the tissue should come. It should not twist. थोड़ा सा और वापस ले, बस, बस.
Yes, yes.
So once the twisting happens, you do unscrewing.
Unscrewing
A little
to
bit.
prevent unscrew. So I think we have reached. We will take one more here and then we will stop.
How do you decide when it's enough?
When we reach up to the point where we have started. So
Okay.
this is the point where we have started.
Yes, yes.
And this is the point where we are.
Sure.
And we go in between these two and we reach here. Out. Wait. Unscrew. Okay. So
one suture is
now we have reached.
over.
Now we have reached to the point where we started. We leave this tissue, this suture T-tag by pressing the blue button here. And as soon as we leave, you can see the T-tag going up to the 1 o'clock position. You can see the T-tag.
So
Now
once
we
you press
remove the needle helix, needle exchange catheter, and try and tighten this thing. You see how much.
So tightening is done by just pulling at the thread?
Yes, pulling the thread using your thumb to gauge the pressure.
Sure.
This is important that you use the thumb to gauge the pressure, otherwise too much tightening will break the suture. You can see we have already started to look for our
smaller.
Yeah.
Why do you have to pull it so many times? You want to ensure that
slow,
there is nothing else in this
no. We don't do it in one go. Little.
Okay.
Class first, class 2, class 3, class 4.
This is like a purse string. You want to do it step by step.
Yes. You don't want to do it class 12.
Wow.
12 goes away. So we have reached, this is the cinch, white portion. Can you see? This attaches to the proximal end of the suture. I will now tighten the suture. You can see the suture moving over the cinch.
Can you show the handle unit how he is tightening? Can you focus on the handle?
Now suture is moving. Wait. Let it go. Be very patient. Now stop. Now do. Now he will do the cinching. He will tighten the cinch. Do it. So as soon as he does the cinching, you see that the pressure is lost and that suture is in place. Now we have reduced the size of the stomach suture.
This lady being morbidly obese, so you would expect that you will at least put in 3 sutures?
No. At least put in at least 5 to 6 sutures.
5 to 6 sutures.
Not 3. 3 is too less. 3 is too less.
3 is too less.
For any obesity, 3 is too less. They cannot hold.
How much space you give between the sutures?
So the next bite is where I can take the bite. So I have already, this is 1.5 centimeter between the 2 prongs. So the tissue will come in 1.5, second 1.5. It would be around 3 centimeter tissue that has come in the prong.
Sure.
And 3 centimeter I need for the next parallel. So at least 6 centimeter difference would be there. But this is not actually calibratable. You cannot calibrate how much it will be. It can be less, it can be little more, but it should be sufficiently away from the previous bite so that you are at least able to have a good tissue intake.
Sure.
Okay, so we will now load the suture first. The suture, which will obscure my vision in the further process. I have cleared it out. Here. हवा इसी में हवा डाल देना. और हवा डाल. Now give it. So when I was trying to bring in the needle exchange catheter, there was something in the channel which was coming in front of the needle exchange catheter. It would have obscured my view for the entire next suture time. So it's better you clean the channel. And then use the suturing device so that you are able to see what you're doing. Out, out. Sorry, in, out. Other back, other back. Unscrew. How much time is there? No problem. 30 minutes. Out. And wait, half back, एक back, back ले और कम करो बस 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 unscrew. Out. This side. Out. Unscrew. BP. Tell him to take the BP less than 1. Oh, sorry. Out. Oh, sorry. Oh, it is bleeding. Out. You need to reduce the BP. So, go to ooze like this. So we've reached to the posterior wall. We will create a base over here. Out. Karo. Unscrew. Okay. Out. Wait. Unscrew. Out. Wait. Unscrew. So sutures are always parallel to each other.
I think now we could control the blood pressure. Pressure was almost 160 by 100. That's why we are seeing some mucosal ooze.
So these ooze are quite common. It is not necessarily due to blood pressure. They are small vessels, which can be actually taken care by the suturing itself.
Okay.
Out. Aadha वापस. Yes. So we have to continuously communicate between our technician and the support staff to maximize the outcome for our patients.
Yeah.
Right. Okay. Yes.
As Dr. VGM mentioned, we need best endoscopist, best technician, and best equipment, and all of that.
Best support staff.
Best support staff, and all that is available today. That's why we are showing this test now.
And the best center. So, state of the art center here at VGM. Out. And thoda half back.
So as we see, all the steps are almost similar, but at different sites.
Okay.
We are trying to pull in the tissue using a helix, and then releasing the.
So we've reached up to the point where I have started it.
Yeah.
I think this is a good place to have the cinch so that we have good control over the cinching. So I've left the suture T tag and I will try and reduce the stomach through this. Now, come. Boarding pass.
Their boarding passes.
Now we are trying to cinch it. The cinch has reached, and then we will tighten this cinch. Do it. Hello. Okay. लगेगा एक. So we have reached up to the G junction. This is the squamocolumnar junction that we are seeing. I think we can have space for one more suture.
So they are loading the next suture.
Yes, they are loading the next suture. We have made a good reduction in size of the stomach.
Yeah. Wow.
So
Excellent.
this is what is there. So I'm thinking this is the G junction.
Yeah.
This is the squamocolumnar junction. You can see that this is the esophagus. I think one over here, one here, and oh, I had the helix. I can guide you. One over here, one here, one here, then back. I think that should be a good ploy. Here then. Air. 10 ml syringe, that's it. That's it. Now. Okay. That's it. Now you start at the interior wall. I think this should be a good place to start. Start. One screw. That's it. So we have taken one bite over here. We are going to take the next bite. Yes. In the greater curvature, somewhere here. Okay. Out. So we move our hand like this and try to take the maximum tissue inside. नहीं हाँ अब आया हटो. So these are difficult bites because the scope is angulated. You have limited space. And these are serial sutures. So as we studied in physics, probably class 8, 9th, when there is a serial system, it is dependent on the weakest link. So each suture that you are not taking well will actually be your weakest link. Out. That's it. That's it. Unscrew. That's it. I would need a normal scope after this. Yeah. Out. Wait. Unscrew. No, we could not take the bite. Okay. Screw. Best. Screw. Or screw. Unscrew. Okay. Okay. Okay, now out. Two only. Half back. Unscrew. एक वो लेंगे बगल में उसके. Yes. Okay. Out. Best, 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 best. Unscrew. Very good. So we have reached up to the point. I will drop the suture here. Cinch. नीचे रखा. And tighten the.
So what do we call this structure? We call it as a neo stomach.
Yes. Neo stomach.
There are a lot of questions coming in for Dr. Sharans.
So we can answer them one by one.
Yeah. First, they were asking like, what would be the ideal cost for this procedure?
So that healthcare guy is there. He will answer the question.
Yeah.
Sorry.
And what is the approximate weight reduction which can be expected?
So we expect 20% of the total body weight loss for the procedure, and that is sustained up to 2 years.
For 2 years. Wow.
Yeah, it can be more also, but the robust data is still 2 years. So merit trial was monitored them up to 2 years. So it is a randomized controlled trial. So when I am talking about robust data, I am talking about a randomized controlled trial.
Okay.
There is observational studies till 5 years also.
Wow.
And not many new modalities have a randomized control trial as a robust data. Do it. No?
And post procedure, how do we, what precautions or care should we take for these
Yes,
patients?
that is an important question. I will discuss the question.
Okay.
So this is the final bite that I am going to take.
Excellent.
I will come out and do a check endoscopy. Okay. So I would be needing a normal scope here and normal upper GI scope, and I will answer the question now.
Okay.
So when we talk about the post procedure stuff here, so she's in my center. Typically she stays here for a day. She goes home tomorrow morning with a diet chart.
Wow.
That diet chart will include the diet for the next 6 months. That would be liquid diet, clear liquids for 2 weeks, liquid diet for 4 weeks, that is 6 weeks, semi-solid diet for 4 more weeks, and then solid diet which will be less carb, less fat, and more protein for the next 4 months. So this is the diet chart that we allow them initially. They have to start some sort of exercise protocol and a physiotherapy protocol. We have our in-house physiotherapists that guide them. We also have a booklet that has all the poses that they can do, the physiotherapy exercises that can be done, that should not be done, and we have follow-up. The only thing that is very important is the patient follow-up. They each have their unique set of questions and unique set of reassurance that they require. Also, the protein content in the diet has to be higher side, because what we are trying to do is we are trying to reduce the fat and build up the muscle. So to increase the muscle, you need to have good amount of protein in your diet, and typically Indian diets don't have that good amount of protein. So we might have to give them some amount of protein supplementation post-operatively, which we has used. That is probably summarizing the diet and exercise protocol that I give to my patients.
Now we just changed the scope to see the to look at the neo stomach, what has happened inside.
Okay, so we are going in,
Yes.
and okay, now I need inflation. That's it. CO2 is on, air is off, air standby. Good. So we have reached the G junction here. I expect here is the G junction. So initially it was 43, now it is 45. So I expect some amount of G junction to be pulled down.
Okay.
Because what we are trying to do is we are trying to reduce the stomach. So either it gets, G junction gets pulled down a little and this also gets pulled up a little. So small hiatus hernia 1 to 2 centimeters can also be disappeared after doing an endoscopic sleep procedure.
Wow.
So this is important because reflux is a common problem in obese patient, and sleeve gastrectomy is known to increase the reflux. So it is important that patient should know, should understand. We are actually having this stomach very small. Wait, sorry. Wait. No. So this is the antrum. I am sure you can see the size of the antrum that is there. And then we look at the new stomach that we have created, and this is the size of the new stomach that we have created. And this is the fundus that we have left. So and this is the G junction. I think this is very robust, and there is no empty spaces as you can see in between.
Yeah.
There is no what do you say, gaps. It is snugly fit in. You can compare the size post the narrowing of the body. The antrum looks suddenly really big. Whereas if you have this recording, you look in the initial photo that I froze and I was able to tell you the CNE, and you find that the stomach was even bigger than antrum. Antrum was looking smaller in comparison to stomach. Dr. VGM, please join us. I wanted to show you how much we can reduce. So this is the antrum. So initially when I showed the upper GI endoscopy, I showed the antrum and the stomach was bigger than the antrum. Now we start with the stomach. This is the stomach.
This is not stomach, this is intestine.
Yeah. So it looks like intestine. So there are no holes, there's nothing. Wow. And we reach up to the G junction. This is the squamocolumnar junction that you feel. Right. So this is what we have done, and this is possible with endoscopic surgery. Mobile se video banana. This is very nice.
Yeah.
Shyam ji. Video. Yeah, so we have reduced the size of the stomach, and this is the stomach. This is the G junction.
So I think we should give a big round of applause. The entire team here is applauding Saransh Jain and the team of Apollo Overstage, head by Shyam Sundarji. Where is he? He's here right over here. So he's our navigator, and he's a national head for Apollo Overstage from Healthware, and his entire team of people. So we really appreciate. And Saransh, technician, who's an expert ESG man. So he's been assisting him. So thank you so much for this wonderful demonstration.
Just a second.
Yeah.
When you come out, you need to understand that you have already placed overtube here. So when you come out, you have to remove this overtube. While removing the overtube, I like to keep my scope at the tip of the overtube to reassure my anesthetist that I have not done any injury to the posterior pharyngeal wall while putting in the overtube.
Wow. That's phenomenal, and I really thought you did a surgical procedure. You brought in the intestine and anastomosed it to the stomach antrum.
No, let us hope she loses a good amount of it.
I'm sure she's got a BMI of 50. So I'm sure with this she'll recover, and she's got diabetes, and she's got hypertension, got dyslipidemia, poorly controlled diabetes, sugars going up to 400. I'm sure all this will definitely come down. She'll have a better quality of life. She's got osteoarthrosis of both knees. She's got sleep apnea. She's got a pulmonary disorders. All this will come down. So what is more gratifying is you don't need today a laparoscopic, sleeve gastrectomy. You can go ahead and do this simple procedure through endoscopic route. Only thing it requires is general anesthesia. So we just have to take the consent of the anesthetist and the cardiologist. And I should really applaud our anesthesiologists,
Navneet and
Harish
Dr.
and Dr. Navneet,
Navneet
both are there.
and Dr. Majid.
And Majid is also there. All three experts, they're amazing, experts. So our gratitude to the entire team of anesthesia and the entire team VGM for this successful procedure.
So one question, Sharans,
Yeah.
before we finish. Where all can we use this new device, Apollo Overstitch?
Yes. So this is the suturing device. When you talk about suturing device, it is used to approximate two places. You can use it for closure of your post third space procedure defects. You can use it to close leaks and fistula of patients like tracheoesophageal fistula, chronic fistula. You can also use it to close perforations. So perforation during a procedure is a dreaded complication, and suturing is the way that the surgeons do it. We tried to bypass the system and allowed the body to heal by putting in stents, but it's better if we just suture the site and close it off and then put in a stent. Also important to understand,
stents will not
approximate the tissue.
Here we need
approximation
we can achieve.
Also, it is important that it is to be used only when it is a clean wound, not in an infected wound. The suture won't hold. So surgical principles, surgical principles apply to this. Surgical principles are absolutely important when you are doing anything related to surgery. Maintain your anesthetist knows what you are doing and what he is doing. Maintain that your technician knows what you expect from him. If the lecture live streaming audience would have listened, half of the time I was talking to my assistant, half ton less, half ton more, little less, little more, and that is absolutely important and of prime importance in getting the tissue that you need, and not more and not less, to do a non-complicated procedure.
There are two things that I found. One is just like how during ERCP you just do a pirouetting movement while you're reducing the scope. Like this, you're doing a pirouetting dance right from anterior wall to posterior wall and back. So all this body language is also important here.
Yes.
And Lord, how many cases have to be done on the animal model and then a human being to do without supervision for someone to do this procedure? What is the learning curve?
So I would start with the animal models. You need at least 5 to 10 settings on animal model, because the first 2-3 settings you are actually learning the device, not the model. You don't need the model for that. You need to know the device. The device functions in a little different way than the other devices. So you need to know the devices, and then after 3-4 times you need to know the animal model. After that you need at least 10 to 15 supervision cases, wherein you get some part to do yourself and some part is being done by the proctor.
Expert.
And he guides you in the tough spots that you are there, and then you can start doing your own and try and take the primary cases first. And you can also do revisional cases. You can also revise surgical outlets. You can also this is a whole new plethora of Pandora box. You can do a lot of stuff over here. Start with the simple stuff. Thank you so much.
Thank you once again to Sarash,
Thank you,
Jane
Dr.
and
Sharaj.
team, and to
Excellent
Apollo
demonstration.
Overstitch team. So congratulations. So he has to leave to catch his flight. So thank you, sir.
Thank you, Sharaj.
Yeah. Now we have another celebrity talk now for 10 minutes on GERD. Is there a need for manometry and impedance paciometry in GERD? Is there an indication at all? Because for many people, it is just doing just a PPI double dose or PPI prokinetic combo. So people are not really keen on doing manometry impedance. And to me, I think a patient has to be fully evaluated before earmarking him which way he has to proceed as far as GERD is concerned. And we have an international expert who's been on the advisory panels pan globally, and who's been we call her chief, and she's a teacher of teachers. And Professor Shobna Bhatia from Mumbai is ready to tell us, do we need manometry and impedance pH-metry in GERD? What are the indications? Thank you, madam. Over to you.
So,
Welcome, madam.
thank you, Chief. So first thing I must thank Dr. Mohan Prasad. I've been listening to the previous session, and one of the things I realized what he said is that, sleeve gastrectomy is associated with a lot of GERD. So we better know whether this patient is likely to develop it, not likely to develop it, what are we going to do. So this is where my diagnostic modalities come in. And can you just, can I share my screen? Yeah, so just a minute. So I'm going to just talk. And first thing I'm going to presume, and I hope that my presumption is correct, that most of the postgraduates and the people who are sitting there are able to, can you hear me?
Yes, ma'am. Go ahead, ma'am.
Okay. So our understand manometry and the method of pH-metry, because I will not be able to touch upon the methodology of these procedures. So first few things. First is there are 2 situations or 3 situations in GERD that we all come across. First is that most patients have typical symptoms. The load in our country is about 8 to 10% of the general population has symptoms of GERD. Almost 80% of them will respond to the simple PPI that we give. And in a normal setting or in the rural setting, in the primary care setting, we don't need to do any procedures or any investigations for these patients. In patients, the next set of patients are those who do not respond to PPI or have a poor response to PPI. They are okay for some days, then again they get symptoms, or they get absolutely no response and they come back to you saying, look, doctor, you gave me the best PPI and nothing has happened. The second group of patients is the atypical symptom patients who, if they have a good response, you're really very happy. But in atypical symptoms, the good response is only about 40% of cases. Whereas poor response or no response is more likely. So now what should we do? We have a few questions. First, is this really gastroesophageal reflux? The second question is, if the patient has reflux, are the symptoms that the patient is getting due to reflux, or are they just associated symptoms? And why are the symptoms present even after acid control? So we are going to deal today only with the first 2 questions, because that is what is going to help us understand when and where we need to do these procedures. So as I said, there are 2 situations. So if the patient has a good response to PPI, there is no need for further phenotyping of the reflux or treatment, or investigations. The patient can just quietly be on the PPI. If he needs if he can go off the PPI and come back if he gets recurrence, he's fine. Now there will be a patient who will say that, look, I am not happy. I need to get my symptoms sorted permanently. And that is when you have either endotherapies or surgical therapies for the reflux. And that is when you need to do a manometry and a pH-metry. In patients with no or incomplete response to PPI, we have to decide whether this patient is genuinely a reflux patient, which means we look at the probability of reflux in a patient. If there are classical symptoms like heartburn, sour regurgitation. So be careful, it should be sour regurgitation, not bland regurgitation. There is no dysphagia, no weight loss, and no other symptoms. You think that this is reflux, do an endoscopy. If the patient has grade B and above esophagitis, this is definitely reflux. No further investigations for diagnosis of reflux. However, if a patient doesn't respond, that is when you start doing manometry and pH-metry. So as I said in a nutshell, first is you always look at structural disorders. Look for conventional endoscopy, advanced endoscopy techniques. I think Dr. Prasad Iyer is going to cover that. Esophageal capsule or US. Do an esophageal histology to look for EOE. And if that is negative, start looking at the function. You have two types of functions which I'm going to cover. That is the motility and the reflux. And obviously radionuclide esophageal emptying is something that we don't do nowadays, but it is a very old investigation, useful. Some people, the pediatricians find it useful, but really its utility is questionable today. So first is manometry. Best thing to understand is manometry does not diagnose gastroesophageal reflux. There is no parameter in manometry which will tell you that this is definitely reflux or not reflux. So please do not use it for diagnosis. It is useful to before pH metry for two reasons. First is to place your pH metry catheter at 5 centimeters above the gastroesophageal junction. And that has to be done manometrically. The older techniques of doing it endoscopically are not correct. Look for other diagnoses. As I said, reflux or heartburn and sour regurgitation is suggestive of reflux, but it may be bland regurgitation, which the patient may not be able to explain, and a patient may have mild dysphagia, which he has not appreciated, and suddenly you will come up with another diagnosis. The presence of ineffective motility does not exclude a functional esophageal disorder. What I mean to say here is, in patients with functional heartburn or reflux hypersensitivity, do not expect a purely normal manometry. Slight abnormalities are there even in normal people, and therefore that is not a diagnostic criteria. So look at these two videos. On the left is a normal manometry going on, where there is progression of the peristalsis temporally from left to right, which means it is progressive from proximal esophagus to distal esophagus. And the right side, there is absolutely no progression. There are simultaneous contractions with no LES relaxation, which is suggestive of achalasia cardiac. So this is a normal manometry where you see this is the upper esophageal sphincter, This is the upper esophageal sphincter, the contraction, the lower esophageal sphincter, which is relaxing or becoming light green during the swallow, which is normal. So we look at this manometry, and the first thing during manometry we look at is the lower esophageal sphincter. The sphincter pressure normally is 11 to 30 millimeters of mercury. Less than 10 is considered as abnormal. Today, we do not look at the LES pressure, but look at the esophagogastric CI, or the contractile index, which is similar to the distal contractile index for the esophageal body. So then we look at whether there is a hiatal hernia or not. In patients with reflux, the presence of a hiatal hernia will worsen the symptoms because there will be an acid trap or an acid pocket between the proximal part of the hiatus, which is the lower esophageal sphincter, and the distal part of the hiatus, which is the crural diaphragm. So acid collects here and keeps on causing reflux up and down because the LES is also weak. And therefore, this is called an acid trap. Therefore, when there is a large hiatal hernia, these are patients who will not do well with medical therapy. As I mentioned, sometimes you might get an alternative diagnosis, including a EGG obstruction, where you have to be very careful to decide whether this patient is going to benefit from any kind of surgery. The next thing that we look at is a high resolution impedance manometry. Now we know that this is the normal manometry, and when we swallow, the bolus is actually proximal, or bolus clearance occurs before the peristaltic wave. So therefore, this is the pressure and this is the bolus down. And when you superimpose them, you can see the bolus as well as the pressure wave simultaneously. Normally, the bolus clears completely and there is no bolus left over in the esophagus. And look at these two examples. The first example is of a transient LES inhibition, where the LES is inhibited and suddenly you see a lot of refluxate, which is purple in color, coming up into the esophagus. On the second side is one of the mimickers of reflux, which is a rumination. The patient complains that a lot of fluid comes up into the mouth and is swallowed. But in fact, during manometry, you will be able to see that the patient is contracting the diaphragm and then suddenly retching. And then you see fluid coming into the esophagus from below, which is actually the rumination. And these are patients who get misdiagnosed as gastroesophageal reflux, often get operated, and there is a problem. Sometimes patients with delayed gastric emptying also can have similar phenomenon where they keep on refluxing, but these patients will not benefit from surgery. The other mimicker is a supragastric belch, where all of us see these patients who keep on coming and saying, there's a lot of air, and they start belching in front of you. These are classical supragastric belchers, and they will not benefit either from a regular medical therapy, but definitely need either a psychiatric care or some kind of neuropsychiatric medications. So in gastroesophageal reflux, the findings are going to be that the lower esophageal pressure may be low, that is the EGJCI may be low, the hiatal hernia may be present, and there may be dysmotility, which means the contractions are all not transmitted. Some of them are failed, and if more than 80% are weak, we call it a esophageal dysmotility. Previously, this figure was at 50%. When we have a lot of weak and failed peristalsis, we would like to find out whether the patient has the peristaltic reserve. In that case, you give multiple rapid swallows. If there is a good peristaltic reserve, then in that case, the patient does not have a significant dysmotility and the patient will not have a problem after surgery. The second thing we do is the pH metry. And here we have the nasal probe, which will do single probe pH, dual probe pH, and the impedance testing. So let us see the equipment. This is the pH recorder. This is the pH placed in the stomach, in the esophagus and stomach. This is 5 centimeters above the LES, the pH sensor. And the pH recorder will do the pH as well as pH impedance. And it is programmed to detect a pH less than 4, where when this fluid comes up, it is recorded as an acid episode. Now, this is a single probe placed in the esophagus. There is no gastric measurement. There's only esophageal measurement here. And you can see these dips. These dips less than pH 4 are calculated by the computer and are recorded. And we look at these findings directly. When we place two probes, one is placed at 5 centimeters above the LES. And you can see that there is these pinks here, which are reflux episode. This line is a little faint, but that is pH 4. In the stomach, you can see that there's a lot of this pink, which means the gastric acid is not controlled. And therefore, whenever there is reflux, we know this patient will require good acid control of the gastric acid. The other type of monitoring is the wireless pH, which is called the Bravo. The advantage is that you can keep it there for 4 days. The patient does not have a problem. It has to be placed during endoscopy. And the other advantage is that you do not need to do a manometry to look at the LES level. During endoscopy, pull the scope 5 centimeters above, and this is clipped to the LES in the esophagus, and the patient can go around for even 4 days with this, and the study can be downloaded and analyzed. I don't think any center in India has this, so therefore there's no point in discussing this in detail. Now, if you want to prove that there is GERD, I said that first, is this GERD is our question. So then in that case, we have to do a pH metry. We may do it with a single channel. The patient should not be on PPI for at least 8 to 10 days. and if the pH is less than 4 for more than 6% of the time. So for the postgraduates, I must say previously 4.2% of the time was considered. Now we say it is 6% of the time. And if it is more than 6% of the time, we say that this is definitive gastroesophageal reflux related to acid. The other thing we see is in patients who have, why this was changed from 4.2 to 6% is that even in normal patients, some of them will have up to 6 or 7% of acid coming into the esophagus. And therefore, a value of less than 4 total acid exposure time is definitely normal. Less than 6 is likely to be normal, and more than 6 is definitely abnormal. And in patients with esophagitis, the acid exposure level is usually 9 to 27%, which means at smaller values, we should not be considering doing invasive procedures, since these patients may actually not benefit from invasive procedures. We should still keep them on drugs. So the cutoff values we will see, as I said, definitely abnormal is more than 6, borderline is 4 to 6. And the reflux episodes, if they are more than 80, you start thinking this is reflux. If it's supportive, you can look at other parameters, which I'm not discussing today. Definitely normal is an acid exposure time less than 4% and reflux episode less than 40. There was this Demister score, which was done many years ago. It is still valid. The surgeons use it a lot. And at that time, they looked at 4.2 as the cutoff. So if this calculation is more than 14.72, it is considered of reflux, and more than 100, we consider it as severe reflux. The next thing we want to know is whether the patient, when he has the reflux symptom, does he get the symptom? So is the reflux episode and the symptom correlated? And this we can find out when the patient presses these multiple buttons on his equipment. It looks like a video game actually. And when you press them, if the patient has, if your patient has heartburn, he presses the button. If there is a reflux at that time, in that case, we can say that the symptom is definitely due to reflux. So there is this diagram which we draw, which many of you are familiar, where we use it for the chi-square statistical test. So pH change, yes, no, symptom, yes, no. And this tells us whether the patient has significantly symptoms which are related to the reflux. If it is positive, so you can see at the bottom, the calculation is done for us. There is total of 105 episodes of reflux, out of which 19 had symptoms, whereas the patients did not have, the total episodes that the patient has pressed the button is 701. So the symptom index eventually turns out to be about 86%, which is a positive symptom index. Above 50% is considered as positive. So what are the issues with pH metry? First is there is day-to-day variation. So Bravo pH metry, which I mentioned, which is placed, the capsule placed in the esophagus, is useful for this, where you can monitor the patient for 48 hours. So if the first day was negative, second day is positive, you can find out the best possible day when the patient has maximum reflux and label the patient as reflux positive or negative. The second issue is if the patient has non-acid reflux. Now, these are patients who are already on a proton pump inhibitor. There is non-acid reflux, or there could be a weakly acid reflux. Now, the pH probe that we use will not diagnose a non-acid reflux because the pH of this fluid is more than 4. And this is where we need impedance. So what does impedance do? It looks at the number of ions that are flowing up and down. So therefore, the pH probe has 6 impedance channels which are placed above the LES, 3 centimeters apart. The highest probe is 3 to 4 centimeters below the upper esophageal sphincter. It has 2 pH probes because we want to see whether the gastric pH is low or not. And here, quite often, we do this on PPI because in these are patients where we suspected GERD, the patient did not respond to the PPI. So therefore, we think that this study should be done on a PPI. If you want to do it off PPI, this study has not much value because the single channel probe, which is much cheaper, is as good. So impedance measurement here, this is the catheter. I just explained it to you. This is what it looks like. This is the box, the pH box, where the patient presses the symptoms, the medications, etc. And this is what the study looks like. So this is no longer as simple as the first study that we looked at. This has these impedance channels. Now, all these impedance channels, every time you swallow, this signal will change. Air has a high impedance, so therefore the thing will go up. Liquid has a middle impedance and solid has a very low impedance. This is the pH at 5 centimeters above the LES. I'll just show you all that in a different detail. So you have to expand the study and look at this study carefully. So this is the esophageal pH. And we said a pH less than 4, you will see this pink. So we see that there is an episode of reflux. This is marked out where the fluid is going upwards. The impedance has dropped. That means this was fluid. If it was gas, the impedance would have risen. There is a swallow here where the patient has swallowed air. And therefore, this is an impedance showing a reflux episode. When you look at this, there is acid here. So therefore, this is an acid reflux episode. Look at the next one. The same thing has happened. There is a reflux episode here, but there is absolutely no acid when you look at the pH channel. The pH at this point is shown here, which is 5.2, which means that this is a non-acid reflux or a weakly acid reflux. More than 7 is considered as a non-acid reflux. So according to this consensus, which was published about 4 years ago, the conclusive evidence of reflux is a LEA grade C or D, the presence of a Barrett's. The borderline is when the patient has either no reflux on endoscopy or maybe an LA grade A or B. When you do the impedance pH metry, you will see the acid exposure time more than 6 is definitely reflux. If it is between 4 to 6, it is query, and supportive evidence is what we look at. So next is what should you do and why are the symptoms present, which I won't be discussing now. So in a combined impedance pH and manometry thing, you'll do the motility assessment, do the pressure measurements, look at the esophageal contractions, reflux, liquid, gas, acid, non-acid, and the bolus transit is done with the motility, where we see whether it is a complete bolus or some part of the bolus is still staying back in the esophagus, as I showed. Now, this is the final conclusion. I'll start here. If the patient has negative or consistent with GERD, but symptoms are not necessarily related to reflux, do a manometry. Don't find any relevant findings related to a motility disorder like achalasia, do an impedance. If the patient is not sure, you are not sure whether this is reflux, do it off PPI. If you're sure this is reflux, do it on PPI. And look at the symptom association, pathological reflux and physiological reflux. So there may be patients where the reflux is physiological, but the symptom association is positive. If both these are negative, you're not sure what's happening. If the patient has acid reflux, double dose the PPI. If the patient has borderline with some symptom association and a hypersensitive esophagus, add an antidepressant. If there is pathological reflux, even if there is no symptom correlation, continue the PPI. And if everything is negative, treat it as a functional disorder. Coming down in patients who have definitive reflux, that is first and third, the patient has not much response to PPI, do a pH and manometry and consider surgery in these patients. So in conclusion, these two investigations are extremely important, but they are not important in all patients with reflux. They are important whenever a patient does not respond or when a patient responds but wants to go for surgery. And pH-metry will prove the reflux, whether it is acid, non-acid gas. Manometry, you want to check the esophageal motility before you jump and do a surgical or a non-surgical procedure. Thank you very much for a patient listening.
Madam, can you hear us?
Yes.
Yeah, so please give a big round of applause for Shobnaji's lecture. So the whole team is applauding you. We have, people have registered 580 registrants since at least till morning, and it has crossed 600. So from Philippines to Indonesia to Burma, Sri Lanka, Nepal, India, Middle East, and also it goes to African countries like Tanzania, Nigeria. So many country people have joined at different time zones of the world. So it was a phenomenal program, thank God, and thank you so much. You've been an international expert on, motility. So we are really fortunate to have you, madam, today for your wonderful talk. Thank you so much. We are ready for live cases. So
Thank you very much. If there are questions, let them put it in the chat box. I'll answer them personally. Thank you.
Positive. Thank you so much.
Thank you
so much. Bye.
Thank you very much. Yeah.
Friends, we are moving on with the workshop, live workshop. There are 2 cases posted, both sides, and we're going to start anti-reflux mucosectomy, the arms procedure, which was described by Professor Inoi. One side, Madhura is doing a case, the other side, Dr. Vamshi is doing a case. Along with me is Dr. Sangameshwaran, who will be the expert commentator. He'll take the whole program through, and this arms, is very useful wherever there is no hiatus hernia. If there is only Hills 1, Hills 2 of laxity of ileus, you can definitely attempt this procedure. It's less morbid, it can be done under propofol sedation, it can be very quick. So we're just doing only an endomucosal resection ultimately. And over to Dr. Madhura Prasad Suman for taking us through, and to Sangameshwaran.
So over here, this is a greater curvature.
Ma'am, case history running, ma'am.
About the case history.
Yeah, so this is, you can.
Old female patient who presented with regurgitation and abdominal burn for the past 2 years. Endoscopy showed columnar lined esophagus.
They've started. We can also start simultaneously.
Next slide, please.
Once they're ready.
Okay. Single slide. Yeah.
So
we have got Dr. Madhura Prasad Suman.
So previously she had low-grade dysplasia, and she is on surveillance and follow-up right now. So they opted, she's an elderly person, so she didn't want to opt for a surgery, which we understand. But so she opted for doing an anti-reflux mucosectomy.
In view of her age.
In view of her age.
Yeah.
So if we see here, anti-reflux mucosectomy, anti-reflux banding has been done, anti-reflux ablation has been done. So all these have, with their data, they have worked well in so many patients, and being least invasive, they are preferable. So here what we do in all the procedures, it's similar, where we leave 2 centimeter gap on the greater curvature. If you can see here, I've marked it for you here, which is just two times the scope width. So, and then we're going to leave that part and go focus on the lesser curvature. So I prefer injecting mix of, yeah, I prefer injecting, can you inject? Wait 1 second, go back. He'll, yeah, start injecting. So we are injecting actually saline with some indigo carmine marker, and then we have also artificial tears, and of course we use diluted epinephrine, which is a secret, so we don't want so much of a bleed. So we will keep injecting all around.
What are the anatomical landmarks for injection?
So here we want to go close to the squamocolumnar junction. Patient has Barrett, so I'm just holding on to the OG junction instead. So we have an EMR cap right now. So yeah, kneel out. So we'll inject again if required. For now, we'll just do the first. Keep injecting. Yeah, keep on injecting. So doing an EMR, what happens is they go in for a stricture And so that's why we don't want it to be circumferential. We want it to be semi-circumferential. Yeah. We'll check for the other landmark which we marked, which is on the other side. Let me just check once. Yeah, so this is where we've marked. We've left that space. We are going around and going here. Yeah, needle out. We'll go closer to the OG junction. Yeah, inject, start injection. Okay, yeah, that's fine. Needle back. So we have a series of patients and they have good results with the arms. That's, I think I'll inject a little more. So before we resect, because I need to go see we want to keep 1 centimeter on the esophageal side and 1 centimeter on the gastric, 2 centimeters on the gastric side. So more of the gastric and less of the esophageal side. Yeah, that seems to be, is it right? Let me suck out a bit of fluid so I can see better. So it takes around 6 weeks for the lesion to heal. Let go. So this is the side where we started.
How do you select the patients for arms?
So we have to first let them know that this is like not a time tested procedure, but we give them the real statistics of what we see in our patients, and we don't want a large hiatus also because it's going to be difficult to it's not going to be useful for those patients because hiatus is all about, it's going to be more an anatomical problem, right? So that's not going to solve this. So I think I'll go closer here because that's Barrett's. I can't see the top part of the squamocolumnar junction. But what do you think, sir? Shall we start here?
Yeah.
It seems to be all right.
Yeah, it seems to be all right.
So we'll inject a bit more over this side and then we can start. Yeah, that's the place where we marked. So I'm going closer as much as I can. Hold the scope, please, to the G junction. So yeah, that's the closest I can get to. It is a large cap, but I would like to go as close as possible. Hold the scope, please. So we would like to. So also whenever we take in an instrument, a needle out, keep injecting. Yeah, keep injecting. So whenever I take an instrument inside, this for the postgraduates, I try to stay in the straight route and not insert it in the J because it's going to damage the channel of the scope, right? Even when you're taking out if possible, but at least when you're inserting. Now I'm going to seat the snare and proceed with the first dissection. Do you think that's a good lift for us to proceed?
Good lift is okay.
Okay, so then we will start proceeding. So for the seating of the snare, this one is, we are following the first one which Professor Inoue introduced, which is just the EMR form of the arms, but there are so many modifications which have come in. All this one has definitely helped in studies and
before starting the procedure per se, we have injected now. So can you brief upon the accessories we are using here? We are using a different type of snare where we don't use this snare for other purposes commonly.
Yes, this is a monofilament snare which is really small. And what's the diameter of the snare? It's just around 1 centimeters.
Yeah.
1 centimeter. So it It seats very well inside the cap, and this is what we use for EMR resections as well.
So we don't prefer braided snares, right?
Braided snares are also good because they'll hold the tissue very well. And there'll be uniform distribution of the current. This is the edge of the tissue which we have marked. So I'm going here, little closer, little closer, little closer, little closer. Hope we can get a bit more closer. No, not that way. So we will go back again. Again, we will try. So I think that should be good. That should be good, I think, because we are not able to see the junction. So here I want a red out before I ask you to wait, don't tighten. I want a red out just like how I band. So now you tighten, yeah. Then I use the endo cut. I can push away and then cut. So endo cut Q. It's at endo cut U, yeah. So we use a blend rise current to prevent ooze, which we do find ooze, and we have the coagrasper ready in case we need. It's not working. Endo cut. Cut. Endo cut Q.
Q.
Mele.
Q there.
Yeah, that's fine.
Q.
Yeah, it's fine. Yeah. No, it's fine. And he'll keep closing as I keep cutting. That's it. So
yeah.
So little more. Yes. So now it's detached.
Yeah.
Now we have got the first cut.
Yes. And what has to be done in arms as against the ARMA, like the classic teaching of INOE is to use 1/3 from esophageal tissue and 2/3 from gastric tissue. Whereas the ARMA, people have done only on the gastric side. Probably one of the important things is that the APC beam can probably damage the endoscope. They always kept 2 centimeters away from the OG junction before they did ARMA, but more and more enthusiasm for ARMA. We have done arms for the past 6 years and we have good results. If you choose a patient properly, we do always a manometry, impedance pHmetry, select the patient, see if there is no hiatus hernia, choose only hills 1 and 2, then the results are good, very gratifying. So we keep surveillance follow-up. I've had a patient, the longest patient is probably 6 years back when I did the arms procedure. This patient had dysplastic Barrett's. So now today we did a screening endoscopy of the transmission. Absolutely normal. There is no, he's absolutely off PPIs. There is no reflux at all for the past 6 years. Completely 15 years he was on PPI prokinetic and a D-Meester score of 130. So he's completely off PPI. So it's unimaginable. It works well. So, but you have to choose your patient.
Yeah, sir, is there any selection criteria you follow in your practice between surgery and endoscopic modalities? Second, among the two modalities, endoscopic modalities, arms versus ARMA, how do you choose, sir?
Yeah, ARMA is a more recent procedure. Arms, started by INOE at least 6-7 years ago. So we have been doing it. So we know the follow-up. So arms works well. Like what Madhura is demonstrating now, it works very well for hills 1 and 2 and with significant reflux. Yeah. So if like in this patient that I'm talking about, who we did surveillance today, so also had a dysplastic Barrett's and he had undergone radio frequency ablation using Halo 90 system. So absolutely, like today we thought at least we'll screen for metaplasia, dysplasia, absolutely nothing. No, so that is a sort of effect. So I'm very happy about it. The ARMA is a more recent procedure. So we need to look at the long-term results. So in the short term, it seems to be working well. Some of the centers like Professor Nageshwar Reddy's unit, AIG, are doing a lot of ARMA now, and then they are following up. So we just need a follow-up for all these patients.
Yeah, we'll go
so
for the
all
next
these
cut.
patients of arms also, we do pre-procedure manometry, impedance pHmetry, and then post-procedure endoscopy to see the position of the OG junction, as well as do a manometry, impedance pHmetry after 3 to 6 months to demonstrate a reduction in the acid exposure to the esophagus.
What are the events in form of adverse events we expect during the procedure, post procedure of arms?
Yeah. So very beautiful question from Dr. Sangameshwaran on what are the complications that could arise out
how
of
do we be
arms
prepared?
procedure? How do we get prepared? What to expect? See, number one is that area that we are dissecting in the fundic region of the
Just
stomach
checking once.
has got a lot of vascularity. So there could be some bleed from that area. So one of the important gadgets that we use is Olympus Coag Grasper. It's a very beautiful instrument from Olympus. So we love it. So all that you have to do is just grab it and coagulate, press the pedal. It doesn't produce deep coagulation. It just produces enough coagulation to cauterize the vessel, seal the vessel. So that has to be kept ready. You should be prepared for some bleeds. That is the only thing. And if you do not leave a 2 centimeter gap at least on the greater curvature, so you go all around like a horseshoe, all around and dissect,
Just
but leave at least 2 centimeters. Because otherwise, if you don't do that, there'll be fibrous tissue. It'll form like a string, and it will produce like a purse string. It will produce a stricture. So the procedure has to be properly, like you'll have to mark it with a marker. So 2 centimeter gap, 1 centimeter is that of an endoscope. So 2 endoscope width is approximately 2 centimeter. So that much space has to be left. Then you go all around to do it. And right now you see Madhura is pressing the pedal to seal a vessel.
So I'm just keeping it closed and pressing superficially itself. Because even a closed Coag Grasper helps.
Yeah,
so it's stopped.
See, she's just touching the vessel with a closed tip of the Coag Grasper. Still she's able to seal the vessel. It's very beautiful because the power that is transmitted is more superficial. It doesn't produce in-depth injury.
Larger vessel, but I think it stopped bleeding there.
Yeah.
But it's a little bit difficult to
This is a small vessel. I don't think you should worry about it.
So we will go ahead.
You can keep dissecting.
We'll inject
we
a bit
cover
more.
up the entire lesser curve, 2 centimeter. We will leave around the
Correct.
greater curve.
Correct. Exactly. Now like we are starting one more arms procedure. Dr. Vamshi Murthy is about to start on the other side. Let me just check if the OR2 is ready. So we keep hopping between the two rooms.
Yeah.
Are you ready? Yeah. Okay. So, friends, we are in endoscopy OR2. So, where Dr. Vamshi Murthy is doing this procedure of arms once again.
Sir, case history running, sir.
Yeah, this is a 51-year-old gentleman who presented with regurgitation for past 2 months. And this is how it looked. So, it has got a laxity of Elias. There is no hiatus hernia. We did manometry. We did impedance pHmetry. And then that is a narrowband image of the OG junction, which shows a columnar lining. Dr. Vamshi, would you mind showing us the OG junction once before you move in? So,
good afternoon, everyone.
Fitted it with the cap. Yeah, please tell.
Just now we started examining the OG junction in this patient. This patient had more of heartburn and reflux symptoms. He was PPI dependent, and now we have an excellent procedure.
Is there a grade A or B reflux esophagitis that you see?
Yeah. Maybe grade A?
Yeah.
Yeah.
There are tiny, mucosal breaks indicating grade A reflux esophagitis in spite of the PPIs. He has had a poor quality of life and he does not want to continue with PPIs. So even though he presented to us only 4 months back with a 4 months history, but it's been going on for a few years, the reflux problem, but not disturbing him. For the past 4 months, it's more disturbing. And you see we saw the OG junction, there is no Barrett's, but a reflux that disturbs the quality of life, and in a young or early middle-aged individual who does not want to continue with PPIs because many people are worried about the PPI side effects in the long run. So that is why this patient is posted for arms. This is a simple procedure. So what is this transparent hood and what is that notch which you find, Dr. Vamshi? What is that groove?
That groove allows the special snare for the arms procedure, which we do. It has a concentric snare which we use for the arms. And this arms, it stands for anti-reflex mucosectomy. It's a beautiful and accidental innovation discovered by Professor Inouye. Earlier, when they were treating Barrett's, this was around story around 12 years back. What happened was when they were doing EMR for Barrett's esophagus, they found out like patients developed few strictures when they did circumferential incision near the GE junction, and surprisingly, patients' dyspeptic symptoms completely resolved. And over past 12 years, there are many changes for this procedure, and now we have new endoscopy gadgets for making this procedure much simple. So this is the retroversion view. What we are seeing is right side is the lesser curvature and this is the greater curvature. What we'll do is we should not do a complete 360 degrees EMR. What we can do is we should leave at least 2 centimeters over the greater curvature side. For that, before starting, I'll use a dual knife for marking the.
So this is a Olympus dual knife which is being used.
So EMR should be just near to the GE junction. So this entire area I'll be trying to cut during the procedure. Yeah, I've marked this area. I'll try to, or maybe this somewhere, this till here, 2 centimeters or diameter of the scope or tip also is fine if you can leave. Yeah.
So as I was discussing in the previous data, so one endoscope is 9.8 millimeters, like 1 centimeter. Approximately 2 endoscope width will be 2 centimeters. So you just leave that gap so that it doesn't become like a purse string.
Yeah.
So, yeah. Now he's going to inject, so what is it that you inject?
So a solution of methylene blue with a little bit of diluted adrenaline to avoid bleeding when we are doing EMR. So we'll raise the cushion and then we'll start.
Even better solution will be indigo carmine.
Indigo carmine.
And we use indigo carmine also. So
yeah.
I would prefer indigo carmine because methylene blue sometimes can be carcinogenic if it is inside the tissues. So, like, why do you have to use dye? Why?
Just to know the submucosal
saline cushion. It just gets lifted from the muscularis propria. Is there enough lift? Is important, paramount importance. Do you mix epinephrine or you don't?
Yeah, I prefer using epinephrine because otherwise this area is relatively vascular and sometimes we tend to encounter bleeds. We have tried doing without adrenaline also.
See, as he is engaging already, the assistant, started putting in some fluid because as it is dripping out, then you can jab, then it just, quickly swells up. See, that is a very good submucosal saline cushion that he has produced.
Okay, needle in.
If you want the cushion longer, we can use, other solutions which can be more viscous solutions, which can stay in the system.
Like methyl cellulose.
Like methyl cellulose is one of those. It comes as the eye drops, so which are sterile, and methyl cellulose, solution can be injected, which can stay for longer. So if it can be quick, then even just the saline or water is enough.
Yeah.
So it's not a problem.
So we are trying to raise the cushion all over the lesser curvature.
So you can move in the needle in and out so that it finds a plane of submucosa so that we don't inject beyond into the muscularis.
So already we have this Jodithan technician with us. As I start injecting, pricking the mucosa, before that itself he starts injecting so that immediately the plane is already achieved.
Yeah. So, yeah. See how beautifully it just swells up.
You inject that? No, you can inject still. Yeah.
So after these two arms cases are over, we're going to demonstrate the Allurion balloon, which is, not
needle out.
very commonly used, but many centers have started using it today, and because it does not need an endoscopic
Needle.
technique. So, and obviates a need for any anesthesia or sedation. So that is the advantage of this balloon. So which just automatically, like works for 120 days, and it just, exits its water and then passes off out per via naturalis after 120 days. And people lose at least 10 kilos in 4 months time. So which is a very good response. So we're going to demonstrate the Allurion balloon, and then we have one more procedure, which will be the ARMA procedure, anti-reflux mucosal ablation, which will also follow. So please stay tuned. After that, there are beautiful videos of transoral incisionless fundoplication, ESOFIX. That will be demonstrated by Dr. Mohit Bandari, and then there'll be another demonstration of the endoscopic sleeve gastroplasty by Dr. Mohit Bandari, and then there'll be one lecture on tricks and tips of the trade in doing the endoscopic sleeve gastroplasty. So we have experts here to go ahead and complete this workshop. I'm sure I believe that you people are getting benefited by watching these procedures by all these experts.
So as Dr. VGM sir is speaking, we started doing EMR at this site. We used a special snare. Tighten.
Finished. Then collagen ready.
Okay, tighten. So this is a special snare from Olympus. Tighten. Somehow we could not dislodge it. Yeah. When? We achieved a nice submucosal lift. However, I think
you have to cut more.
Yeah. We are using LB 200 in this room. Yeah, that's fine.
So Vamshi, you always use 1/3, 2/3 as Professor Inouye described?
Yeah.
1/3 of esophagus and 2/3 of stomach.
Yeah. Watchman. So we have this hampering of vision over here, but that's not a problem. We'll try to. Yeah. Water kodunga. Wash. Yeah. I'll just try to inspect the area which we have cut, then we'll try to continue the arms. So we have done more than 100 cases of arms at VGM hospital, and more than 94% of patients are now off PPIs, and they are much comfortable. Yeah. Now I'm using this Olympus snare. I'm trying to load the snare on the EMR cap. Yeah.
So for loading the crescentic snare, it's a monofilament snare that has to be seated in the rim. So what you do is just go oppose the scope to the mucosa, give a suction, and then bring out the snare, and the snare will conform to the shape. So the Olympus provides a set of 5 snares, which comes with this. So if you're reusing the snare, that becomes a problem. If you use a fresh snare every time, then you don't get into this sort of a trouble. So now, it got seated. So generally, like 1 or 2 times the snares work. And so, there's no problem. You can slightly pull back. Yeah. That's fine. That's fine. That's fine. That's perfect. No problem. It came out. That's okay.
Beautiful.
That's okay.
Now that we can see the snare has been seated beautifully. This is the site which we started. Now we'll be trying to continue the procedure. And we'll continue doing the EMR.
You just push out from the cap a little bit. Yeah.
No.
Yeah, now we can visualize better. Yeah, now we can cut.
Tight. Yeah. Not tight. Yeah.
It's not cut fully.
Yeah.
Now it's cut. Now it's cut. So we just keep sucking out all the gas that comes out, and because of the dissection.
No, I'm sucking it. So many people ask, are the results immediate after arms?
I don't think so. Because why? Because if you're doing a Nissen fundoplication, you just wrapping the stomach around the OG junction, the results can be instantaneous. Whereas here, it takes about 5 days for the collagen to appear, and then for the remodeling to take, it'll take 6 weeks. So at least for 4 to 6 weeks, patient has to be on PPIs plus minus prokinetics. So otherwise it doesn't work. So it takes time. So, and again, I find it very useful to spray collagen in these people. This is fine. You can go ahead. You don't need to seat it exactly in the rim. So it'll still work. So if we just spray collagen, immediately, we initiate the fibrous tissue formation. The healing is by fibrosis, and the fibrosis makes a sling that happens at the OG junction. So.
Yeah, this is fine.
You just go to the margin and start.
Yeah.
So, cut edge of one this thing, we just always approach and then you start off from there. Yeah. Just adjacent to that. Yeah. Perfect. Perfect. That's perfect. I think that's great. Yeah.
Should I come a little down because the GE junction is...
That's okay. You can just still go a little inside also. Doesn't matter. No problem.
Yeah.
Because we're not producing a purse string stricture. So not a problem. It's continuously sucking, and as the assistant tightens, then he just moves the the polyp outside the cap, and then you just start applying the cutting current, so it can be endocut, and that quickly came off.
Yeah. So as I'm continuing in this room, I think Dr. Madhura is almost finished with her arms over there in the other room.
Yeah, can we switch to show Dr. Madhura's video? We'll switch to OR1.
So I'm... So we're almost done. I think we may need one more time.
Just a minute, we are not switched.
Yes. Ma'am, you're on.
Yeah.
Yes, so
Madhura, you're on. So this is, Madhura is finishing this procedure. So she'll just show you the end result of the dissection.
I'll remove this.
So this is all parts of what we have resected. So I'll go leave it in the duodenum because it keeps interfering. So we're almost done.
So our armament.
I think we have one more bit of tissue to dissect and we'll be done. So
Bleeds can be managed with co-grasper.
Co-grasper, and so but we like to spray collagen at the end. So till now we were just tackling a few bleeds here, and I think I will do that also.
Have you ever
a
felt
few ones.
the need of hemoclip at any situation in your expertise?
During this arms procedure, no, but we can. It will always. We should have everything. I believe that we should have the entire bleed armamentorium ready for any case. So I think we should tackle this still. Generally they're all small submucosal vessels and they settle.
But we have seen in some of the demos brisk bleed from bigger vessels there.
True.
So sometimes if you go deeper, then it can happen. They're the muscularis propria vessels which come up sometimes into the submucosa.
And also most of the doyens don't use epinephrine, and I don't know, we use it. It's a luxury not to have a bleed, right?
Right.
What do you think?
No, the problem why they don't use some of them epinephrine is sometimes because of ischemia that it produces, the vessels are temporarily sealed. But once you go out, the patient can start bleeding.
Correct.
So
Perfect.
for that reason,
True.
so some of the units
delayed
do
bleeds
not use.
happen.
We use 1 in 100,000 epinephrine, so which is very dilute. In our unit, all the past 100 cases, we have never had a problem of delayed bleed.
Because
and also, but probably one of the things that we do in all these cases is spray collagen, so that that can seal off the vessels. So
yes, can we look at this in the RDI mode? RDI.
Not really. Yeah. So
we can see the vessel, but I just
RDI
want to see by
mode
RDI. Yeah, let's see that.
That is a red dichromatic imaging.
Correct,
so where you can see the vessel underneath, so the blood. So otherwise, you don't see the blood. I mean, you don't see the vessel, you see only the blood. So here RDA is a great help that way to identify the vessels wherever there is a bleed.
Hold. Yeah.
So this is the Exera system EVS
you can
X1,
switch back to
which is
white
very
light
good.
mode.
And this is Olympus Coag Grasper, which is being used. See how beautifully it just sealed off the vessel and immediately the bleeding is gone. So at the end of the procedure, we always have to introspect properly, take time to inspect the whole area to see if there are any vessels. If so, you can just coagulate them before coming out. But smaller vessels can get sealed once we spray collagen, so there is no problem.
So, what do you think about the small tissue here? Do you want me to remove that part also?
I do not think so. I don't think that you should. But probably, if you want, you can use even a Coag grasper and cut that tissue.
Generally, it's very vascular, right? When we see these of course. Open.
Yeah, you can grab the tissue and you can just, probably pull and, See, she pressed first the coagulation pedal and then she pressed the endocut. See, that is it. These islands, like if there is a ridge separation between the two areas that you dissected, mucosal resected,
it's not holding.
You can always use Coag grasper to dissect. Like both Madhura and Vamshi, both are experts in poem and G poem. So they keep using, the Coag grasper even for dissecting fibers. You see here. So you want to continue, connect all the segments that you dissected. So helpful it is just to hold with the Coag grasper and just grasp it and then cut it. That's it.
Yeah,
it's
one
simple.
more time. I think one more bit of tissue we need to take over here, right here. So I think we have learned to be perfect at your hands, so we don't like imperfections. That's why we are removing that bit of tissue. So we will inject and we will do one more snaring.
One more, and then we'll
more.
just briefly, I'll have a look in OR2 what is happening, how that case is going on, and then I'll come back to you.
Audio switched over to Vamsi sir, your line.
We encountered a small bleed and we tackled it just now. CO2 up. Anna.
More talking. Actually, forward view le theriyudhu.
Your CV. Your CV. Your CV for introduction.
I think 1 or 2 more cuts should do. Konjam. We'll try to inject a little more. Yeah. 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 That's fine. Snare. So only 3 steps in this inject, suck and cut. I might have to use another snare because we have already taken 4 bites. And the snare shape is, it's no longer in the crescentic manner. I'm trying to load the snare. We'll use one more snare. Yeah.
You give me the cover. So this is called the Snare Master. This is from Olympus. So
video,
are you seeing it, the video? Yeah. Okay. This is the Snare Master, which comes in sets of 5. So that 5 times you can cut. So that's how it has been devised.
Tighten. Yeah. Okay. Should be okay. We are trying to inflate more. I think 2 more cuts and we are done. We'll just inspect the area once more. Yeah. Okay.
That's it. So you have to continuously press the pedal in order to get the cut effect. So
Jodithan asked me to wait, that's why I waited. So we are using continuous only CO2 while doing any third space procedures.
So for all therapeutic procedures at BGM, we use only carbon dioxide insufflation. We don't use room air because in case there is a perforation, then we are safe. So again, one more seating of this crescentic snare master from Olympus in the groove. Yeah, that's fine. You can go ahead.
Not an exact this thing.
Not exact, doesn't matter, but
we can still continue.
Yeah, you can still handle it. Not a problem.
Little on this side.
You can rotate some more, little more to the right.
Yeah.
Yeah. Yeah. Yeah. That's fine. Yeah. He got a good grab.
Excellent. So this is what we did till now. Yeah. We'll just inspect the area and we'll come back.
You want to show the bleed? Yeah. Can we switch to this, Madhura? We want to show how you control the bleed. Huh? So switch to this side.
Ma'am, your mic on, ma'am.
So
Open.
Yeah.
So there is
Madhura,
a
you're
nose
on.
there.
See, we were discussing about the bleed and see how much of blood is there.
Yeah, hold.
So here again, you can give wash. We can give RDI to see the vessel. If there is a problem, if there is a brisk ooze, we can always do that. So, but these sort of bleeds always are a part and parcel of this all these procedures. So the whole team is geared up.
Yeah, we are with RDI.
Yeah, we are in RDA mode.
I think we need to clean up a little bit to see.
Yeah, give some wash.
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 I think it has stopped. Enough. Okay, stop the wash. Let's switch to the white light first and check where the, I think it will come out.
So we just clean up the whole place, just look for, the control of bleed before proceeding. So this is important because, whenever we do a procedure, it's just not enough to start, doing a procedure without knowing the complications. So bleeding is one of the major problems here. So, which is being controlled by Dr. Madhura very efficiently. You want to switch to RDA mode now?
Wait. Just a second. First we'll see. Yeah. Now you can switch. Okay,
see
there
how
it can see beautifully.
the RDA mode shows the blood vessel inside the pool of blood. So you can exactly target it. So especially if you're not using a spray coagulation mode of APC, if you want to target the vessel with a coagulation grasper or you want to put a hemoclip, as Dr. Sangameshwaran was pointing out earlier, they're always helpful if you have RDI. So the pool of blood is gone now. So we can just very quickly, as she finishes the suction, give some wash again, and then you'll be able to see the area again.
Because it's a big blessing, because bleeds are the things which really delay us in every procedure, be it ESD, POEM.
Yeah, see that vessel is seen now. The yellow colored thing is the vessel.
Yes.
So that can be easily tackled now.
Waiting for the coagrasper to come out. Yeah, that's better.
Yeah, that cleared the place.
Good vision.
You have to move slightly to the right.
Yeah, getting the grasper out. Yeah.
Yes.
That's the place which is oozing, right?
Those are the vessels.
Yes.
See?
Open. Hold the scope, please.
This beautiful Olympus RDA system, and
yes, perfect.
Helps in identification of both the vessels. So it's a beautiful demonstration how the newer technologies can help.
Switch back to white light. Let's see a comparison. Yeah, but see, we can't see anything here. But there we could see the vessel.
Yes.
So beautiful. Switch back to RDA.
RDA now.
Yeah.
There are two vessels.
Yes.
One, going off above 6 towards 3, the other one goes off to 9. So 2 vessels are there. So both have to be coagulated.
Yeah, I think that's holding both. Yeah. That's correct?
Yeah, keep on pressing the pedal, coag continuous. So it's a soft coag that is used. So it works very well. So
I find that clearing the field of, all this wetness helps the coagrasper to work better. Sometimes it doesn't. I wonder if it's the current settings, but generally, can we switch back to white light? When we clear the fluid, it works better, the coagrasper.
Correct.
So,
absolutely.
Yeah, that's another bleed. Let's.
Yeah.
Yeah, that's just a small vessel. See, this is a forward view. I just came in to see because it was easier to see. We've gone into the esophagus 1 centimeter.
You are ready to spray collagen. You want to show the effect, how you cut, and then we'll move. Okay. So can we switch, sir, to this room?
Should be okay?
Perfect. Perfect. Good job.
Vamsi sir, audible.
Yeah. So this is what we did. We did EMR just near the G junction on the gastric side. We left almost 2 centimeters near the greater curvature this side, and over the lesser curvature we did circumferential, almost like a horseshoe shaped EMR, and I think patient should be fine after this procedure. Maybe after 4 weeks, we will try to step down PPS and see how he's responding.
The vessel, should you seal the vessels?
Yeah.
The coag grasper?
This look fine because we are going to spray.
You just can do coag grasp of the vessel.
Okay.
So that it's better.
Yeah.
So there is no delayed bleed.
Yeah.
Hardly it will take another 2 minutes.
Yeah.
So always identify vessels, coagulate them, and come out.
So at VGM hospital, we try to, after EMR, to enhance sealing, and for achieving hemostasis, we always use collagen spray. Sir, you want to speak anything about collagen spray?
Yeah, I spoke even in the other room. I was speaking about collagen.
Okay.
So yeah, these are vessels which you probably can even touch, if you don't want to hold.
Oh,
yeah.
already.
Yeah.
Yep, hold. Yeah. Open.
Yeah, that is sealed. You should grab the next adjacent vessels next to that, and then try to, seal all the vessels. Yeah, these vessels should be definitely sealed before you start coming out.
Open. Close. Open. Close.
See, this soft coagulation mode, you don't need to cut. So this you can even touch. The diffuse thing, you either grab or touch. Yeah, whatever. If you grab, you can grab it. No problem. Open.
Close. Close. Yeah. Open. Close.
Are there any more vessels? Just watch properly before you come out. I think these vessels have to be sealed. You see this large vessel there?
Yeah.
So that has to be sealed. Yes.
Close.
Yeah.
Okay.
Yeah.
Okay.
Grab. Yeah.
Open. Close. It's fine.
These are very tiny vessels. These will get sealed off with collagen. So any bigger vessels have to be sealed. So just have a look here. This
We'll
side,
just touch
left
it
side.
like this.
Yeah. That one also.
No, don't open.
Don't open. Just wants to touch.
Okay.
This leash of small vessels. They're like probably venules over there.
Okay. Should I cut more or this is fine? We left 2 centimeters.
Yeah. Just 2 centimeters. If you give a gap, it should be enough.
Yeah. Okay.
But if you think you're not left only 2, then you can cut more.
Fine. Should be fine.
Where are your markers?
Just beside this.
Yeah.
This is the marker. Down at
okay.
At 5 o'clock.
One marker there, and the other side, you've gone up to the marker.
First marker we tried. This is the one.
Yeah.
On the left side.
That means you're done.
Yeah.
Now you can just spray collagen and come out. So we'll go to the other room briefly to see how they are spraying collagen, and then we come back here. Are you ready to spray collagen? Can we switch to this OT? Yeah.
So
We
this
are
is
on
the,
Madura, you're live.
yeah, so
See.
this is the area which
Yeah.
we have resected. So that's like,
Would you like to coagulate these vessels also before
yes,
you
yes,
move
I'm
on?
definitely going to
Yeah.
coagulate all the vessels before we move. We have to, seems very vascular for this patient.
Yeah.
So,
Why we chose two cases by two different demonstrators is to see the differences of approach and, also the 190 Olympus endoscope on one side, the RDA, the new RDA scope on the other side, to show the advantage of RDA over just the NBI. So
just
that is
hold
why
it
we chose two
superficially.
cases, two operators, the same procedure, but can have different challenges because each patient is different and each operator might be differently doing small techniques which could be different from each other. So there's one who's there which you can grab and
Yeah. Hold. No, that's a bit close that side. Okay, we will grab it again. Open. I think, open. Yeah.
friends, we are not taking a lunch break. We are continuing with the demonstration of Allurion balloon soon after this, immediately.
Is that good enough?
Which is an OP procedure. And after that, we'll move on to the next procedure is ARMA, anti-reflux mucosectomy, which will be demonstrated by Sunil Chakravarghese. So, and then there will be transoral incisionless fundoplication and also endoscopic sleeve gastroplasty.
We are ready for the collagen
We are
spray.
ready for collagen?
Yeah.
Okay, great.
We just remove all the fluid.
So when you spray collagen, so we have to remove all the fluid. So, and also clean the, channel of fluid. And then we just inject some air or carbon dioxide in the working channel just to dry it up. And then we just spray collagen. So collagen spray itself will take hardly 3 to 5 minutes. And that's about it. Krainda. Yeah.
So what happens is, yeah, we'll go to D1 and leave it there. Yeah. Ready? Yeah.
That's a beautiful dissection all around. So leaving 2 centimeters on
It's
the
not
greater
very
curvature
visible,
side.
the 2 centimeters,
Yeah.
because we are very close to the OG junction.
Yeah, that's right.
But this is the first mark.
Yeah.
And that is the last mark, which
Yeah.
I think it got buried in this one. Yeah.
Correct.
Yeah.
So that's fine. Perfect. Go ahead.
Okay, so we will start spraying. So
The collagen spray catheter comes with the preloaded syringe, which is a cartridge, along with the bellows. So to enable you to force, we also have an air pump, so which can also be used to augment the spray. And again, the snowstorm effect is one problem that always happens, as with Cook's Hemosil spray. So we just focus and start,
the only enemy is moisture. So otherwise it gets clogged up immediately. That's the start of the thing. We'll start spraying.
Yeah.
Yeah. Spray more. Yeah. So we'll keep spraying around. All around. I think that should have covered about it. Let's check after we stop. Yeah.
You
We'll
put
stop.
some water on the lens. I think in this room the procedure is completed. So we'll just show the final effect. Post EMR, how does the OG junction look? Post collagen spray.
Little bit
Take
air.
that to the antrum and push it out.
Yeah.
Maybe.
Yes. So that is the post collagen spray, but that's not the place we resected.
Use RDA to check because there is some blood there. Just check if
That is the location.
that's
Yeah.
the old blood.
That's the location.
Yeah.
That's where we did.
There's a small pool of blood.
Yes, there is definitely. No, I think we'll spray here once more. It's
Yeah.
not sprayed.
One
here.
more spray.
One more time.
For this segment, it is not sprayed.
This part seems to be all right.
Yeah.
Fully sprayed. It's only the last part.
So we always straighten the scope and bring out the catheter in the straight position, not in the J position. Sometimes it can get bent. And the transparent hood always protects, so you can keep it inside. So all this segment is completely, filled with collagen. So now we move to the unfilled segment, and then we just spray and come out. So see the difficulty that she has in J even reaching there, because we are close to the OG junction. We follow the 1/3 of esophageal side and 2/3 of the gastric side. So
Where is that? Just somewhere around here. The other side.
yeah.
Other side. Oh yeah,
Yeah,
we
yeah,
have
there
crossed
it is,
it.
there
Yeah.
it is.
Yeah.
Yeah.
Okay.
Start
So
spraying, yeah.
no, we'll just pull the catheter
Yeah.
a bit out and then we can spray. Yeah, spray. Yeah, we'll just go to the other side. One second. Stop. Now, okay. Yeah, now
Yeah.
spray. Yes. Perfect. I think that's good.
So I think we are done in this room. So thank you, Madhura, for a wonderful demonstration.
Thank you so much for this opportunity.
Procedure, invention, how to do an endomucosal resection. So
Yes.
and this is ARMS, anti-reflux mucosectomy. Now we'll briefly move to OR2 to see how did that procedure go through, and then we'll start the Allurion balloon in this room. So
Yes. Vamsi sir, are you back with you, sir?
Yeah. So
We're ready?
we made one more cut just to make it. Now we left this gap. So after healing, the patient will be much better. There is a small bleeder, I think, which will tackle.
Coag graspa?
Yeah. Yeah. We are trying to just coagulate that area, or will come on the other side. Yeah. Open. Yeah. Hold on. Wait. It's far away. 1 minute. Just Not happy with the X-ray. 1 minute. Yeah. We'll just untwine this. Wow. We can, on forward viewing also, we can try to do this, I think. Looks fine now. Yeah. Yeah. Open. Close. Close. Yeah. Open again. Close. I think the okay. Open. Open. Close. Yeah. Give me some water wash. This is fine. We'll leave it like this.
Sorry.
This is twisted over here. No.
Yeah, that's okay.
Looks fine. We'll just spray collagen now.
Okay.
I'll just inspect the area. Quick grasper. Close. Just hold the scope like this.
There's a difficulty in reaching the spot on J.
Open.
So, yeah.
Open. Open.
You can, yeah.
Close.
Yeah.
Open. Close.
Yeah, that's coagulating.
So all axes, when we are exchanging, we are trying to make the scope straight so that the exchange of the axes is much easier. We'll just spray collagen at the mucosal defect which we have done. Yeah. While introducing the catheter itself, we'll try to keep the CO2 on while before spraying collagen.
Off.
And it's better not to have any contact with water.
Mic irukkutumba. Edukka venda.
Because that itself will form a coagulum before spraying collagen. Yeah. Ready?
It's off. It's off or on? Huh?
CO2 is off. No. Yeah. On pannaga again. Yeah. Yeah. In our catheter. We're trying to change the catheter because got clogged. This should be the straight before doing. X-ray should be straight. CO2 on. This should be straight. The X-ray should be straight. Yeah. CO2 is on. Yeah. Okay. It should wait. So this is a snowstorm appearance, but I'm in place, so I'm not losing the focus. That should do. Forward view. Okay.
Hello, hello. Yeah. So what we should do is one is should completely suck out everything, and also if needed one more collagen spray can be done so that the healing is good. And also any patient who's ventilated, sedated, intubated, you should always suck out all the fluids so that there is a risk of aspiration is avoided, because in this procedure we'll be going on putting this thing water. So we just have to spray this area again, maybe. Just go down, show the area. Yeah, there is some raw area here and some ooze also. So just use quag grasper here, please, to stop the ooze, and then we spray.
Close. Open. Okay. Close. Open. Close. Close. Open. It should be good.
I think one more collagen can be sprayed.
Yeah. Open. 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 Close. Close. Yeah. Okay.
So for want of time, we just stopping here. We'll just spray some collagen for this and we'll come out. So thank you so much, Dr. Vamshi, for this wonderful demonstration. Now we're going to see the Allurion balloon, which is an obesity balloon, which can be given to the patient like you swallow a capsule. You don't require sedation. You don't require any, procedures, anesthesia, nothing. So we have an elderly gentleman who's going to swallow this balloon right now. So before that, we see the video on the Allurion balloon. So the EDP team can now play the Allurion video. Yeah. So Bruce, how did it get this? See the demonstration of Allurion balloon, and I thank Dr. Mohit Bandari from Indore, who's been kind enough to provide the Allurion balloon. He was supposed to be here today, but unfortunately he's unwell and he couldn't join us. But nevertheless, we have Dr. Bindu Smita with us from Mohit's unit. She's a medical doctor. She'll be demonstrating the Allurion balloon, and you can focus upon the patient. You can focus the patient, please. Here is a 73-year-old gentleman whose BMI is 35, and we're going to demonstrate how he easily swallows this Allurion balloon, and we are going to use the Allenger's DigiScan, the latest digital C-arm, to see the how the balloon expands in the stomach after swallowing. So over to Dr. Bindu to explain the parts, and then we move on. Can she have a mic? Yeah. Yeah.
So what is the specialty of Allurion?
So the since Madam is still not linked, but you see here, this is the container with 500 ml of fluid, and this is passed on into the Allurion balloon. The advantage is you don't require an endoscope, you don't require anything, no sedation, no anesthesia, just swallow it like a pill. So can I have the demo piece which you had? Yeah. No. This is how it looks. After going into the stomach, this is how it expands, and now you're connected, are you? Yeah. Not yet, Dr. Bindu. She connected.
So this is a balloon, how it looks after we fill the balloon. It has 50 ml of fluid inside. You can see there is a valve here. This is called a release valve. It is tied with a suture. Since it is a demo balloon, suture is not there, but it's tied with a previous suture. So after 4 months, the suture disintegrates and the valve opens up. So when the valve opens up, the fluid which is filled inside the balloon is deflated. It comes out and the balloon is deflated, and the balloon passes out with the stools. So that's the mechanism of the balloon.
So please give Madam, gloves. So you can gloves are here. So you can just wear the gloves. So this is the swallowable balloon. ஐயா இதை தான் நீங்கள் முழுங்க போகிறீங்க, அவ்வளோதான், சிம்பிள். மாத்திரை முழுங்குற மாதிரி. அதுக்கப்புறம் அதை பெருசாகிடும். ஸோ we just keep the patient for at least for 12 hours. We just, what is the preparation that you give, for this patient?
So we keep 4 hours NPO, and before 1.5 hour before the procedure, we give aprepitant, which is an antiemetic. So there are 3 doses in this medicine. There's day 1, day 2, and day 3, which is given as for 3 days. Day 1 is 125 mg, day 2 and day 3 is 80 mg each. Okay, this is.
Why do you have to give this?
So this is mainly to prevent intolerance after the balloon procedure. And second thing is, since it is done without anesthesia, the patient may have gag and lot of nausea while we are doing the procedure. So to prevent that, we give it 1 hour or 1.5 hour before the procedure.
So this patient has already received aprepitant and also has received ondansetron. And what else have you given?
The patient has taken diclofenac and antispasmodic, just in case if the patient is having pain and cramps during the procedure. To avoid that, we are giving antispasmodic and diclofenac before the procedure.
That's it. And we're going to start this procedure. So please go ahead.
So the Allurion weight loss program, it's not just a balloon which they are selling, it works as a weight loss program. So this Allurion balloon comes with a health tracker and a weighing scale as well. So this is the health tracker, and this is the weighing scale which is given to the patient after the procedure, so that we can track the activity of the patient. So health tracker tracks the sleep, water intake, and it has a BMI and all the details of the patient. This is connected to the Allurion.
Yeah, that is a health tracker.
This is the
which
health
is
tracker.
showing.
Okay.
Can you open the health tracker?
Definitely. It's just like any other smartwatch.
Like a smartwatch.
Right. Okay. So this is a connected scale. This is both of them are connected via Allurion app on the patient's smartphone. So every time the patient stands on the weighing scale, the weight is recorded onto the app, so that we have the entire history of their weight loss. So Allurion comes as an entire kit. We don't need a saline bag separately. It comes with a filler kit. This is a 550 ml of filler bag, and it has a filler tube. And this is the balloon. This is the Allurion gastric balloon. And we also have something like a guide wire, which is called a stylet. So this makes the patient easier to swallow the balloon.
So it's important that the patient understands what he is going to undergo. Otherwise, there'll be a lot of anxiety among patients. But this gentleman has already been primed, so he knows what he's going to do. It's just going to be simple. He's going to swallow the pill.
So there is no need of endoscopy, just swallowing one pill.
So Dr. Vamshi is asking no need of endoscopy.
No, we don't need an endoscopy.
He's very upset.
That is the USP of this balloon. We don't need an endoscopy to put it in, and we don't need an endoscopy to take it out.
We've been doing obesity balloon through endoscopy for the past maybe a decade or more. But this one is so simple and easy. You don't need to put in, you don't need to take out. It just passes out.
So this is the balloon.
So who manufactures this Allurion? Which country does it come from?
This is from US.
United States. That's why it comes always with smart gadgets like smartwatch and everything.
So you can see this is the capsule. This is a gelatin capsule inside which the balloon is folded and kept inside. So it takes 2 to 4 minutes for the capsule to disintegrate and open up. And after that, we can start the filling.
Do you need to lubricate this or dip in water?
We don't need to do anything. As patient swallows, patient saliva will help him to swallow it, and also he's drinking water continuously, so it will slide in easily.
So it just passes in.
Right.
Okay. Need some gloves. Just help her.
So there are 3 markings on this catheter. You can see there's 1, 2, and 3. So this is the 30 centimeter marking, this is the 40 centimeter, and the 50 centimeter marking. So we put it till the 3rd mark, so it ensures that it is crossed beyond 40 centimeter marking.
So the single marker is 30 and 2 markers are 40 and then 3 markers are 50 centimeters from the incisors.
Yes.
That means to ensure that you cross the OG junction even in the tall individual.
Right. You can take the glass. I think I need one of you to translate to him.
Yeah. But you tell me, I'll translate.
So I'll just keep the capsule in the mouth of the patient. He'll have to keep drinking water continuously.
Sure,
As he swallows water, the balloon just.
Yeah. So இது வந்து அவங்க நீங்க தண்ணி கொஞ்சம் வாயில வெச்சிங்க அதுக்கப்புறம் இந்த ஹாட் வாட்டர்.
No, it's a normal.
இது ரூம் டெம்பரேச்சர்ல தான் இருக்கு. ஹாட்னா அது மெல்ட் ஆயிடுங்க. வேண்டாம். இதே யூஸ் பண்ணலாம். அது உருகிடுச்சுன்னா அப்புறம். யா. ஓகே. சோ அப்ப வாயில கொஞ்சம் ஒரு லேசா இத்துணூண்டு ஊத்திக்கோங்க.
Normally
அப்படியே வெச்சுக்கோங்க.
He'll have to sip it directly from the glass.
இதுல இருந்து டைரக்டா நீங்க இந்த குடிச்சிட்டே இருக்கணும். அது வாயில வெச்சிருவாங்க. அப்படியே அதை முழுங்கிரணும் அவ்வளவுதான். That's it. சொல்லுங்க. கடிச்சிராதீங்க. அவ்வளவுதான். இப்ப குடிங்க. அது கப்ல வச்சு தண்ணி குடிச்சிட்டே இருங்க. நீங்க பாட்டி குடிச்சிட்டே இருங்க.
Keep drinking.
குடிச்சிட்டே இருங்க.
Keep drinking water. Keep drinking.
மெதுவா.
Keep drinking. Swallow. Very good. Keep drinking. Drink.
இன்னும் குடிக்கணும். அவ்வளவுதான். போயிடுச்சுங்க. ஆல்மோஸ்ட் முடிஞ்சது. வெரி குட். Very good. முடிஞ்சது.
Okay, stop drinking water.
போதும். Sure.
Now close the mouth. Mouth close. Okay.
வாய் மூடி வச்சுங்க.
Okay, he can stand up so that we can take a X-ray. Yeah, we'll have to take an image.
நல்லா இருக்கீங்களா? ஐயா அவ்வளவுதான் முடிஞ்சது. ஒரே யா யா whoever is not wearing an apron can go out please or go behind. Shanmugh Sundaram, please leave.
So if they can see the image of the C-arm, you can see there is a slight turn in the stomach. The catheter has taken the right turn into the fundus. That ensures the capsule is in place.
Correct. Absolutely.
Yeah. So we can start filling now. Okay.
After filling again, we can rescan.
We can rescan it.
No, slowly. Put a towel underneath. That sheet is. Yeah.
I need an heavy stand this side.
Does you need the stand that side? Okay.
So now we are connecting it to the filler tube to start the filling.
So that has got a 3-way stopcock, and she's opening the 3-way stopcock.
Now you can see there is a drop by drop.
Yeah.
As the balloon opens up, you can see the continuous flow of the fluid.
So you just pump in some air
We are
to push
just
out the
increasing
fluid.
the pressure to push the fluid down.
Now you can focus here, see the continuous flow here in the Yeah, you can see in the transparent this thing, you can see the continuous flow, which means it has opened up, the balloon is opening up and it's continuously flowing. So how long does it take for the fluid
It takes
to pass?
5 minutes, 4 to 5 minutes for the
And
fluid to be
what is
emptied
this
from.
fluid that is there?
It's a proprietary fluid from the company, which they don't disclose what
It is not
made of.
water.
It is not water because we can't keep the water in the stomach for long time as it has infection properties.
But no, not really, because there are many balloons what we have been using for 2 decades or so have all contained only water. So nothing has happened. So these balloons, because it's not a sterile track, so because it's inside the stomach, even if by chance these balloons get corroded, the water will flow out.
Yeah.
So there could be some idea with which some fluid specifically has been made by Allurion to make it available here, to produce probably a dense liquid, and then probably that also helps in the dissolution of the suture after 120 days.
Yes.
So slightly more viscous, yeah. So the density is more.
No,
No.
because they say it's not required and they have not tested it with methylene blue. So we don't know how it works with methylene blue. No, the balloon is designed to deflate on its own and pass out through the intestine. So the chances of bowel obstruction is very low because it is designed for the same. Yeah.
So how many Allurion balloons have been deployed globally at this point of time?
They have reached almost 1 lakh procedures now.
1 lakh procedures. When was it introduced in the United States? Almost 5 years?
It's been a year, 5 to, they are reaching close to a decade, I believe.
A decade, almost reaching a decade. But in India, it has just come in probably less than a year.
Yeah, it's been a year since we started here.
And it's only thing is it's a little expensive for Indians, but I'm sure affordable Indians can always use it. So because it's so easy and not cumbersome, so that way it will be really helpful. So and automatically it passes out. So are there any reports of this 1 lakh renderings of this Allurion balloon? Are there any reports of any obstruction of the pylorus, any endoscopic necessity for endoscopic intervention?
There are a few cases where they had to do an endoscopic removal of the balloons, but mostly this is a very safe procedure, balloon procedure, which is available.
Like what percentage could have this sort of necessity to, like if it goes and obstructs the pyloroantrum, then that completely gets closed, and then you have to endoscopically go intervene.
We'll have
to puncture and then
we have not luckily we have not got any cases so far like that, since we have placed around 800 to 1000 balloons in last 1.5 years, but we have not had any cases which has obstruction.
That's very gratifying. 800 to 1000 balloons in India, and we have not had an opportunity of going endoscopically to remove. That means the complication rate is less than 1 per 1000.
Right.
That's literally not a complication rate at all. So that is something nice about this balloon. Nice to hear about it. So what amount of weight loss that you're seeing? What is the minimum? What is the maximum?
The average weight loss with this balloon is close to 15%, which is what we have. More than weight loss, the tolerance of the balloon is better compared to that of any other balloons.
So my another question is, like it is like any other space occupying lesion inside the fundus, any other balloon. All balloons are like they distend the stomach. The fundic area is the area of accommodation. So like even with little quantity of food, you feel you're full.
Right.
So it takes probably 48 to 72 hours for the brain to adapt itself to understand that this is how it's going to be. The signal of satiety probably, which is constantly going in the first 48 to 72 hours will be probably, shut off. It will not reach the conscious brain. It'll keep going, but won't reach the conscious brain. So patients don't feel, disturbed. But my question is, like, what happens after 48 to 72 hours? Is there any still there are patients who keep complaining of this epigastric fullness,
Yes.
feeling of fullness?
The feeling of fullness would be there for the same feeling what they had on the first day would be there for at least 15 days for them. Post 15 days when they go on to their normal diet, they'll not be able to eat as much they were able to eat earlier. At least it is reduced by 50% of their volume.
So these 15 days, what medication do you give to keep them
for balloon,
comfortable?
for especially for first 3 to 5 days, we give medications only for the symptom management. We give ondansetron and we give antispasmodic and diclofenac just as and when required. And PPI is mandatory for throughout the period of the balloon. So we give PPI BD for 15 days and after that we give it once a day.
For 120 days, you can keep them on PPIs?
PPIs, they should be on PPIs for 120
Why?
days. It is mandatory to be on PPIs.
Okay, that's interesting. But I do not see any necessity for PPIs for 120 days. But we'll have to probably look into more literature,
Right.
dive into literature as to find why PPIs are indicated.
We are done with the filling, so I'll just.
It's over?
It's over.
Wow, very nice. As we are talking, the filling is over.
Yeah.
Very nice.
So I'll
Now-
remove the catheter and then we can take in another X-ray.
Yeah, sure. Now see how it has been filled, and now no more flow of fluid. Now she is removing the. முடிஞ்சு. எடுத்து மூச்சு விடுங்க. முடிஞ்சது அவ்வளவுதான். Finish. அவ்வளவு. Finish.
Can see?
See, that's
Balloon
it.
is
That's it.
removed.
துப்பணும்.
You can
Okay.
get a.
One second. Kidney tray.
Yes, sir.
Yeah, the gag. That is a gag reflex which has produced this. So he should be fine.
Okay. We
Yeah.
can take an X-ray.
I'll take it. No problem. So, கொஞ்சம் தண்ணி குடிங்க ஐயா. சும்மா
Little,
கொஞ்சம்
small
குடிங்க.
sip.
Just very little. Thank you. போதும். That's enough.
You're
So,
feeling
how are
full.
you? How are you, sir? நல்லா இருக்கீங்களா? அவ்வளவுதான். அது எடுக்கும்போது அந்த கேக். So while removing the catheter, there was a gag reflux, but patient has settled down very well. இப்போ அங்க நின்னீங்கன்னா ஒரு எக்ஸ்ரே எடுத்து பார்த்துக்கலாம். பலூன் எப்படி விரிஞ்சிருக்கு. அவ்வளவுதாங்க. முடிஞ்சது. Finish. Come, please come. வாங்க. வரு.
Yeah, as we were demonstrating, he told there is some fullness.
இப்போ அந்த வயிறு வந்து கும்முன்னு இருக்குங்களா உங்களுக்கு இப்போ? இல்ல. Now is okay. அப்போ இருந்தது ஆரம்பத்துல. So while the balloon inflation was going on, வயிறு பெருசான மாதிரி இருக்குங்க. Okay. He feels a little bit full, but he is comfortable. So he's not distressed. Right. So now we'll go. We'll have an exposure. All people not wearing aprons, please leave the room. Sir, you're not wearing an apron. So. Yeah, we can screen.
Yeah, we can see.
You can move the C-arm a little bit to cover the entire fundus. C-arm can be moved a little bit. C-arm, move. Not this side, this side. You have to come this
Patient
side,
has
left
to-
side.
Yeah, this should be
நீங்க
fine.
அப்படியே இருங்க. Stay on.
This should be fine.
Yeah. Screen.
Yeah, you can see.
Yeah.
I'll show you the balloon there.
Yeah. Can you show that balloon? Madam
So this is the wall. This is the wall of the balloon and this is the shadow of the balloon. Okay, this one.
So it is not completely filled with fluid.
No, it's not a radio opaque fluid. So we can only see the air in the balloon. The small air bubble. We
Yeah,
can
there
see.
is some air also there.
This is the one.
Yeah, there's some air and then the balloon. Slightly darken it and then probably you can refocus later on. 1 second. Yeah. So now can you rescreen? Screen again. One more screening, please. Yeah.
So this is the valve of the balloon with which we have filled the balloon and there's the shadow of the air inside the balloon. This is the one.
Okay. Very good. வாங்க சாமி. Please come. See, அவரை காட்டுங்க. நல்லா இருக்கீங்களா? How are you? Goodன்னு சொல்லுங்க. Fine. Wow. Good. Excellent. Thank you, sir. Thank you. Please. Very good. Yeah. Please come. Wow. இல்ல. Yeah. So, yeah, this is, I understand this is the first time of live demonstration in a workshop, first in Coimbatore. This is the first live demonstration in Coimbatore of this Allurion balloon, which, we have done on a 73-year-old gentleman. So we're tolerated it very well. So we'll keep you posted, folks, how the weight loss is. Now we move to one more procedure in the next room. That is the ARMA anti-reflux mucosal ablation. This will be done by Dr. Sunil Chako Varghese. So over to OR2 for this procedure. After that, I know. I announced. Oh. Oh. We'll first there will be a video of TIFF which will play the transoral incisionless fundoplication. We will see Dr. Mohit Bandari's demonstration of TIFF. So to EDP team, can you play the video of Dr. Mohit Bandari on TIFF? Transoral incisionless fundoplication Isofix device. So we'll watch that and then we will see the ARMA procedure and then we'll move on to yet another demonstration of sleeve gastroplasty. And then finally, you will listen to Dr. Mohit Bandari and tips and tricks of doing the endoscopic sleeve gastroplasty, which will be of great help to all the beginners.
We don't have this problem here. Mohit doing great. See? Okay. More. Go more. You're good. Try to. Good. All good. Now, very important. Keep it here. Keep it here. Yep. You should put it with. Good. Try to see if you can pass. If you feel resistant, tell me. Good. All good. Okay. More. Okay. This is too big. See? Now, what you're gonna do is, no. Look, before you do that, show him. Now you have to go on the direction of the greater curvature. Now start. Knobbing. Knob. But you see, you direct to here, see? Good. Now bring the scope down inside. No. We're not talking to him. Bring the scope inside. We need more insufflation. Let's put this. This is not bad. Bindu, can you detach here and retach again? Okay, good. Make sure we don't have any Need more insufflation a little bit. Is anything on? Oh, good. Looking good, guys. No? Good image.
Looking very good. Yes, great image.
Okay. Uh, okay. Just needs to have more insufflation. Good. Okay. Now bring it inside and show us. Show us. No, good. Okay. We'll do this first, Mohit. So look, no, but that's I wanted to show you that how we go here and here. Oh, put the first. Okay. Yeah, let's load. Okay. If you should not, because you do, we lose the site. Okay, guys. So try to show me there. Good. So now we are trying to go to. Now show me. Good position.
You're at 8 o'clock.
Huh? 8 o'clock. You're killing me.
I know. I demand perfection, Gelbo. I know that you can do it.
Okay, show me more.
There you go.
Good.
Yes.
A little bit inside. No, that's the buttons. The buttons. No. Yeah. Okay. Now unfreeze. Unfreeze. Button. Good. Now try to show me. Nope. Okay. Oh wait. Was very good. That's why we. That's why you should not never lose the sight. Now this is. Yeah. Looking good.
Yes.
Okay. Helix unlock.
Yes.
You can even go in the zone. Good. Now. Now we lock. If you pull, it stays. Now we pull this side. I don't think I can get it a little bit. Do you think I can get more?
I do. Come back towards us and pull the device out of the patient.
Let me pull the helix a little bit more.
So untorque it.
Untorque it. Oh,
Yep.
first you want.
Pull. Open the device 2 clicks.
It's not opening.
Actually, take it all the way to the. Yeah, okay, now pull the device. First, screw the helix in some more. Yep. Okay. That's right. This is a better spot anyway. Put the helix in right there, inside the lip.
Here?
Inside the lip. Close the station mold 2 clicks and then advance the helix.
Like this?
Yes, better. That's better. Okay. So Galbo, I'd like to encourage you to do a free willy maneuver here. You need to get that helix out of its channel. So can you bring the mold to us? Counter rotate counterclockwise towards 6 o'clock with your tissue mold.
Like this?
Yep. Open 3 clicks.
Okay.
Give a little tug on the helix.
Pull the helix.
Just pull it a little bit. There you go. Okay, now pull the device out of the patient to cover the blue band. Good. Push in scope. Good. And you can also have your scope operator give you a little bit of tap suction, but you have a much, much better bite now. Watch that helix though. You don't want it to rip out. I would close the tissue mold 2 clicks.
Okay, good.
Good. Pull the device out of the patient another 1/2 centimeter. Good. A little more traction on the helix. Make sure the helix is locked.
Locked.
Push in scope.
Okay.
Good. Rotate 30 degrees with some tap suction by your scope operator.
Here.
Let's close that tissue mold 1 more click.
Okay.
Good. Now wrap some more. 10 degrees.
It's the maximum I can.
Okay. Clamp it down.
Clamp it. Now
Okay.
suction.
Were you trying to get to 11, Jeff?
It is
Yeah.
11 there. No?
You're at 11. Yeah.
Okay.
I'm fine with that bite.
Oh, fire.
I would not push in. Just fire right where you are.
Fired. Now we reload. Guys, one of the guide wires are not going well.
Okay. What you need to do is grasp it with your fingers, retract it gently, turn it 90 degrees, and re-advance the green sleeve itself.
Now it's going. So what we're gonna do here, we're gonna open up 2 clicks. So let's move.
Yes. I would open 3 clicks and move the tissue mold to 8 o'clock. Unlock helix, let it relax, and then re-engage.
Open.
Yep. Unlock helix.
Unlock it.
Good. Reposition the tissue mold towards us to about 8 o'clock.
Like this.
Yes. Good. Put the helix lock back on.
Okay.
Pull the device out of the patient 1 centimeter or 2. Now 1. Okay, good. Now traction on the helix and make sure the lock is on the helix.
Lock it.
Good. Close the tissue mold 2 clicks.
Okay.
Rotate 30 degrees with scope suction.
Scope suction. We're ready to go now?
Yes, clamp it down. Good. Lock, suck.
Fire.
Not much push. Yeah, fire. Okay, can I watch you reload, please? I'd like to watch this reload. Can you move the camera so I can see the reload? Okay, thank you. I just want to see how it's functioning.
Okay, can we reload?
Yes, yes.
I'm not seeing the click. Okay. Going good. Now looks better.
It does look good.
Okay.
Good.
Open. Helix selected.
Yep. Very good. Very good. You can get 20 degrees of wrap.
Need another one there, but relax. Go to wake up.
I would open the tissue mold 2 clicks.
Good.
Okay, now close it 2 clicks. I just wanted to take some tension off of it. That's good. Close it 2 clicks.
Yep.
Okay, pull the device out of the patient a little bit more. Yep, good. Okay, now wrap with scope suction.
Wrap. Now.
A little more, just a little more. Okay, clamp it.
Clamp.
This time you need to do the full lock, suck. You have to push in on this one. It's a much deeper bite.
We have to push. Okay.
Yes.
Okay, good. Good.
Yes.
What? Oh, good. Now let's go. Go. Now, press. Yeah, lock. Open. Open the button. Now, I understand. But now, move. Okay. Now, move the device. Now, move the device. Now, rotate to the other side. Now, you can. Wait. Move the device. Now, see? Good. Now, close enough. Close enough. See? Now, good position, guys.
That's 12 o'clock. I'd come towards us a little bit.
Good. That's good one.
No, that's 11 o'clock.
Wow.
Yep, you're clear over at 10 o'clock now.
10 o'clock. This is 12.
Need to bring. No,
See?
I don't think so. Hold the device right where it is and swing the scope around. You'll see that that's about 11:30 right now.
Okay.
1 o'clock is right where you see that little bit of a line, vertical line. See that? No, you're way out. You're now at 11 o'clock or 9 o'clock with the tissue mold.
So as much as we rotate, your clock goes back?
That's the wrong direction. 1 o'clock is right in front of your face.
Here?
Nope, that's way more towards us.
Oh, I understand.
More toward,
Rotate too much.
more towards us.
No. Here?
Yeah, that's 1 o'clock.
See, you just passed.
Actually, it's still 11:30.
What do you want?
Move the tissue mold clock counter. Yeah, that right there, 1 o'clock.
We don't have installation. This thing here is up. We are not seeing the other side. I don't know why.
The posterior wall is pushing in. It's creating an optical illusion. But you're at 11:30 right now with the tissue mold.
So let's position first. This is what you want?
Right there. I would open tissue mold 2 clicks.
Okay.
Yep. And put it in there. That's still almost 12 o'clock. It might be a little tight. It'd be better if it was towards us a little bit more.
Where do you want? Here or here?
There.
Here.
Yes. Still 12 o'clock. Come towards us more.
Sorry. Like here. Here?
A little more.
Here?
Yes. Perfect. Perfect. Okay, now I'm gonna ask you to do something here, please. Push in the helix and slack it. Bring the mold way over towards us. Turn the mold over towards us 90 degrees. Nope. You're getting ahead of yourself. Push in the helix.
We don't understand your English. You're
Okay.
talking too good English for us.
Forgive me. Okay. Push in helix to slack that wire.
Okay.
Okay. Turn the tissue mold clockwise 90 degrees. Other way.
Tissue mold clockwise. Okay.
Towards us.
Good.
No. Towards us. Turn the whole device towards us more.
These or these?
Other. There you go. Okay. Now, hold it more towards us. Tissue mold towards, yep. Good. Okay, now put the lock on the helix.
Lock it.
And give small traction, not a lot of traction.
Small traction.
Good. Pull the device out of the patient until the blue disappears.
Okay, blue disappears. All right.
Very good. Push in the scope. Close the tissue mold 2 clicks.
Just a second. Go ahead.
Okay. Close the tissue mold 2 more clicks.
Okay, 2 more clicks.
Pull the helix a little bit.
A little. Good.
Clamp it down.
Clamp it down.
And don't move it. Just fire right there.
Okay.
With invaginator on, but don't move. Right there.
No. Listen, just fire. It says just right there. Didn't say no suction, no?
You can put on the suction, but just don't push.
Okay, fired.
Fire. Okay, reload.
Can't. Position. Okay, reload.
Okay, yes, please. That was a good one. It was hard, but you did great.
Okay.
Okay. So that was an important firing. Now all you need to do is reinforce that. You don't have to do a lot of twisting or torquing or anything funny. Just try and put the fastener somewhere different than you put the last set, but in that same basic region.
Okay, I'll talk to him now. Move. Okay, good. Good.
I think you're fine. I'd clamp it down, put on the invaginator and fire. A little push this time.
Okay, clamp. Clamp it. Suction. 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 Okay. I'll pull it. Okay, fire. Very nice.
Nicely done.
Okay, reload. Very good. Now we take off. Off. Off.
Yes, I
Bring
like
the helix
that.
a little
I
bit
like
to you.
that. Yep. Put the lock on the helix so it keeps your traction for you.
Okay, I just put it. All good.
Yep.
Now pull the looking good.
Yes.
Suction. Very okay. Abstract.
Nicely done.
We lost a bit. Good. All good. So
You're
now
good.
open. Okay. First, hit it. Abstract, can you show us the hit it? Good.
Did you reload?
That's it. You got hit it. Good fight. Think that the helix is a little bit stuck. I will open up the. Okay. Should I push the device in?
Yes.
Okay. Which side?
Nice. Nice.
Make push. Stop. Looking good.
Looking very good. You're doing a great job.
Reload it.
I don't think so. I did not see you reload.
Yeah, me too. Let's reload. play. Go to 5 o'clock. Good. That's the same thing. No, no. No. Yeah, please. But Abhishek have to go to the other side.
Can I suggest that you bring the camera back over to that side and do 7 first, please?
Okay, like this?
Camera to the other side of the tissue mold.
Yeah, okay.
And may I suggest you move the tissue mold further over and do 7 o'clock. I think it'll help you get
This.
orientation a little bit better.
Here?
Yep, that's 5 o'clock, 4 o'clock,
5?
5,
Okay.
5:30.
This is okay?
Yes, that's good 5.
We are losing inflation at why? Guys, we're losing inflation. Why? That's not 5. See? Exactly. No. Look. See? You can play with that like this.
There you go.
Here?
Yes, agreed. 5.
5.
Good. Good spot.
Now it's time. Now I just hit it, and as we have to pull the scope back here. Okay?
Nicely done. Nicely done.
Good.
Great job. Yep. That is as big of as much length as you could possibly achieve right there.
Quite more. Open. Now, open up. Open. Awesome. Good.
Good bite.
Suction?
Yes. Make sure you put on suction and do push, please. Yep. Right there.
Fire in the hole.
Fire.
Okay. Loaded.
Nicely done.
Good. What? Because I'm here now. I'm just feeding you guys. We can. And just I'm not complaining, just observing. Okay. Because it's a new device, and every single transfer was like this. What I feel. Good. Now open.
Doing great.
Turn the locker. Turn the locker. Hit it. Hit it. There's one. No, only one lock. Yeah, because we take the pressure, and then you can adjust. Good. That's good. Lock. Good. Now pull inside of the fit. Try to pull the mesh. You see? Look at okay.
Looks great. Max length.
Okay,
Nice job.
Really, once you unlock and you start pulling, you have to lock, because otherwise it's gonna go back. Looking good, guys.
Looking great.
Okay. Clamp
Just
it.
make sure you fully clamp it and push in this time for sure.
Case section. Just a second. Okay. Fire. Okay. All good. Suction off. Reload. Have 2 more to go. Hold up. We have 2 to go. But now, how we gonna okay? Let's now look inside. First thing is unclamp. Now we'll put that inside. Okay. Take it up. Yeah, but okay. Go to 7 o'clock. First which side? 7 o'clock. Okay. That goes. We don't want to go here. Looking good. Like it should.
Perfect.
Okay. Engage it. Open. Good, good. Now go to the side. Stop. Get it flush. Get some little bit more tension. Good. Now push to the side. But you always get it.
So you're doing great, but I would close the tissue mold 2 clicks and add some scope suction while you pull.
Okay. Suction. Good. Little bit
Good.
healing. Okay. I think it's the maximum someone can go.
It's
Just a second.
it's the maximum. Yes, I agree.
See? Okay.
This is a very big bite. I would do this slowly.
Okay.
So make sure you lock, suck,
Suction
push
on the
out the
scope
diaphragm,
The scope also.
and fire.
Okay. Fire.
Squeeze the trigger really fully against the handle, please. No fire on more. If you fire on more, you ruin everything because it's the needle that goes without any. You fire, it fires. This is fire. So now what you're gonna do is suction up, over here. Locker. Locker. Okay. Open. Good. Now reload. Everything is doing fantastic. Okay, ready? So now this is the game, okay? This is gonna be your best shot. So try to it's good. Okay, lock. Okay, pull a little bit. Get it. Okay, the device. Good. Good position, guys. Perfect. You're doing great.
Clamp it. Okay.
There's a big bite again, so nice and slow.
Fired.
Yay.
Sir, your mic on, sir. You're on live.
Oh yeah, hi. Hello friends. So we're just briefly interrupting the transoral incisionless fundoplication video for showing a very quick procedure. This is called anti-reflux mucosal ablation, which has gained a lot of popularity of late. This patient has got again lax ileus. There is no hiatus here. So this is Hill's type 2 ileus valve. It's a very quick procedure. We just can paint some APC. We're using ERBI APC end firing probe, and this we have done the markers. You can see the markers. So I'll show you on the J maneuver, the fundic side. So these markers. So as usual, as we were seeing with the arms, we just do two final marks where we don't want to, cut. Those are the markers, the final markers, 2 centimeter markers, where we'll give a gap. So between the area to be, coagulated versus the area to be left behind, so that we get a horseshoe. So either you can paint like a horseshoe or like a butterfly. So we thought we'll do a horseshoe. See here, this is a wide open ileus, and like it's not a hiatus, but it's a kills 2 to 3, but not a hiatus hernia. You can see the squamocolumnar junction. I can show you the NBI. So this is RDI. I'm sorry, switch to NBI. Yeah, that is the NBI. You can see here the squamocolumnar junction is coming up. This is what we have done. See here, this is very much visible. This is a lax valve, and we just want to see the results because patient was against doing a fundoplication. So can we go to red light? Yeah. Okay, the white light imaging. Okay, good. So this is what we're going to do now. So we're going to paint using APC. We're going to skip this 2 centimeters on the greater curvature side. These two markers, that area will leave, and then the rest of the area we're going to do APC. Along with me, Dr. Sunil Chako Varghese, who will be demonstrating for most part. I'm just, giving the start, and then he'll continue. So you believe in clockwise or counterclockwise? Okay, any arbitrary point that makes my life easy. So probably, like we did these markers because just we wanted to know where to start from. So that we'll discuss little later. So we'll go ahead with start the procedure now. So I'm going to, start using the end firing probe, APC. So we're using carbon dioxide insufflation. We are using the ERBI APC end fire probe. So I'll try to go slightly non-touch mode as far as possible. Otherwise, we'll have to keep cleaning the probe. See, because of the respiratory excursion, it keeps moving. So I'm keeping my foot and the view, everything at my comfort range, because we need to keep repeating this. So you can paint like this for a distance of 2 centimeters. Let us see the first paint that we made. See. We started here at this side. Yeah, this is where we started. somehow the air is leaking. The air is not staying inside. So, I mean the carbon dioxide. We'll change the knob. So, yeah. Okay. Wow. That made a great difference. Yeah. Now it is much better. See, the air is staying now. Carbon dioxide is staying here. So, still there is some leak. Carbon dioxide. We keep burning the tissue like this for a length of 2 centimeters. So I would leave it to Dr. Sunil Chakravarghese to continue and complete this procedure. So it's a simple procedure which is very helpful. It produces fibrosis, and usually, like we do it 2 centimeter from the OG junction. So the carbon dioxide is escaping. You can keep cleaning the probe also. You can pull out the probe and clean it and put it back whenever you have some tissue sticking on. So this can be, you can remove the probe, remove the probe, clean it and put it back. That's all. So this is one problem with the APC probe. So with the tissue can get stuck to it because we don't have a water jet there. So that's a limitation. So we just keep burning tissues like this. So he just also, he brings out the probe in the straight position and then does a J maneuver in order to minimize the trauma to the APC catheter. So, yeah. Yeah, ERBI setting we are using setting 3, which is the APC probe setting, effect 3. So that effect 3 is giving only 30 watts. So many of the centers use 70 watts and 100 watts. So if you're using 100 watts, Dr. Sunil tells me that we have to inject, saline to protect the deeper structures, because otherwise thermal coagulation, burn injury can happen. See, this is what, if you can do without touching, then nothing like it. If the air would stay there, carbon dioxide stay there. If you do painting without touching, then, it just doesn't accumulate the tissue there. You don't need to keep on cleaning. Sure. Here what happens is lot of gas, argon gas will go. See, what happens is the argon gas forms a plasma on top of which the electric current produces coagulation. So that is why it's called argon plasma coagulation. So as you press the pedal, the first thing that happens is the flow of argon gas. So because of the touch method, the probe is getting stuck with tissue. If we can do it non-touch. So I know it is easily said rather than done, because there's so much of respiratory excursion there. So which produces a problem. So much of gas, argon gas gets accumulated. So you need to keep sucking the air so that the patient doesn't get bloated up. It's always wise to keep watching on the oxygenation parameters of the individual who's under, anesthesia, to see to that. And also where if the oxygenation is coming down, that means there's so much air in the stomach that is producing a compression effect on the diaphragm. So you have to be watching out in between. In between, stop the procedure, keep sucking out air. So So after the demonstration of this procedure, the trans-oral incisionless fundoplication demonstration by Dr. Mohit Bandari will continue. So we continue to do this, and probably we can revert back once that video is over. We would have probably progressed. What do you think, Sunil? You want to show some more of painting, and then you just later on you can say show the video, then they can switch to the video and come back. Correct. Yeah. Absolutely. So try to see if you can, side probes are also, side firing probes are even easier maybe, but most of them have used end firing. So non-touch, you can stay on top and keep pressing the pedal. Yeah, now it is much better. See, because it keeps moving, so automatically the tissue comes into contact. So it just goes, the probe goes and touches the tissue. So, but here we don't move the probe. You see, none of us moved the probe. Probe stays as such. Only the endoscope tip is moved or rotated or torqued, whatever. So the probe remains at constant position, and preferably the black marker should be out of the probe. Here the black marker is slightly inside. Can you just push the probe outside a little bit until that black marker is indicative of the place where the probe has to stay, so that it doesn't damage the scope. So again, while firing, do not press the pedal when you're focusing the endoscope, then endoscope can get damaged. Yeah. Exactly. Sunil, should we complete the tip video?
Yes, we can.
Yeah, we'll keep progressing. Can we, I request the EDP team to continue with Dr. Mohit Bandari's demonstration of the transoral incisionless fundoplication. Again, once we are ready, we'll call you back after burning quite a bit of the tissue. Over to the
The cap. You see the cap?
Yes.
Put it out.
Nice.
Oh, we move. You do this. Fix it. Oh, yeah. I have to clean the lens. Alcohol? Okay. All good. What the heck on that? Beautiful, no?
Beautiful. That is 320 degrees of wrap. Lesser curve is over on the right-hand side of the screen. The anterior is on the top, posterior on the bottom. The fasteners that are the highest are the last ones that you did. And you have 4 centimeters of length.
Nice. Wait a little bit.
So when you asked Dr. Galvo, could we put a couple more in? We could have put a couple more superficial ones closer to the lip of the valve there. But the functional part of the high pressure zone is about 3 centimeters away. So it's a very good looking valve.
Okay, guys, looking good.
Looking good.
I'll take some of the. Better now?
Well done, Dr. Bondari.
Here or here? Here. Here. Here and here. You want here? Oh yeah, we can. Look now, because we are descending a lot. Better? Now I can take a picture. Let's measure the was over insufflating. Okay, guys, thank you very much. You have any
Great job.
Okay, so we are planning to have 7 more cases in April, no?
We look forward to it.
Congratulations, guys, and just let us know how these patients do, and give us as much notice as you can on the cases in April.
Thank you very much. Bye bye.
Yes.
This towers can see. This tower is not good.
Dr. Galvo, can you hear us okay?
Yes, sir. 100%.
Thank you.
I was trying to surprise you to get you with everything ready, but you cut me. Like my wife.
Hey, how is our previous patient doing?
Doing great, sir. Doing great.
Good.
And even alive.
And I'm glad to hear.
Can we put already? This is a check. Okay. 1 to 2. The go, no?
Yes. Agreed. That's a good one.
Yeah. If I behave bad, if I behave nice,
No.
I'll be nice. 1.
Yeah.
Now?
2.
2. See, depending on me. Doesn't depend on you, sir. 1.
That's true.
2.
It depends upon you. Yes.
Okay. Let me just tuck here. And we'll be ready to go.
Hey, Dr. Galvo, can you, as they're putting the device in, maybe have the camera so we can see the patient a little bit better, or as you're putting the device, as you're inserting it this time.
Like this?
Beautiful.
Yeah, that's good.
This, you know what it is?
Right.
He has an islet of gastric mucosa on the esophagus. See? Nothing to worry about. But eventually you can have an ulcer here. Peptic ulcer here. See? This is retained gastric tissue. Have you ever seen this, guys?
I have not.
Okay. Nothing to do.
What's it cause from, Dr. Gabo?
It's kind of displaced gastric tissue in the esophagus. See?
But different, not Barrett's.
Nothing to complain about. Nothing to be worried about.
Is it like a Barrett's esophagus or no?
Yeah, but it's not, because it's not metaplasia. It's the stomach.
Yeah, it's very cold here.
Can I tell you
We have
something?
snow.
Can I tell you something? We don't have this problem here. Mohit's doing great. See? Good. Good. All good. Now, good. Now, for show him now. Wait. Up, up. Now, no, no. Need more. You do that here, that here. Make sure we don't have anything. Looking good, guys. No? Good image?
Looking very good. Yes, great image.
Okay. Okay. Just need to have more. Wait. Good. Okay. Now, show us. Okay. Yeah, let's load. You should not. You should not. Because we lose the slide. Okay, guys. So, try to show. Good. So now we are trying to go to. Oh, good position.
You're at 8 o'clock.
Huh? 8 o'clock. You're killing me.
I know. I demand perfection, Gabo. I know that you can do it.
Show me more.
There you go.
Good.
Yes.
The button. The button. Okay. Now come free. Now try. Nope. Okay. Okay. That's why. That's why you not ever. No. Looking good.
Yes.
Okay. Helix unlock.
Yes.
Now. Now we lock. You pull. Now. I don't think I can get it a little bit. You think I can get more?
I do. Come back towards us and pull the device out of the patient.
Let me pull the helix a little bit more.
So untorque it.
Untorque it. Oh,
Yep.
first you want.
Open the device 2 clicks.
It's not opening.
Actually, take it all the way to the. Yeah, okay, now pull the device. First, screw the helix in some more. Yep. Okay. That's right. This is a better spot anyway. Put the helix in right there, inside the lip.
Here.
Inside the lip. Close the tissue mold 2 clicks and then advance the helix.
Like this?
Yes, better.
Good.
That's better. Okay. So, Gabo, I'd like to encourage you to do a free willy maneuver here. You need to get that helix out of its channel. So can you bring the mold to us? Counter rotate counterclockwise towards 6 o'clock with your tissue mold.
Like this?
Yep. Open 3 clicks.
Okay.
Give a little tug on the helix.
Pull the helix.
Just pull it a little bit. There you go. Okay, now pull the device out of the patient to cover the blue band. Good. Push in scope. Good. And you can also have your scope operator give you a little bit of tap suction, but you have a much, much better bite now. Watch that helix though, you don't want it to rip out. I would close the tissue mold 2 clicks.
Okay, good.
Good, pull the device out of the patient another 1/2 centimeter. Good, a little more traction on the helix. Make sure the helix is locked.
Lock.
Push in scope.
Okay.
Good, rotate 30 degrees with some tap suction by your scope operator. Let's close that tissue mold 1 more click.
Okay.
Good, now wrap some more. 10 degrees.
It's the maximum I can.
Okay, clamp it down.
Clamp it. Now
Okay.
motion.
Were you trying to get to 11, Jeff?
It is
Yeah.
11 there, no?
You're at 11, yeah.
Okay.
I'm fine with that bite.
Oh, fire?
I would not push in, just fire, right where you are.
Fired. Now we reload. Guys, one of the guide wires are not going well.
Okay, what you need to do is grasp it with your fingers, retract it gently, turn it 90 degrees, and re-advance the green sleeve itself.
Now it's going. So what we're gonna do here, I'm gonna open up 2 clicks. So let's load.
Yes. I would open 3 clicks and move the tissue mold to 8 o'clock. Unlock helix, let it relax, and then re-engage.
Open.
Yep. Unlock helix.
Unlock it.
Good. Reposition the tissue mold towards us to about 8 o'clock.
Like this.
Yes. Good. Put the helix block back on.
Okay.
Pull the device out of the patient 1 centimeter or 2. Now 1. Okay, good. Now traction on the helix and make sure the lock is on the helix.
Lock it.
Good. Close the tissue mold 2 clicks.
Okay.
Rotate 30 degrees with scope suction.
Scope suction. We're ready to go now?
Yes, clamp it down. Good. Lock, suck.
Fire.
Not much push. Yeah, fire. Okay, can I watch you reload, please? I'd like to watch this reload. Can you move the camera so I can see the reload? Okay, thank you. I just want to see how it's functioning.
Okay, can we reload?
Yes, yes.
I'm not seeing the click. Okay. Going good. Now looks better.
It does look good.
In the amount of bleeding, the
Sir,
blood
you're
loss
on live, sir.
compared to arms.
Yeah.
Sir,
Here-
mic on, you're on live.
Yeah, yes. So you just see the effect of APC. What Dr. Sunil has done is two things. Show the 2 points where you're left on the greater curvature side.
So we have left this alone.
Yeah.
To so that to prevent stenosis.
Right.
So yeah. So we've not touched this area about 1 centimeter along or 1.5 times the scope diameter along the greater curve, and we have done the ablation about 1 centimeter on either end, and the widest about 2 centimeter along the lesser curve. So this will shrink, and this will cause a good will strengthen the GE flap valve.
Correct. And now show the RDI mode. It looks very nice on RDI mode. You can see the coagulated tissue appearing very clean and clear. So it's 2 centimeter on the lesser curve side, and on the greater curve side where we have left those 2 centimeters untouched. The rest of it is 1 centimeter, of coagulation.
And we have maintained that 1 centimeter distance away from the squamous columnar junction also.
Absolutely. So we have done this job, and this procedure is complete.
Yes. And
so
we'll just go ahead and do some collagen
we'll do
spray.
the collagen spray. Just we'll let them watch the collagen, and then
So-
we move back to the
So you
stiff
can see
video.
a few points this between the arms procedure, sir.
Yeah.
I think it is a little more time saving.
Time saving.
You didn't have to inject. You didn't need a submucosal lift, and you can, as you can see, the blood loss was very minimal. The only thing you need to ensure is the current setting. Your forced argon plasma setting should be accurate for younger people, elderly people, and you should make sure that you do not you do not penetrate deeper. You should not be perpendicular when you do the APC, and you should be tangential, and you need to come from proximal to distal ends.
Absolutely. So you can go more even parallel. So then it will be like a paint. So you're just putting in some air through the channel to dry the working channel. Now we'll go ahead and spray collagen. The collagen will help in hastening of the healing of this process and increase the fibrous tissue formation there. So, and also it avoids the patient from developing any pain or dinophagia in the first 24 hours. We put these patients on sucralfate. ARMA patient, ARMS patient, all of them are put on sucralfate and PPIs at least for a couple of weeks.
Jodi, spray?
Yeah.
Spray, Jodi. Catheter block hai,
Oh, very much powder. This catheter, once it comes into moisture, gets blocked. So we're just we're changing the catheter. We're putting in a new catheter. So this is one of the disadvantages of this procedure. So absolute avoidance of moisture will help. This collagen is called HemoSeal spray. This was my invention in 2011. So it is still yet to be approved for commercial use in India, but over 100 institutions are using it on a R&D research basis. So you can cover large areas just by this spray.
Jodi?
Yeah.
Sure, sir. That's fine. That's enough. So thank you, sir. We're done with our procedure, sir.
Yes. Now we'll move back to a video on the transoral incisionless fundoplication. Still will continue, and then after that will be a demonstration by Dr. Mohit Bandari of endoscopic sleeve gastroplasty, and then his lecture on the tips and tricks of the trade. You can show the,
Retroflex view.
yeah, no need for retroflexion. You can show the from the forward view whether you're able to see the, that collagen sprayed area. See, yeah, good, because we are already seeing the esophageal side also, and the gastric side also from the lax ileus, so at the OG junction. So that finishes our ARMA, anti-reflux mucosal ablation. So now we'll move on to the video. So to EDP team, can you keep playing the video? And I thank all people who have been involved here, all our staff members, nursing and anesthesia staff, and all those people who are involved from the EDP team. Special gratitude to Ebenezer and Rajesh and the entire team of Videoline, Anand, who have been responsible for this live telecast. And I'm grateful to all our industry partners and also all the pharma partners who really supported and made this program possible. So we should again connect probably in the end of February on yet another live workshop. We'll be demonstrating more cases. So join us. To friends who have joined Trans globally, our gratitude. Do not log out. Still important lectures are yet to come in. So please hang on and enjoy today. Thank you. Bye-bye.
Yep. Very good. Very good. You can get 20 degrees of wrap.
Need another one there, but relax the headache. Go to 8 o'clock.
I would open the tissue mold 2 clicks.
Good.
Okay, now close it 2 clicks. I just wanted to take some tension off of it. That's good. Close it 2 clicks.
Yep.
Okay, pull the device out of the patient. Scope suction.
Wrap.
Just a little.
I'd like to thank.
This time you need to do the full much.
Okay, good. Good.
Yes.
Okay. What? Oh, good. Now let's go.
Bring the mold way over towards us.
Okay.
Yes.
That's not 5. See? Exactly.
Max length.
Okay,
Nice job.
No, don't fire one more. If you fire one more, you ruin everything. Because it's the needle that goes without anything.
The fasteners that are the highest are the last ones that you did. And you have 4 centimeters of length.
Nice. Wait, aspirate a little bit.
So when you ask Dr. Galvo,
endoscopy services here at Indore, and I'm also a consultant to Apollo Endosurgery, which produces the devices alongside Pentex and Olympus. Next. So Manuel joined us around 8 months back, and Since then, we have been working together to take the field of bariatric endoscopy to newer heights. Next. We have done total 15,000 bariatric procedures, and as you can see, we have done more than 600 endoscopic sleeves and around 32 swallow balloons. This is probably the first series of swallow balloons and probably the first and the largest series of endoscopic sleeve gastroplasties done across the country and maybe in the Asia Pacific region. Next. We started from sleeve gastrectomy, progressed to gastric bypass, and then to one anastomosis. And then we moved on to the endoscopic sleeve gastroplasty and the swallow balloon. Next. If you see the total number of endoscopic sleeves done at our center are 628. Out of them, 418 were done at our own center and 210 were done outside. The number of revisions for around 62 and number of primary procedures were around 566 in the endoscopic sleeve gastroplasty group. Endoscopic bariatric procedures, as we see, they have recently emerged as very safe and effective, minimally invasive procedure for the treatment of obesity, and they offer effective weight loss at a very lower cost. This intervention has gained a lot of patient acceptance. The best thing is that we can avoid surgery, and we also know that a lot of complications associated with surgery can be avoided by endoscopic bariatric procedures. The basic issue which I wanted to address today in front of this august audience is that it serves as a very good bridge between the medical and the surgical therapy. The therapies can be primary, it can be bridging procedures, or it can be revisional procedures. And all can be done by endoscopy under different group sets. Next. We also understand that these procedures continue to develop and there are a lot of limitations at this point of time. And to improve outcome, device improvements are necessary, technical standardizations are necessary, and we need combination therapies. And the most important thing is the learning curve and the clinical outcome, which is the essential concern, and also the standardization. So we also know that bariatric procedures, as physicians or as clinicians or as surgeons, we all understand that there are different varieties of bariatric procedures, and these variety of bariatric procedures are, to determine that, just like there is no one effective medical treatment for the cure of diabetes or for the remission of diabetes, I would say. Similarly, there is no one effective treatment for basic remission of obesity as per the definition of the books. So we need to come up with different mechanisms because what we are dealing with is a very, very chronic disease. It's a very recalcitrant disease. So we do not have just one treatment whereupon we can say, okay, that's fine. And now we have got this as the most standard treatment to be done on all the patients. Next slide. So if we see endoscopic sleeve gastroplasty, it's done by the Apollo overstitch device. It works on the principle of taking non-absorbable sutures inside the stomach to reduce the size of the stomach. And the endoscopic suturing device comes by Apollo endosurgery. Leads to good amount of weight loss. Procedure is minimally invasive and reduces a lot of risk of operative complications. It's not a very invasive procedure because we are not basically breaching the peritoneum. And it does not involve the cutting or stapling of the stomach. Next. As you can see, this is the Apollo overstitch device, and the suture which is shown as a Prolene suture. And there's a curved needle on which the suture is mounted with the needle. There's a helix which pulls the tissue, and this is just like a grass cut. And then this is the needle holder, like a sort of thing, which is an overstitch device. The device is now FDA approved, and it's for the first time in India that somebody used it in 2012, but they did not use it for obesity. But across the world, it was done by Professor Abudaya as the first device which came for the clinical use. Next. So this is basically a video which shows how this device is there. As you can see, this is the Apollo overstitch device. We have the needle which is being loaded, and once the needle is loaded, the helix can basically come inside and pull the tissue after the loading of the needle, and through that particular tissue we take the suture. So it's a very effective device for the treatment of obesity. And as you can see here, it takes full thickness suturing, and this full thickness suturing is intended to make permanent fibrosis. Next, please. Next slide. So you can see that this is a demonstration by the Apollo. Can you fast forward the video, please? So what I can see here is that this is a hole here, and just to show as an example, this particular needle, once mounted, can take the full thickness sutures through this particular gap and can close the gap very easily. So it's a versatile device, and the beauty of the device is that it's a proline suture, which is a 1,0 proline and a 2,0 proline, pardon me, and it's full thickness, so it stays there, permanently. And this is the helix. And as you can see, once you pull the tissue, bring it inside the device, you can take these sutures. Next. Can I have the next slide, please? So, also the device comes in a single lumen. So you can see the overstitch SX is a single lumen. So usually the surgeons face the difficulty by using a double lumen device. Now there's a single lumen device which is available, and that's the beauty. And it works similarly like a double lumen device. It's a little more costlier, and it's not available in most of the countries, except for US and Europe. Next. Can I have the next slide, please? So as we can see that the endoscopic sleeve gastroplasty involves, complete reduction of the capacity of the stomach by taking full thickness sutures. And this will cause permanent fibrosis at the end of the procedure. Next slide. And it involves the complex movement of hands. It's not an easy procedure to perform. The surgeon has to turn and twist. He has to basically understand the three-dimensional image and modeling of the stomach, and basically create a tube. Next, please. The Apollo overstitch device is this, and as you can see that the proline suture can be loaded, and that full thickness suturing can be done by this particular device. And this particular instrumentation is loaded on a double lumen scope in this particular diagram. But as I previously mentioned, that there can be a single lumen as well. Next, please. So these are multiple suture patterns. Next, can you just fast forward? Next, please. Next, please. And I'm not going to go into the suture patterns, but there's a Panama experience, there's a Gontran Lopez Nova technique, there's Manuel Del Rao who established and published their own technique. I'm not going to go into the details of it, but there are different suture patterns. I wanted to explain that. Next. Next, please. So this is how it works. So helix is pulling the tissue into the device. You can fast forward the video. And once the full thickness suture is taken, you can move into different parts and basically completely reduce this particular lumen. And after you drop the needle, it can be cinched by using a tag where one part is held by the needle and other part held by the tag. Next slide. So this is what happens. It basically reduces the capacity of the stomach, and as you can see with this particular barium picture, that it not only delays the gastric emptying, but something like a sleeve gastrectomy. Although the two procedures are very different, but this is similar like a sleeve gastrectomy. But I always mention to physicians and everywhere that it is not equivalent to sleeve gastrectomy. It's totally different. The physiology is to delay the gastric emptying, and that's totally different from sleeve. In sleeve, there is rapid emptying of the food across the duodenum. Here, there is basically a delayed gastric emptying. Next, please. So, you can see that even after 240 minutes, this particular thing, which a radionuclide is retained. So you can see that the percentage of retained gastric content increases with over a period of time. Next, please. The physiology of ESG is delaying the gastric emptying by scintigraphy. And that's what we see in most of these cases. Next. This is a very beautiful video. Can you play the video, please? So I have done this case in Bangalore, and Manuel took this video. So while I was doing an endoscopy, we are also doing a laparoscopy. So you see how it looks. So you see, this is an endoscopic sleeve which we did, and you see these are the sutures. So how the stomach is reduced in the capacity is very beautifully seen in laparoscopy. And this patient was a cirrhotic And you see the NASH was there, and this is a beautiful picture showing both laparoscopy and endoscopy simultaneously. Next, please. Next, please. So we know that physiology is to delay the gastric emptying, and that's what is the mechanism. That's what we are banking upon. Next. Next, please. So this is now a video of how it is performed. As we have already explained, that it's a full thickness endoscopic suturing, and these multiple suture patterns. This is a helix device pulling the tissue. The overstitch is basically taking the sutures, and it's pretty full thickness. So you can see the lumen is reduced here. Next, please. Next, please. So this is the data. 566 cases at Mohawk, mean BMI 34.4. Next. Next, please. The percentage total weight loss is around 20%, 100% resolution of OSA, hypertension 91, and type 2 DM 76%. Next. We standardized this and published it into the journal. The technique, and Manuel was the one who standardized it, and we published in Obesity Surgery along with 40 different procedures. Aparna was also a part of that particular group, and she was one of the experts on one of the commentators on the banded sleeve groups. And we published this with Manuel, and there were around 50 experts from across the world who were involved. Next, please. Next slide, please. So these are different multiple publications, and keep on moving so these are multiple publications. Next. And just showing that this particular thing, the merit trial, is just completed, and it's the best abstract which is accepted in the IFSO. And after the merit trial, they say that this is going to get a full US FDA FUS, that is functionality use approval in United States of America. Next, please. So I think I'll basically mention that there are a lot of studies which show that 7 to 9 cases is the learning curve. But what we realize that the learning curve is at least 50 cases for most of the surgeons. And next slide, please. And multiple studies, but this paper is very important. Keep this slide. Can you go back? This paper is important. We published our MBRSC data, our own center, into the Digestive Endoscopy Journal. It was the first of the series of its kind. And this was the first effective treatment, and published from Mohawk in Indore. And now we have crossed 600 cases, so it's an honor. And I thank Manuel Galvao for this particular thing, because he first trained me, became my mentor, and then joined my center as a director of bariatric endoscopy services. Next, please. So I think most of these studies would show that the total weight loss is more than 10% in most of these cases. It ranges from 15 to 18% of total weight loss. Next, please. So in summary, I would say that endoscopic sleeve gastroplasty requires a multidisciplinary team. It's a very new endoscopic technique, so it has a learning curve, and there is the approach of endoscopy is necessary because we also deal with these patients for revisions who had weight recidivism. We treat them for weight loss failures like tightening of the sleeves and bypasses. I'm not going to go into the details because this is probably meant more as a nutrition course, but I wanted to give an overview of endoscopic sleeve gastroplasty. These are training courses at Mumbai. Can you move on the slides? Ahmedabad. I've trained more than 400 gastroenterologists with Manuel, and we organize these courses every month. And now we are doing a very dedicated hands-on course. So these are some of the glimpses of our courses, and these are the modules. So thank you very much, Aparna, and all of you for gathering. And I hope I did not took the time, and I stick to the time. All of us know a lot about intragastric balloon, but I thought I should talk more about endoscopic sleeve, which is going to be the next big thing in India. Last but not the least, about the swallow balloon. I think that's also something which is going to come to India in a very, very big way, and does not require an endoscopy, no anesthesia, and no admission in the hospital. Patient can be sent home within 2 hours. So thank you very much, everybody, and I look forward to interact with you sometime very soon.
keeps on changing. ठीक है. Okay, yeah, this is good. So, I am seeing the lesser curvature now in front of my eyes. All I do not want is to enter inside that lesser curvature and cause a stricture. So you can see that I'm pulling it right back there. And now I can, okay. Now I'm not gonna go more down there because this is the lesser curvature. I don't want to block the lumen, so I'll go a little straight here. So this is my point exactly, but not beyond this point because I don't want to completely block the lumen. I want a lumen there. That's it. Now I'm gonna go medially, but before that I take one more here. So you can see that gap there. I actually would want to enter inside that gap so that I can take. Now that's fine. Now I can go easily a little medial. So now I can go a little medial. So what I'm going to do is come here, go a little medial, and this is the area. Okay, fine. Okay, now I'm going to go more here. So you can see that gap there. So I'm going to pick up on that gap so that we make a nice tube out of this. All right. Okay. So you can see that the lumen is there, which I'm trying to reduce it to size. I'm going to go medial now. Here, something like that. Yeah, this is the area. Okay. One more and I think we should be done. Okay, so we're going to go a little above here. Okay, that's fine. Okay, so that was my first layer. I'm going to drop the needle here and I'm going to just remove entire air and just going to lock it. Right. Very good. Okay, so that's the first layer. I'm going to orient myself. So you can see a nice tube building up. That's the first layer. That's the pylorus you can see beyond that. And now I can start to take sutures. So you can see this is the anterior wall. This is the greater curvature. This is also the greater curvature or part of it. This is the posterior wall. And we'll keep on going all around this. Now I'm going to go and come with my second layer. So here we are. Now I'm using a Pentax scope here, so we just have to be a little more, smart while we make this loop. That's one of the problems here we face with this scope. Now I'm here, I can see So this was my previous, I am starting from here. Okay, okay, just a little back, Yeah, that's fine. This is okay. This is fine. Sure. Okay, so that's the second layer. I'm again gonna completely remove the gas and use the cinch to just lock this suture in place. That's my second layer. I'm gonna pull the scope back and see how many more layers I'm gonna require, right? So you can see that that's the kind of tube I'm gonna build up. It's looking beautiful. I'm gonna probably require 2 more sutures, so that's fine. Okay, so we are coming up with another layer, and you see a nice tube on the way here. So that's the loop. Here is the helix. Okay, let's start. Okay. Mm-hmm. 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 So if you have something like this, you're gonna unwind it like I did now, and then you're gonna start it again. Okay, so maybe here, yeah, it looks okay. Yes, fine line there. Okay. Mm-hmm. 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 Okay. Mm-hmm. 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 Okay. So, removal of air, last but one, cinch. हाँ अच्छा खासा. Beautiful. Okay, so this is a nice tube. I'm gonna pull and see if I need more suture. I think, let me put some more air inside to understand if I need one more. I think I'll take one more. What do you say? One more. Okay. That's the Z line, so we're gonna have one more. Okay, fine. So that's the area. I'm gonna target put a हाँ बस वन में हो जाएगा. Okay, so that's the area. Yeah, started from here. Wow. Hmm. 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 Rob? Right. So that's the last. So I'm using a Pentax scope here, and this is a double lumen scope by Pentax. And we have a high definition Pentax system on which we are working. And this is exciting because okay, yeah, that's fine. Good, nice. So yeah. So we will once again see what we made. So I'll just put some water to remove this clot. Okay, we can take out this scope, clean it once and put it again, just for the purpose of demonstration, the tube which we made. Looks like a, we'll remove the double lumen, overstitch. Or we can use the double lumen, but we'll remove the overstitch assembly if that's possible. Take a single lumen. Let me put this assembly. Clean? Okay. So okay. Okay, so I'll put the same thing inside. That's the over tube. Once we are in the esophagus, all of us know that we need to put some air to blow the balloon. I'm in the esophagus. That's the Z line. You can see nice Z line there. Now I'm entering inside. So this is the small fundus which remains. So the usual method to demonstrate this is to go inside with a single lumen scope, but I'm demonstrating it with a double lumen. So that's from where I started my suturing. The pylorus will be there way ahead. Can you see the pylorus, everybody? I think you are able to. And now I am coming back. So let me clean my scope. So you can see this is the tube which I made. A small tube, pulling it back, back, back. And that's the area of the fundus where I have some fluid. So I'm going to suck that entire fluid. And then I'm going to blow it again to show you the anatomy. So that's the entire tube which I made. And here is a Z line which you can see. Thank you very much.